sect.
So it is extremely important. The actor will always give you the name, but finally the kingmaker is the director. He directs what that, and then the actor has to perform.
Definitely, sir.
So that's what happens with the left hand.
Yes, sir. So the key is left hand. Your left hand should be very strong in learning laparoscopy.
So basically, if you have special energy sources, usually you may not be able to keep up the plane, and they will cause cicatrization of tissues, and you may start going in a deeper plane. So now we are going anteriorly. So now this is a plane where I can go further down. Now I would try and change the direction of the rectum being pulled up. So you can understand that many people would not try and hold the rectum itself. But being a thin patient, I do not have linea to try and hold it. Okay. Okay. Asana.
So, sir, we are going live on YouTube also.
Oh. So you can appreciate that this is the bulb of the Foley's. The possible urinary bladder is coming up to this level. This should be the area of prostate and would be seminal vesicles below. So I am going to go in this plane where.
Ankur bhai, nice to see you in a suit.
Morning, sir. Thank you, sir.
कैसे हो?
Fine, sir. How are you, sir?
कुछ प्रॉब्लम है तो आप बता सकते हैं हमको स्टेप्स पूरा भी.
No, sir.
Samir, your also moderator is Dr. Ankur Patel, who used to be a consultant in our department, but he decided that Mumbai he didn't make enough money. Ahmedabad had much richer prospects. That's why he moved to Ahmedabad from Mumbai.
Good morning, Dr. Ankur.
Thank you, sir.
Sir, Anand here. Any recommendation for cautery setting, particularly when I'm seeing you are using only.
So when you are it usually is kept about 30 to 35, but more important when I'm using monopolar diathermy, it's extremely important. I would not give a continuous current. So it's just small pulses of the current. So and at the appropriate site, so you have adequate.
You also see that there is no charring of tissues. It is just coagulating without any blackening on the side. That's a sign of a good cautery. Samir, how far down will you go anteriorly?
Anteriorly, I should go below the level of seminal vesicles in midline.
So another important point for the PGs watching this is that the denonvillous fascia anteriorly has two layers. So one layer you must preserve on the seminal vesicle, one layer must come on the rectum. Don't bare the seminal vesicles because that can cause infertility. This is, of course, a very elderly man, so it doesn't matter too much, but get used to going into that plane.
Do you ever require harmonic for these dissections, Dr. Samir? Or you prefer only cautery?
Usually what happens, I personally feel the monopolar hook is a very versatile instrument, because you can go and precisely use the monopolar diathermy at the desired area. So the issue is when you use any kind of specialized energy source, either harmonic or maybe a ligature, the jaws will try and cicatrize tissues while coagulating. And that is where at times you may miss the plane.
So the message here is that you don't need any fancy instruments or harmonic for doing this surgery. You can do it with the basic laparoscopic instruments in a smaller setup too.
Bipolar.
Not necessary that you require a harmonic or a thunderbeat or any other source of high valuable energy source.
So most important, you require to have a
good bipolar.
A good bipolar section. एवढा thin आहे ना तो.
Sir, Dr. Vijayaraj here. In the camera system, you use 30° or 0°, which is your preference?
Yeah, basically we are working in the deep in the pelvis, so it's every time preferable that we use the angle scope. So preferable for such advanced procedure, you require a 30 degrees.
Sometimes some says that 0° is far better in pelvis.
Very
Because of
frankly,
this
when the
colorectal.
initial of my cases, when we used to do with the surveillance camera, namely a Vatek monopolar. So in those we used to use a halogen bulb, and halogen the 0° transmits lights all around the optics or the camera, the lens, whereas the 30 degrees will give the illumination only from maybe the 10 o'clock to 2 o'clock.
Yeah.
So that's where in case of halogen light source, it was to be a different issue. However, now with improvised light, either with either xenon, that is one, and or maybe a LED, this problem does not exist.
So what is the
Purvai,
preferable
we
in
are also
advanced
giving
surgery?
you live feed from a gallbladder in the next OT, which Dr. Prasad Bhukebai is doing. So consistently through the day, we will be showing you 2 surgeries live. Later on, we'll have anorectal on one side and advanced lap on the other side. So feel free to ask the team by Dinesh Pal, who's doing our audiovisual transmission, to switch from OT to OT with the audio. Do you have a
Perfect,
good video signal from both OTs?
Yes, sir. We
Yeah,
have both
perfect.
the videos.
Just let the audio be with Dr. Rege.
Yes, yes. You can tell from that side
Yeah,
where you
yeah.
want audio, but
Yeah.
video will be in both sides.
Perfect.
So which which light source will be xenon, LED, or halogen in advanced laparoscopy?
Question is, if you are affording well, xenon is better. I personally feel xenon gives a better light illumination as compared to LED. The only problem of the xenon is, one is costly, and secondly, the maintenance becomes higher. Secondly, when you are using, it gives a lot of heat. So your assistant should understand that if the tip of the telescope remains in contact with any of the tissues or any of the clothing, it may burn that area. So the xenon otherwise is much better than anything else.
So while you dissecting, we go to the another OT. So just progress of the left one.
Sir, I didn't get you, sir.
No, continue. We'll continue the discussion with you while we are seeing the gallbladder on the other side.
So there is
Yeah. You can appreciate a good amount. Patient has been kept with good hypotensive anesthesia. The team led by Dr. Kale sir, Dr. Priyanka and Dr. Shweta. So thanks to them, though I'm still making my life uncomfortable for myself.
No, we would like to see that uncomfortable part also, sir. That is part and parcel of any surgeon.
And Samir can have these moments that they should know on how to control. No?
Yes, sir.
Bipolar.
So you usually prefer suction resection, sir?
Here it's a question of planes. So it's always preferable that suction should be used because you would like to have a good amount of hemostasis at each and every junction.
So can we shift to the other OT where we have just started the lab cholecystectomy?
We'll come back to you in a very short while, sir.
Yes, no problem, no problem.
Gallbladder OT.
Yeah, good morning, everyone. Can you hear me?
Yeah, Prashad, sir, we can hear you.
Thank you, Roy sir, for giving me an opportunity to present the case here, and welcome everyone. This is a case of cholelithiasis where we are trying to do a laparoscopic cholecystectomy. She also has a hernia, probably a defect size around 1 to 1.5 centimeter. So our plan is to do a Ventralex patch repair along with this lap chole. So we have also injected ICG in this patient. We want to demonstrate the advantage of using indocyanine green in identifying the biliary tract. So I'll just keep operating. If you have any questions, you can keep asking me. If I know the answers, I'll answer you.
Hello, Prakash. Dr. Vijayaraj here. Nice to see you.
Good morning, sir. Good morning, sir.
Good morning. Doing wonderful dissection. So in the context of the PG students, how to start the lap cholecystectomy dissection, posterior, anterior, and what are the structures you have to take care of?
Yeah, so the first thing is port placement has to be proper. I'm sorry, I haven't introduced my team here. On the camera, we have Dr. Priya Gupta. I think she is a student of yours, sir, from GMC Ahmedabad. And we have Dr. Rasika on the head end, giving us amazing anesthesia here. So let me start with lap chole. The port placement has to be extremely correct. This patient had an umbilical hernia. So what we have done is we have gone through the defect so that we can close the defect later. And once the port placement is proper, you can actually start a good dissection. So I start my dissection on the Kellogg's triangle first. So I just incise the peritoneum and then try to find a plane between the peritoneum and the gallbladder. And then just keep going, hugging the gallbladder. So I have completely dissected my posterior wall here. I mean the posterior dissection here. I can see the cystic duct, the arteries here. Everything is well defined. We can actually, after I dissect some more, we can actually come to the ICG mode. And we can show the importance of ICG in this case. Now, in gallbladder, the change in traction every time is very, very important. Because as you know, in surgery, traction and counter traction are the key to a good surgery. So traction at proper places makes your surgery very easy. And
Wonderful dissection. Wonderful.
And with the hook, we just try to do small, we use small dissection. I mean, we just cut small amounts with the cautery. Just can I have the Maryland?
So Dr. Prasad, any role of bipolar? Are you using bipolar while dissecting the thing which you are doing with dissection, which you are doing with hook?
I usually don't use bipolar.
Okay.
But we do have a bipolar ready with us just in case, because you should always have a bipolar. Considering if there is some bleeding towards the liver, I think it's better to bipolar it rather than use unipolar to cauterize it.
So as the bipolar devices have improved, so using a hook for young PG students who are here, so it is very difficult for them to use a hook. So using a bipolar, I feel they are all shaped of a Maryland, and it is very good. Now I've shifted using bipolar in each and every gallbladder. I'm stopped using hook in all my patients.
That again depends on how the student has been trained. So if you are okay with using a bipolar, that's totally fine. So at the end, it's about surgery, and you have to perform a good surgery, and the patient should have good results. So what you use as a tool is just not that important.
So we'll be shifting to OT.
I please go ahead.
Yeah.
So whenever there's something important, I'll let you know.
Yes. So can we shift
Thank you so much.
to Dr. Samir Regesar's OT?
Hello.
Sir, can you hear us?
Yeah. So possible there's some amount of bleed, but I have identified my seminal vesicles, kept a layer of Denon-Wheeler's fascia there. Would you appreciate this?
Yes, sir.
Under camera. Can you see this?
Yes, sir. We can see the seminal vesicles.
Yeah. So important thing, we should not go very close to it. You try and preserve. The fascia is removed only in case of malignancies. So try, and this is benign condition. So we do not want problems. So now the dissection has to go as low as to the level of levator ani, so that I can have a good amount of. So you just said some words about bipolar, and I just took the hint that I should take the bipolar in my hand. It's a very good instrument. However, when you compare a bipolar with a monopolar, monopolar can be used for a small amount of tissue. However, bipolar you require to have a good amount of tissue intervening, then only it functions very well.
Sir, but with commencement of newer devices, now they have come up with cutting bipolar also. So if you use small tissues also, it will cut. So they are improving bipolar devices. And it is
Samir,
safer
can I ask
for.
you to do some suction in the pelvis so we get some clearer view? Samir?
Yes, yes. Let's fix it.
अंकुर भाई बहुत दिन में खतरा नहीं भेजा यार.
Sir will definitely send, sir.
तुम्हारा कौन सा AZB क्या नाम है उसके LKP?
Yes, sir. Induben Khakra wala.
हाँ. I hope after the Garba there is somebody in the audience apart from four of you.
No, sir. The hall is, I mean, it is almost about to fill, sir.
Very nice. And
Yes, sir.
my only apology is that I could not attend in person. But next Good ASICON, I'm definitely going to be there. Apurva bhai, I'm waiting to be called next year.
Sure.
On the left side laterally, up to what level you saw?
I would like to visualize the Levatron eye, so that at least I would like to go below. See, the patient has at least about 2 to 3 centimeters of prolapse. So you should at least dissect at the up to the level of Levatron eye, so that it will be possible for us to try and pull the rectum up, so as to have a good fixation.
Sir Anand here. I have one question. To assess the full mobilization of the rectum, would it be better to first mobilize posteriorly and then assess how much anteriorly we need to
Perfect.
mobilize?
So that this question raises a lot of controversies and opens a huge area for discussion. Huge. If you ask me, personal opinion, rectal prolapse surgery has evolved. So it evolves with posterior dissection or complete dissection, then only only posterior dissection without anterior dissection, and then going to now only ventral dissection. Now, firstly, it started with telescoping, understanding the anatomy. The people thought that it takes the curvature of the sacrum, and that's where you require to only have a good amount of posterior. So there's no need to dissect the anterior. Then came then people started having problems because of either bleeding and then later on injury to nerves, and that's where it started with only ventral. So question is, what surgery when you plan? Maybe an elderly person, I would still try and go with posterior mesh rectoplasty at times. Young person, it's always preferable you try and do whatever minimum to have any kind of damage to the nervii regentris or to the erectile nerves, so that the patient should not have problems. So these surgeries have evolved. Secondly, these surgeries are still dominated with what symptoms they present. So if patient has a redundancy of colon with presenting lot much of constipation, I would still go ahead with resectional rectopexy, then maybe a suture or mesh rectopexy or fixation rectopexy. So these surgeries, now what are evidences? I think you have evidence for each and everything here. So there are people who will try and do posterior, will always find some or other reference that only posterior is superior. Some people are very familiar. So a European group is more familiar with ventral and they get promoted. Now you require to take this procedure as per your competency and what your patient would suit it. So would you understand that I have gone below the level of seminal vesicles?
Yes.
Yes, we can appreciate.
Anand bhai, there are a total of 104 operations described for rectal prolapse. And if you see the original paper by John Golliger in 1946 in British Journal of Surgery, he was only doing circumferential mobilization of the rectum with no fixation. And still his recurrence rates were only 8%. So I think it is the mobilization and the fibrosis that you get that is important.
Sir, would be the adolescent age of the patient who present with a full rectal prolapse. would you recommend anterior dissection in that group or just posterior mobilization?
Anand, in my practice, 90% of laparoscopic rectopexies are ventral. I really don't find advantage of doing posterior rectopexy. If you see the data, as Samir mentioned, 20% of patients after a posterior mobilization of the ampulla develop constipation, de novo constipation. A ventral rectopexy actually is easier. Your nervi agentes are better preserved. So in our hospital, we will do perennial procedures for all high-risk patients who can't be given GA. Anybody who's given GA, 90% get ventral rectopexy. If they are young patients with intractable constipation, they get a resection rectopexy, where we resect the sigmoid colon and then do a posterior pexy of the rectum, what is called a Frickman-Goldberg's operation.
Leave it, Anand. Can you see this? Possible these are middle rectal vessels, so lateral ligaments. Some tissues done anteriorly. I have already gone up to the levator ani.
Dr.
So-
Rege, would you hold the thought for a second? I think you can just go on the other side.
Okay,
ICG
no
is
problem.
being injected. We are seeing the ICG. If you, if there is any comments, operators comment, why did we do it?
Dr. Prasad, we are with you.
We have done is we have dissected both cystic artery and cystic duct, and we have created a triangle of safety. I mean the critical view of safety. And we have cut the cystic artery so that we can demonstrate the cystic duct and CBD on ICG mode. Can you see that here?
Very well seen.
Yeah, so what I'm doing is I'm holding the,
Just pull the duodenum down so the PGs can see the bile duct better. Just push the duodenum
Yes.
down so the CBD will be seen better.
yes, sir.
Yeah. Can you see the CBD
So-
now? You see a beautiful junction.
Yes, sir, we can see,
Yes,
sir.
yes.
So what I'm trying to show is when I increase the traction on the infundibulum here, see the tenting of the CBD. That's the area where you should not go here close flush to the CBD, and you should try to stay here. So whenever I'm clipping, I'm just relaxing my traction here so that the cystic, can you see that?
Yes, yes.
Can you see this tenting here?
Yes,
this
we
is
can
a-
see.
So
can
I'm gonna
appreciate.
clip here. I'm gonna clip here. I'm gonna relax my left hand traction. And I'm gonna clip here. Here I'm safe. Are you guys okay with that?
It
Right,
can be
yes,
still
sir.
a bit lower down also. We can.
Yes, I know, but I'm more conservative than aggressive.
Yeah.
But if you say so, I can clip one more since we have ICG here.
Any preferences in the clips, Liga clips, Hemo clips, where you use the Hemo clip or always use the titanium clips?
In the gallbladder, we don't actually use Hemolog clips. We just use these normal clips, LT 300 or LT 400, depending on the size of the cystic duct. So I have no experience with other clips actually, especially in the gallbladder.
So do you prefer to use any energy source for cystic artery?
I don't. I respect the artery as much as the duct. So what I do is I clip two approximately one distally, especially in such a case. And then I cut beyond the two clips so that we are safe. Using a monopolar or a bipolar might cause some transmission of current towards the clips.
What about
And
harmonic?
bipolar is safe. Bipolar is safe anyway. But I
Would you
don't
like to
clip- I don't
prefer
wanna
go for harmonic or ligature or visual
just want the
sealer
clip I have to get.
system?
Also, no clip don't have. Yeah. I'll just clip one more and then we'll go back to Xenon. I'm clipping one more because I feel the second clip might be a bit loose. This is a fairly strong one. Scissor. Xenon back again.
Dr. Prasad, Dr.
Yeah, good
Anand
morning,
here.
sir. Yes, sir.
We can appreciate very nicely done dissection. Usually we put two clips at the remnant cystic duct. Any particular reason, 3 clips and conference or something? You don't want to take risk?
I didn't get your question, sir. Can you repeat it?
Why did you apply 3 clips instead of 2 clips?
Yeah, I felt the second clip was a bit loose. That's the only reason. Otherwise, I usually apply 2 clips only.
And second thing is, can you highlight us like which dye you use and what is the protocol like? If you want to correct
It's
the disease?
ICG. We have actually injected it around 1 hour before this surgery started. So I know by this time it just comes into the biliary tract, and we can be, we are in a position to see it properly. So when you're dissecting the bed, the importance is that you always stay close to the gallbladder and take small cuts and change your traction as frequently as possible.
Yeah, thank
Go
you,
back, go
Prasad sir. Can we shift to Dr. Samir Reges OT?
Yeah, please go ahead.
चल, दाखवून टाकू आपण. Hello.
Hello.
We are with you, sir.
So I see the dissection has gone way down. You can appreciate that both side seminal vesicles have been retracted anteriorly. Can you see these seminal vesicles?
Yes, sir, we can see.
So I'll just adjust mine. So we have gone and identified up to the lower border onto at a 12 o'clock position. So anteriorly, however, on the lateral side, we have gone up to the level of levatrani. These are levatrani. Can you appreciate this?
Sir, because of the redness, we are not able to see. So either
Answer,
focusing.
camera again.
Muscle fibers are not seen.
See, these are levatrani. You can see the vertical fiber. You want me to open this because they have nerves, and you disturb them, they will cause problems.
So lower down is the
Can-
middle rectal.
Pardon me?
Lower down is the middle rectal arteries, left side.
Middle rectal, I will show you. Just come behind. See, these are middle rectal.
Okay.
So ideally, you are not supposed to take out the lateral ligaments because they carry lot parasympathetic supply, and you can take one side, but it's preferable if you don't take either side is preferable. So more or less, my dissection at the lower part is done. Now
Sir,
some
Sir,
part.
can you just give a little wash actually because of
Wash?
the blood?
Okay, I'll put a gauze piece and show you.
Yeah, either Gorspis can also do.
Because wash will stain further, so I'll just use a gauze piece. No problem.
Thank you.
Take gauze piece there now. Takun you.
Any questions from the audience in the conference room? Dr. Ankur, you can take some questions from the audience.
Definitely, sir. So any questions?
Any questions from the audience, please? બાજુમાં સાહેબ તમારી બાજુમાં છે.
Kindly introduce yourself and then we can take the questions.
Hello, sir.
Hey, Baba.
In Coli, if you are in artery not applied to clip, what will be happen? Only bipolar. Now, in hysterectomy, when uterine artery is big, also they are doing only coagulation, not applying any clip, also not occur bleeding. And this is small
no,
artery, then the uterine. Why you applying
which-
3-4 clips?
Which artery you are speaking
No,
about?
sir, this question is for Dr. Prasad.
Okay. Okay.
Okay.
Yeah, can we shift?
Am I audible now? Go back.
लाइट बंद करो.
Hello, Dr. Prasad.
Yeah. Am I audible?
Yeah, you are audible. So there was a question
yeah.
from the
So
floor.
I got the question.
Yeah.
So it's just a matter of preference. I mean, you can cauterize it, you can monopolar it, you can bipolar it, however you want. But I mean, we feel safe when we clip it, just to be on safe side. That's the only reason. Otherwise, you can do, you can use whatever energy you want to coagulate it.
chances of coagulation later on bleeding.
Chance of coagulation, is it? Are you asking me?
If you only coagulate bipolar, then
Ah,
what are the chances of the bleeding post-op? Percentage of
I mean,
chances.
if the cystic artery is too small, it won't bleed as such. If the patient is hypertensive and the BP rises and you have some risk of bleeding. So why take that risk when you can actually clip a cystic duct just within 1 minute?
I think basically what he's saying is what is safe in your hands is your good technique. Even within our
Yeah.
department, I only routinely do a bipolar for all arteries. In 20 years, I have never seen late bleeds in all patients, now more than 10,000 gallbladders.
The
Basically, do what
question-
you do safely. That is all.
The question is why not clip artery? I will ask one question. Why not clip artery? What is the reason? Why not to clip it? Why to take the risk? When there is a 100% guarantee that you can clip and then you can coagulate and clot, you will have better sleep at night.
There is like
Yeah,
this.
yeah,
If-
that-
if your artery is
that's-
only 2 millimeters in size, then a clip doesn't fit well. For a LT 300 clip, you need at least a 3 to 4 millimeter size vessel. So in a very small vessel, I think it may not be a good idea.
Even
Sir, I
clips
have-
are not 100%. Clips also, they can just come out. So it is the way you are comfortable with.
I have two comments for regarding whether to clip or coagulate. I have seen two patients with hepatic artery aneurysm after cholecystectomy. And when I investigated retrospectively, both patients had use of electrocautery. But the thing is, both cholecystectomy were difficult. So I don't know whether exactly the aneurysm arise from stump of the cystic artery or it was a right hepatic artery. But I believe that there was a thermal spread that led to a hepatic artery aneurysm. So properly, if you have a length and probably the clip is safer in that aspect.
But if you're using a bipolar, the spread of the energy is very less. And we have seen Dr. Rosil Gandhi, who is an intervention radiologist, he has done 10 cases of aneurysm, and he told, the thing what he told us that there was clip which was placed both on artery and vein. So because of that, aneurysm develops.
Suction.
Yeah, can we shift to the Samir Regesar's OT?
Hello.
Yes, sir.
I just want to add a comment to somebody said about bipolar and clipping. There good amount of studies are there which studies the strength of the clip versus coagulation by a bipolar. So they have shown adequate or nearly similar kind of coagulation can be achieved by a bipolar, a good bipolar. So it is not that bipolar or clipping is maybe problem. Yes, pseudoaneurysms are known. Even I have documented it from the cystic artery, which bled into the common bile duct. Now, issues of pseudoaneurysm are only because you have done a partial coagulant, so that that's where they can have a partial rupture of the arterial wall, and hence it will come. So it's not a problem of bipolar versus the clip. Now, issue is if for bipolar, the only one problem is at times our bipolar may require a good amount of tissue to be held in between, and the jaws of bipolar little longer. That's where you may try and hold something else at the posterior aspect if you are doing for artery. If you are very sure, yes, it is the option which can be offered for coagulation at any point. So most probably I have completed my dissection. I have gone way down. Yeah. So understanding that firstly you require to dissect as low as possible, going below the level of seminal vesicles onto the anterior aspect, identifying the levator on either side. You can appreciate. Are you getting a better picture now? Hello.
Yes, sir.
Yeah. So these are levator eyes.
Yeah, we can see now.
Yeah. These are middle rectals. Now, luckily for me, this patient is thin. That's where otherwise it's not very easy. Now, these vessels cannot be easily managed with a monopolar. So at times you require a bipolar. So that's where while doing any kind of laparoscopic surgery, it's always preferable that you can have a bipolar kept handy.
All the posterior nerves are kept intact. That's the main advantage of this surgery.
Hello, Samir sir.
Yeah.
Dr. Nishit here, sir.
Good morning.
Good morning, sir. What are the chances of rectal perforation anteriorly in the novice, in the hand of novice surgeon
What are chances of rectal perforation?
in this surgery?
See, issue is if you're visualizing, this is my rectum, and I'm going in intervening tissues. Now I have tried. This is the part of seminal vesicles of the right side. So I am in the intervening tissue. So you can appreciate that I am nowhere near even the rectum, and nowhere near the seminal vesicle. So I have to preserve the fascia over the seminal vesicles. That's where I'm not using a lot of diathermy in this area. So diathermy will be used only and only when you can see the part of rectum comes up. So when as low as you're going to go, the rectum is going to come as anterior or as near to the seminal vesicles or the prostate. So it's extremely important you try and be identifying the plane, confirm that you are in a proper plane, and then only proceed ahead. Chances of rectal, if you are using diathermy unjudiciously, then there would be always chance of having a ischemic problem at a later date. Regular, if are doing a careful dissection, chances would be much minuscule. The second chance of having a rectal injury is with the assistant who actually helps you in retracting. At times they feel that the surgeon is not progressing ahead and they try and give more traction, and that can cause either serosal injuries or at times can cause trauma to the. Can you appreciate this now?
Yes, sir.
Yes.
So that's where that completes our dissection. Now I have tried to do a little more on the tunnel on the lateral side so that my mesh should get accommodated here, because that mesh should lie extraperitoneal because it's going to be a polypropylene mesh. It's not mandated what kind of mesh you require. You can use a maybe a. I would always try and prefer a heavyweight over a lightweight mesh because that gives a better fixation or maybe a better scar.
What is the policy on suture rectovexic versus mesh rectovexic?
But sir, somehow if rectal perforation happens, then what is the plan of surgery?
See, very frankly, if you have perforated it and you identify on table, it's first mandatory that you should try and suture it. All these patients are usually given bowel preparation, and hence possibly you can get away with only suturing without a stoma. Now, if I have caused a perforation, I would not proceed with any kind of mesh. Then I may just use a suture mesh, suture rectopexy in such kind of patients.
Yeah, that is the very good plan, sir. Thank you. Thank you, sir.
So can we shift to Dr. Prashad Zoti? Just few questions.
Yeah, 15 by 15. Moti lagna.
Hello.
Gloves.
Hello,
Samir,
Dr. Prashad.
do you need to do some dissection near the sacral promontory, Samir?
Sir, I have already done. I have
Laterally, I think preserving the lateral stalks is important, but I would do a little more dissection laterally, Samir. See on the right side if you think you need to do some more. Do you have space near the promontory to put your mesh? No. There. Yes, there. You could probably create some more space. Yeah, that's right. So I think the audience must see that Samir has not dissected the rectal ampulla at all, because that is the cause of constipation. He has just made this presacral plane, leaving the presacral fascia intact. This is excellent. And then the mesh will lie in the gutter, in the paracolic gutter, and go to the promontory where it will be sutured. There you just need to take that peritoneum down a bit further so the mesh will lie easily, and it'll be easy to extraperitonealize the mesh afterwards. Yet you preserve the lateral ligaments as Samir has done. While you're watching, Samir, can we shift to Dr. Prasad's OT, please? Audio.
Hello, Dr. Prasad.
Yeah, hi.
If you are planning to put a mesh in umbilical region, so why
Yeah.
not you remove your specimen from the epigastric region? If at all you are using endobag, but somehow chances of at you are planning to put a mesh there. So I think remove the
The-
specimen from the epigastric port is better than remove from the umbilicus when you are planning to put a mesh.
Yeah, I understand your point, but I mean, the defect was fairly large here. And we had put this endo bag, we had suctioned out all the bile which was there in the gallbladder. And we felt this was a okay place to take the gallbladder out. I think you can do that thing too, taking out the gallbladder through the epigastric port, which we usually do. But since this patient had a hernia, we are coming out with this port.
Can the moderators ask the audience if anybody has experience with a Ventralex patch rather than IPOM? What would it do in this patient? I'd like to ask the moderators as well as the audience.
Okay, sir. Anyone in the audience, they have a experience of the ventral patch with the lap cholecystectomy? So, sir, the another question is there. If during the cholecystectomy, anyhow adherent gallbladder perforation is there and some bile spillage is there, it is infective or non-infective, whether you go for mass plasty or you just repair the hernia. What is your take when the gallbladder perforation is there? Inadherent gallbladder perforation during surgery. Dr. Prasad?
Yeah. So gallbladder spillage was the question, right?
Yeah. If
So
inadherent
if
gallbladder perforation there and gallbladder bile leak is there, you
So we
do the
won't
wash
cut
and
the mesh
everything,
anytime.
then you proceed for mass plasty still, or
No,
you
no,
just
no.
do the
We would
hernia
not
repair.
we would not place a mesh in that situation.
Okay.
We are just gonna suture the defect and come out and maybe plan the hernia repair at a later time,
Okay.
rather than taking risk of placing a mesh and having the risk of infection here.
In audience, anyone
Excuse
has
me,
a
sir?
question? Lap cholecystectomy with hernioplasty. Can
So we have taken out the gallbladder now without any spillage. So we are gonna, I think the defect size is around 1 to 1.5 centimeter. Our plan is to place a Ventralex patch here. And obviously we are gonna fix it up.
Prasad,
Yes, sir.
yes, Dr. Prasad. What is your plan of surgery in this case particular? Defect is looking bigger than what you say 1 to 1.5 centimeter, I think.
Patient by
It looks
ultrasound also
around-
shows a 2 centimeter defect. It's less than 2 centimeters. So
Okay.
if you see his index finger is there, 2 index finger size of defect. So about 2 centimeter size is the defect. So now the
Yeah.
question is IPOM versus Ventralex patch versus inlay proline mesh versus onlay proline mesh. So maybe I'll ask Apuru Bhai this question. He's senior professor from BJ Medical. Apuru Bhai, in your if this patient was in private practice, what would you do between these 4 options? You see the skin that is there, big distended skin.
Yes, yes. So considering that we are doing a lap chole, I think IPOM plus would be a good option.
Okay. What about the other moderators? What is their take on this?
Sir, for a defect less than 2 centimeter, we can use a Ventralex large patch, so which is of around 12 centimeter in size.
Yeah, Atani, Ankur Bhai, 8 centimeters is the maximum size available. There is no large size. It is 6 centimeters and 8 centimeters. So this is the biggest size that's available.
So this defect size is just around 2 finger breadths, so maybe around 1.5 to 2 centimeters.
Good for a
So I
Ventralex
think-
patch.
It's good for a Ventralex patch, actually.
And we can very well see the hernia sac also.
Yes, we are gonna excise the sac.
Yeah, so it would be
before we
better if
place
we
the mesh.
dissect out the sac and do a
Yes,
proper
sir.
repair or proper mesh.
Yes.
plastic.
Ventralex sac nikal de.
I think we also need to taper that skin because she's a young lady. I'm sure cosmetically that loose skin is not, see the skin that he's holding. So in this situation, I think doing a little bit of plastic work for the umbilicus also is important. Apurva, you agree?
Yeah, umbilicoplasty is required in this case.
Prasad, aur thoda skin nikal.
Yes, sir.
This is called backseat driving.
So regarding the 12 centimeter, Bard has a 12 centimeter mesh. It is not a Ventral patch, but we can make it as a Ventral patch. As we tie the sutures and we can work out, we can do a jugaad of same as Ventral patch.
अंकुर भाई का जुगाड़ का पुराना आदत गया नहीं अभी तक.
So because the defect is big, if you are using 8 centimeter mesh for such kind of defect, I think it is going to be a bit smaller for this kind of defect. So it is better we use a 12 centimeter patch for such kind of hernia, sir.
Dr. Ankur, Dr. Dushyant here.
Yes, sir.
Yeah. Looking into gallbladder, it was looking like there was not much of cholecystitis at present. Even it was not infected. So there is always a debate between IPOM and a ventral X, right? So even like in this situation, if you can put a mesh, that's not going to be a big problem.
Definitely,
That's
sir.
what my feelings.
Definitely.
Hello. Yeah. Can I comment upon this? Hello. Yeah, I am Dr. Rajan. A little different opinion from my side. It is a bit cheaper also. If you can decide the retrorectus space by open method and put a simple Prolene mesh.
Dushyant bhai, your point is very well made, but unfortunately, this patient only wanted a laparoscopic repair. She came to me as a laparoscopic surgeon, only wanting lap chole with lap umbilical hernia. So the other advantage of the patch is you don't need tackers. You can only suture this patch. So the cost is about 16,000 rupees. So it is easier for the patient to afford also. But I take your point that a retrorectus mesh, only thing is that this patient will now be discharged tomorrow morning. She'll have no subcutaneous dissection. She'll have no subcute drain placed and she'll go home tomorrow morning. In a retrorectus, you need to do some dissection, place a Romovac drain and maybe keep the patient in hospital for a day or two longer. So, you know, that I completely agree with you. The retrorectus is easy to do and much cheaper also. So I think as a surgeon, you need to know all the techniques available and choose the appropriate technique for the appropriate patient. Would you mind if we shift to Samir's OT where he's suturing the mesh on the rectum?
Yes, yes.
Dinesh bhai, just shift to OT with Dr. Samir Rege. Okay, Samir, we are with you.
Yeah, so I have taken a strip of the mesh. I think it's gone a little longer, but that's okay. If you have a little longer mesh, you can cut it later. Otherwise, it's going to be a problem if you put a shorter mesh. So it goes anteriorly, anterior to the left. Before taking the mesh, I have changed the gloves, following all aseptic protocols as for what we use for any prosthetic surgery. And I've been lucky enough to get a 20 Ethibond. Possibly we get everything available in Zen. So this is a good suture material, a braided suture material, non-absorbable, which gives a good amount of strength. Added advantage, the needle is quite stout and a smaller one which can go into tissues much easily. Firstly, I'm going to put 2 rows of suture on left side, 2 on right side onto the seromuscular layer of the rectum, and then the mesh should be kept into the right side of the rectum, which will go and get fixed to the promontory. Now, suturing at times is going. I'm using a sectoral vision. The vision is coming from the umbilicus, and I'm operating from the right side. That helps me as a short person because my shoulders do not go haywire. But you require to be master this art of suturing because this sectoral suturing will help you in many of the cases, especially if you are doing a TEP with central ports, and you ought to have them either plication or suturing of the mesh. This would definitely help you. More important, many people would try and use a tacker when you want to fix on the promontory, because at times it becomes much convenient to put it, because the angle at which you are going to suture on promontory here is going to be acute. You can realize this. So, I would still try and put multiple sutures there, which will try and fix the mesh at that place.
So any role of traction on the bowel while suturing?
Right now, not, because right now I'm suturing at the area where I'm supposed to be the lowermost part which has been exposed of the rectum. So this you can appreciate my my assistant has put it now. Only problem in my peritoneal opening is little smaller, so I have a smaller window to operate, and that's where I'm going in and asking the camera surgeon to come inside along with me. Now,
I think
important
Samir,
Before
Samir,
we
what Ankur is meaning is that if you don't pull the rectum, you may fix it into a prolapse position.
exactly,
So
and any
that is, I
role
think,
of
what you-
to see before suturing that whether the prolapse is reduced or not.
Sir, Anand here. Hello. Hello.
Samir, we can't hear you.
Can you hear me
That-
now? Sir?
the rectum has been pulled up by the assistant.
Yeah, so pulling the rectum is important. So you fix it in the pulled up position.
Am I audible, sir?
Yes.
What would be your approach in a female particularly? The same approach, anterior rectal fixation? Because
Female
the-
especially-
Female patient with a
Yeah,
uterus.
the
in
mesh
position.
you
So what will
push
you do to the
in the
uterus?
anterior
Which it,
For uterus, classical, you can put a stitch, which can go from extracorporeal inside, which can hit the uterus up to the anteabdominal wall. Now, more importantly, it becomes much easier in a female because the pelvis is little wider. And that's where it helps to have a better space than what we are experiencing right now. Second important thing, Aate and rotate kar, because I have to see.
Samir, what would you do if there's a concomitant walled prolapse in a post-cystectomy
Yes.
patient? A rectal prolapse with a walled prolapse.
Rectal prolapse with usually, sir, if it's not very big, usually it should get away with rectopexis. But for that I would try and use a posterior rectopexis, sir. But at
No, but
times you
walled
can-
prolapse, what do you do? Walled, if you do posterior walled prolapse will be untouched.
yeah, but you can take sutures from the uterosacrals or the vault and suspend them anteriorly.
So where will be fixation on the rectum or sir vaginal vault, or where will you place a suture?
Both the rectopexy will be tackled as a posterior rectopexy, because then I at least go for circumferential, and then maybe I will take sutures onto the vault.
So in that case, we cut the mesh in a T-shaped size, and we fix both the end on the levator ani, and we also fix the rectum also. So everything gets pulled up. The whole.
Yeah, and you also want to put a suture on the posterior wall of vault, and that ideally should be a biological mesh in case she's a young sexually active lady. In an elderly person like this, you can I would use a lightweight polypropylene.
Hello, can you shift to the another OT because it's a important step is going on there. Sir, we will come back again with you. Can you shift to the OT where trying to put a mesh there? Dr. Prasad?
Yes. Yeah, I'm back here. So
We
any
are with
questions you
you.
wanted to ask?
Okay.
What did
Yeah.
you do, sir? I was seeing, I think you closed the sac from the open technique, I suppose.
No, sir, we have actually excised the sac completely. We have taken 2 stitches, one superiorly, one
Right, right. You have
inferiorly.
Defined the peritoneal opening.
Yes, yes.
Right.
And that is actually, and since the patient is a bit obese, we thought that's a better idea to do. We would have some space to put the mesh inside. And now we are folding the mesh in half. We are putting it inside. This is a Covidian Medtronic mesh, which has 2 handle-like things here. We put the mesh inside, we open it up, and we pull the strands. And what we do in our institute is, once we place this, we take the stitches and then we put a scope back in to observe whether the mesh is sitting properly or not.
CO2, please.
Yeah. Can you go in? Can you go in and show the mesh?
Yeah, can we, yeah, please. Or a PIP would be a
Lie
good
down.
approach.
Yeah. Cable down, cable down. No, clean the camera, clean the camera. Clean the camera. Can you? Yeah.
Very-
Can you
very nice.
see the mesh?
Very perfect.
Mesh. The defect is perfectly in the midline and the mesh has a good overlap on all sides. So what we're going to do is we'll fix this mesh with these threads which they have already provided. Apart from that, we are going to put two transfixing stitches at 3 o'clock and 9 o'clock. Any other questions you have for me?
Very, very nicely demonstrated.
Very, very well demonstrated.
Thank you, sir. Thank you very much.
We'll go back to Dr. Rege.
Please, sir, please.
Sir, we are with you. Samir, sir, we are with you.
So what are the fixation points, Samir? Where all you will fix? How many sutures?
I would try and take 2 rows of sutures, 2 on left side and 2 on the right side at the lowermost part where we have dissected, so that it gets fixed onto the anterior part of rectum, so that entire anterior part of the lower part of the mesh gets fixed with the most lower caudalmost part of the dissected rectum, so that the entire thing can be pulled up. Once it's pulled up, gets pulled up entirely with good amount of traction.
I mean, small suggestion is get your assistant to pull the rectum up when you're fixing the mesh.
Sir, she's already pulled it up, sir.
Okay.
These are problems of sectoral suturing because both come at very acute angle. So a good hint, good trick is to have 2 instruments, curved instruments like this. But still at times we may struggle.
Or use
Samir,
robotic
sir.
surgery.
Samir, sir.
Hmm.
Dr. Rakesh here. Is it mandatory to take a stitch on levator RNA?
Until unless the opening of the levator is too big, I would not go in for that.
Rakesh, but I think the consensus is that if you have patients who have pelvic floor descent, apart from rectal prolapse, only then you do a fixation on levator.
You can do application also.
So this patient has a full thickness rectal prolapse with a rectoanal interception, no pelvic floor descent. That is more important in a tricompartmental prolapse in women, not in men. Dr. Mahadev, Dr. Sachin, any questions for Sachin while he's fixing the mesh? Sachin, would you ever use Samir, would you ever use a T-shaped mesh or always straight mesh?
I prefer a straight mesh, sir, because the T-shaped to go and inside I understand exactly where you're suturing, the centering may go haywire. That is what I always think.
As we see, the rectum is completely pulled up. The suturing is done on the most, the redundancy has been removed. The Dino's Villiers fascia has been completely exposed. The suturing is done on the rectum, which is taut. So this will prevent recurrence. These are the steps to prevent a recurrence of a rectal prolapse. Also, the nerves have been well preserved. There is no dissection whatsoever posteriorly. So the chance of nerve injury is extremely less. For PG students sitting there, you need to have suturing skills if you want to do such high-end surgeries.
You can't take it there.
Otherwise, this is this type of surgery not possible.
No, basically, when you want to attempt even a basic laparoscopy, personal, I think people should master suturing because that's the only that's the only thing which can tide over any kind of crisis. Either you rupture, all companies would want you to become a technocrat using a lot of gadgets and get out of all crisis. But mind well that until unless you suture and stop any kind of bleeding, a lateral bleed may not stop, though you may have whatever fancy gadgets or energy sources. So it's my sincere request that people should practice suturing for each and everything, because try and do appendix, try and ligate or suture the base so that you get used to do a sectoral or maybe a triangular suturing, and then only they can start progressing. Because if you get stuck in gallbladder, finally subtotal cholecystectomy is the answer, for which you may require to close the stump. You may use a tacker, but a stapler, but most of the time staplers, endostaplers are not available. So if you can practice suturing for open, you can very well do for a laparoscopic surgery also.
So there's a good point for the PG students. Practice your laparoscopic suturing in simple procedures like lap cholecystectomy, transfixing the cystic duct, or transfixing the base of the appendix during appendectomy, so that you don't start suturing directly on an advanced patient like this. Master your suturing skills better on simple procedures.
For PG student, it is like when they are doing appendixectomy, so they start suturing by tying their stump. So normally we are used to using loops. So it is better to start suturing the base. So that is the way they start learning suturing, and then they can apply that suturing skills in advanced cases.
Just as an announcement, we are having this hands-on suturing for endo trainers for postgraduates and delegates. It is still going on in the stall section, and endo trainers for the endoscopy part. You can take the advantage and in between go and have your own hands-on training session over there.
See, what suture material what I have got is Ethibond, which is a good, it's a braided suture material. So when you are trying to suture or fix anything, especially laparoscopic, it's always preferable you have a multi-filament or a braided suture material that has better knotting properties than most of the monofilament. So doing a hepatic jejunostomy with a PDS, is much difficult than doing a hepatic jejunostomy with a Vicryl, which happens to be a braided suture material. Now this Ethibond is a non-absorbable suture material, good amount of strength. So these are preferred sutures, especially repairs of hiatus hernias when you want to close the crus. And this comes with a good needle, good curved needle, which is stouter, which will help you to go through tissues. So especially when we are going to go on the promontory through the prevertebral fascia, presacral fascia, that's where you require a stouter needle. Now you have to be careful while taking those kind of sutures, because those at times you may try and puncture some presacral plexus. So whenever you decide, you plan wherever you want to puncture it, and then go through with a single go, so that you do not cause any injury to the sacral plexus, presacral plexus. I work in a government setup, and that's why many times we try and use a Mersilk, because that's what is easily available, a good suture material available for poor man. Again, the needle will happens to be good, the holding capacity happens to be good, the knotting property is good. Only thing, it is still it gets degraded even though being a silk. So the strength what offered by a Mersilk is not as good as what Ethibond would give.
Samir, during a suture ectopexy, what suture will you use if you are doing only a suture ectopexy?
If available,
Choline versus silk versus Ethibond.
I would still try and, for laparoscopic suturing, monofilament sutures are little no-no, because then you require a lot of attention to be paid, not only to the area where you are dissecting, but the good element that you are not caused any knotting in between. That is one. And whether when you are going to fix, the knot should not get loosened. So in open surgery, you always give one traction. Here you are only two hands. One is putting a throw against the other. So that's where it becomes very difficult. Barb sutures can be used for closure, but not for suture, because the suture rectopexy, because they are going to be interrupted sutures, and they do not serve the purpose. So this is going to be a fixation on the promontory. So you can appreciate I have put a larger, very large mesh inside because I would prefer to cut it at later go. Can you appreciate this
Yes.
promontory?
Yes.
Yes, sir, we
Yes,
can
yes.
appreciate.
So preferably to not try and take in midline because usually veins would come in mid.
Yeah.
How many switches will take in the promontory?
What we have done is we have placed the mesh, we have closed the anterior sheath here. Mesh is sitting very well, but we have
Yes, sir.
still gone to take two transfixing stitches at 3 and 9 o'clock so that the mesh stays flat along the parietal wall. And I think we are happy with the mesh placement. What do you guys think?
Yeah, we are also happy.
Very nice.
Yeah,
So our
nicely
job
done.
here was yeah, any
You
questions?
can have the round of applause from the audience.
Thank you
Dr.
very
Roy.
much, sir. Thank you. Mosquito.
Sir, we are
Sorry,
shifting.
Yes, sir. Yes, sir.
Mr. Roy here, sir.
Yeah. So what is coming up next? We can see both the mesh very well placed, very well executed surgery.
1OT you have a PTH for third degree hemorrhoids by Dr. Nitish
Hello.
Jawar. And in 1OT you will have a robotic laparoscopy done. After that
After
you will
this.
have a lap after this. And the next
Okay,
cases
perfect.
after that is a hiatus hernia and a achilles cardia. Then we have one transpinteric fistula and one more incontinence. Depending on time we will show you. What time do you want to show until?
No. So after this, we'll be having one hemorrhoids and one robotic lap chole, correct?
Sir, nicely performed procedure. Can you hear?
Yes, yes, you can ask, you can ask.
Sir, what is your surgical algorithm of
I think don't tighten it.
rectal prolapse patients and workup?
Yeah.
Who is this for?
Doctor, I
Jitu-
a question
Jitu
for
Patel.
you. Dr. Jitu Bhai from Mehsana.
What is your
Sir, I think in
surgical?
our hospital, one thing we have is a preoperative routine use of MR diffusography. If the patient has any incontinence, then we will also do inner rectal manometry.
Yes.
We will do flexible sigmoidoscopy in all patients. As far as choice of procedure is elderly patients who are not fit for general anesthesia, I will do a perineal procedure, either a Altemeyer or a star, depending on the extent of prolapse. If the prolapse is less than 3 centimeters, I do a star with a posterior fixation. More than 3 centimeters, I do Altemeyer procedure. Any patient who is fit for general anesthesia, I will do a laparoscopic ventral mesh rectopexy. If they have patient grade 1 ASA, then I do resection rectopexy. That is an algorithm.
Do you submit all patients who are fit for anti-rectopexy or do you prefer any other procedure?
So all patients who will give GA.
Those patients who are
90%.
fit.
Yeah.
And
So if
you
you have a
submit for
young-
abdominal procedure, do you submit
Yes, sir.
all patients to anti-rectopexy or is there any
So-
exception?
Only young patients below 40 who are redundant due to sigmoid colon and severe constipation, I do resection rectopexy. In all others, 90% of patients get ventral mesh rectopexy.
Because patients, those who are having severe constipation, they require sigmoidectomy.
Yeah, good.
That's right. So resection
Perfect,
rectopexy
perfect.
means resection of sigmoid, mobilization of rectum and posterior fixation of rectum,
Yes.
resecting the
Roy,
redundant due to sigmoid. Yes, sir.
Dr. Pankaj Modi here.
Yes, sir.
I have one or two questions for our rectopexy part. So
Yes, sir.
initially when you showed the CT, it was showing only 2.5 centimeter prolapse. So is it okay to
Are
do
you done?
this big surgery for 2.5 centimeter prolapse?
So the MR showed 2.7 centimeter. Actually, when the patient sits and squats, it is
Exactly.
more than 7 centimeters, sir.
Yes, exactly. So that's why what I wanted to convey is that MR is not actually answer the clinical picture. What the patient is showing is more important. Because
Absolutely
in
right, sir. So the
2.5
MR is,
centimeter- Yes,
so
sir.
the MR is more important in female patients to
Yes.
look for concomitant vault prolapse or bladder prolapse. Because if you have a tri-compartmental prolapse, then I would put a D or a Y-shaped mesh and fix it to the levators in addition to the rectum. In a
Right.
male patient, I agree with you that MR doesn't have a great role.
Right, because the MR many times doesn't show actually at the time of doing MR, patient is very conscious and may not have that kind of pressure to bring out the whole prolapse part. And sometimes you get misguided. Actually, is it a large prolapse or not? That is
Yes, sir.
one.
Absolutely right.
Also, the
Another
patient
message
is
for
also in the
youngsters-
supine position.
Yes, that is another reason. Second question is, sir, do you have any take on a perennial approach mesh plastic?
So I've never used perineal meshes. Transvaginal meshes and perineal meshes are highly controversial. And I think now I don't think many people are doing this.
फिर बात कर रहे हैं ना.
Because I do put a sometimes perennial mesh. So, but as you have said, every time the people are saying that it's a controversial. Okay, just wanted to know. Thank you.
The mesh erosions are very high with perineal procedures in all literature, sir. So I'll be very careful of using them.
Okay, so that's why I'm not going to ask about those procedures which are done transrectal, suture rectopexy and those things. Again, a
Yes, Pankaj
controversial
bhai.
thing. Right. Thank you, sir.
Yes, sir. So we just.
Sir? Yeah, we are actually done with the procedure and the mesh is sitting well. We have taken 2 transfixing stitches. Thank you very much for everyone for giving me the opportunity. Thank you, Roy, sir.
What about the
And,
peritoneum? Sir, one question from a general surgeon.
Yes, sir.
What about the peritoneum? Will you be closing it or you'll be keeping it as it is?
So this is for which rectopexy or for
Rectopexy.
yeah, yes. So I think we'll wait for the monkeys with Dr. Prasad. I think in a few minutes after, since he's over, we'll shift to Samir now. Dinesh bhai, please shift the mic to Dr. Samir Rege's OP.
We are off. Ajit, we are off.
Purpose to take a smaller mesh, because by chance, if I take a smaller mesh and it doesn't serve the purpose.
See the
I
wall,
got-
we can't hear it
Dr.
clearly.
Rege, your voice is very low.
Hello.
Dinesh bhai, we are not able to hear.
Dinesh bhai? Hello?
Can you hear me, Ankur?
Yes, sir.
हो पण ते मला आवाज जात नाही माझा. Hello? Can you hear me, sir?
Yeah, we can hear you now.
Yeah, this is a polypropylene mesh and always has to be extraperitonealized. So I am going to suture the peritoneum over it, and that's going to be with if this suture material serves the purpose, that's okay. Otherwise, I may just take a absorbable suture material, maybe a Vicryl. आरामात. नाही, नाही.
How many sutures do you routinely take with the promontory, sir?
Pardon, sir?
With the promontory you are fixing. This is, I think, the second suture you are taking with the
This is
promontory.
third suture. Sir, whatever, this is going to be the only fixation which goes posteriorly. So I would try and have a good fixation here. So already taken, this is the third. Whatever said and done, I do not want these sutures to come out. If you see lot many European videos, they would take at least 6 to 7 tackers all around here.
85%.
Huh?
Samir, are there any patients who use a biological mesh?
Sir, I have no experience on biological mesh, though that mesh has been used or suggested to be used, especially in somewhere contaminated, or where you may think that it may get exposed to the viscera. The cost factor, though it may be available, I have not even seen the mesh.
I think in patients with vault prolapse, when you're suturing one edge of the mesh to the vault, in sexually active ladies, because polypropylene is known to cause dyspareunia and mesh erosion. And what is your post-op protocol, Samir, in these patients?
Usually I will start them on liquid diet in about 6 hours. I would try and maintain them on liquids, maybe a purgative so that they do not strain. So they are started on soft diet maybe after good bubble sounds. And initially when we started rectopexy, when we used to do open surgeries, we used to keep them head low for maybe about 48 hours. I think that concept should go off because they should be early mobilized. This is a pelvic surgery. Many times I may still give low molecular heparin just to have a good anti-DVT prophylaxis. Now, would you appreciate that I have left the traction on the rectum?
Yes,
Hello?
clearly seen, nicely seen.
Can you see, sir?
Ankur bhai, can you hear us? Ankur bhai, can you hear us from the OT?
No, we are with you, sir.
Sir, we are with you. We are just discussing. Dr. Rege said something about tackers.
Yeah.
So I was just
there-
interested, do we get enough depth with the tackers? Do they hold well or?
Sir, actually for the, if people is going to using tackers, they usually use non-absorbable or I have no disclosures, but with the people I have seen using barred capture or maybe a Protect. Now issue is Protect has the best purchase because it has good depth. Any other tacker would not have a purchase of more than 4 millimeters. But that's where they use at least 6-7 tackers in this area. Now I'm apprehensive because there are not many veins here. And once you tack and they bleed, then you have no control.
Samir, I have a different view. Your sutures also are not more than 5 millimeter deep because there's pre-sacral plexus embarrass vessels there.
Perfect. But
So why do you want more than 5 millimeters?
yeah, so basically the suture when you take, when I'm
You can
going
still go
to-
through the pre-sacral vessels.
but you
Dr.
have
Patankar, I
tissue
asked
in
this question specifically because we have a lot many PG students in our audience.
Yes, sir. Yes, sir.
So when you take a tacker, the tacker goes at one point, so that the breadth is not much. However, when you take suture, it can be of varied length, maybe the breadth of about 2 or 3 millimeters. So you have tissue which is going to hold it. So that's where I would like to prefer to use the suture. And rather, the second thought is you may require 3 or 4 tackers here, and you have to waste the entire tacker. Now, I do not have a concept of using a tacker for same tacker for second patient because you are using it for prosthesis, and I defer to reuse a tacker for second patient. So then I am going to waste. So at times you are trying to have a economical surgery, which you are trying to make it into a costly surgery. So now, just because I have a suture material which is
Samir, you're also using a lightweight polypropylene mesh here. Any suggestions to the audience about when to use regular weight polypropylene versus lightweight?
especially if you have a very, sir, basically I would still prefer to use a heavyweight only because it gives a good amount of scar. However, possibly if you are doing a posterior and it's good, I have never actually used a lightweight for rectopexy.
So this is a lightweight that you used.
Okay.
This is a soft mesh.
I would actually prefer.
What about the moderators? What is your take, approved by other moderators? Lightweight versus heavyweight mesh? Apurva, can you hear us?
Yes, sir.
Lightweight versus heavyweight mesh, what is your take?
Sir, the sound is cracking, so we are not able to hear the.
Yeah, the question is lightweight versus heavyweight polypropylene mesh.
Yeah. So for rectopexy, I mean, it's difficult to say. I don't know of any study being conducted.
So
Usually we prefer lightweight.
But
our thinking is, mesh erosions are a problem. So because of the risk, we tend to use a lightweight polypropylene as a routine.
Different thinking process. Something I learned.
So, which suture material prefer for the closure of the peritoneum, sir?
Peritoneum you can use preferably to use if you have a monofilament absorbable or a delayed absorbable, something like PDS, which will help me close easily. But now whatever suture is remaining, this still can serve the purpose. This does not irritate any of the nerves or does not cause a lot of adhesions. So I can still use to close the peritoneum.
Okay, point should be taken.
So important that you have to try and close so that whatever peritoneal defects should not remain, so that the bowel should not get exposed. I'm rotating my
You prefer continuous or interrupted?
always continuous. असं थोडा हलका जास्त दाबू नकोस ते. And I don't want the rectum to get rotated. कळलं की नाही? हाँ ठीक है, वैसे कुछ नहीं पड़ते, देखो एक्स्ट्रा प्रेस करने का ना, नीचे के उसे करने पड़ते हैं, देखो सिर्फ रोटेटेड नहीं चाहिए, अदरवाइज रेक्टम विल गेट रोटेटेड नो। मला
In a case of C rectum, where the anterior wall is involved, you resect both layers of denon villus fascia from Daniels.
There's a question by Dr. Daniels that in a case of CA rectum, are you going to resect, which is involving the on the anterior side, would you resect both layers of the denon villus? So when you are operating for a malignancy, it's imperative that you do a good clearance, and that's where you have to bare your seminal vesicles. So that is the difference between a dissection for a benign disease and you are doing for a malignant disease. And if you are doing AR or APR, and so anteriorly you always see bare seminal vesicles, maybe some part the bare prosthetic capsule, so that you can have a good clearance or good oncological clearance. So when you are going to take these sutures, it's extremely important that you do not rotate the
Am I
rectum.
audible there?
Yes,
Yeah, Samir, Kalpesh here, Jani.
yes, sir.
Hi. So in this part, my concern with whenever doing ventral rectopexy, that is why I don't do it very frequently. I do it in very selective patient. Is it particularly this step? When you are closing this, the peritoneum, you can see that there is a long strip of polypropylene mesh, which is being squeezed against the anterior rectal wall. And it's getting folded and pressed against the anterior rectal wall, and that's going to be there for a long time. And polypropylene, we know, has a tendency to fistulate into bowel, not immediately, but 10 years, 15 years, 20 years down the line. So what are your thoughts on that?
Sir, I agree that at times I always get the feel that it may act as a sling which is against the rectum, which is going to compress. As some small amount of bleeding. So, but issue is right now that we are at times we are thinking that if we have to protect the erectile nerves which lie posteriorly, this surgery would merit, especially in young people, especially
absolutely.
when you have a unicompartmental disease.
So that's why I do it very selectively. I do it only in young adult males, VMR. Otherwise, I do posterior mesh rectopexy on all my patients. But I
Perfect,
believe
sir.
Roy almost exclusively does this thing.
Yes.
For prolapse. Roy, your thoughts about the concern for fistulization of this strip of prolene. And in this particular step, you can see when you're just closing this peritoneum over the rectum, that whole mesh on the anterior surface of rectum, it's getting folded and actually it's getting compressed against the rectal wall. I'm sure that we are going to have and this is just my personal opinion, of course, that we are going to have a rash of these meshes perforating into the rectum 10, 15 years down the line.
So I think, Kalpesh, this VMR has been done from 2005 by most European centers. And the latest data was more than 10,000 patients followed up, and the rate of mesh erosion was about 0.8%. I think we have in the past been using posterior mesh rectopexies and closing peritoneum where the mesh was fixed to the rectum all their lives, and nothing much happened. I think this is an overrated thing. I think what is important is to avoid hematomas and infection. That is the cause of mesh erosion. If you use a lightweight polypropylene mesh, and I would actually use PDS to close this, fix the mesh to the rectum. There is a Korean paper that shows that when you use a polyfilament versus monofilament, there is a slightly higher risk of mesh erosion. But there is enough data from European centers for now more than 17 years showing that the mesh erosion rates are very, very low.
Actually, I would like to share some thoughts way back in since 2001. I mean, I have seen 4 or 5 cases where the mesh has rotated through the rectum, and we have satisfactorily removed the mesh per rectally, piece by piece, over a period of 2 months. But the patient never, those are the cases of open rectopexy, where we usually use to do a Wells rectopexy or notaris, where a large mesh is placed in the posterior rectum place, posterior to the rectum.
Yes, sir. Apurva, point well made. Apurva, what is your experience with perineal procedures? I'm sure in BJ you do a lot of perineal procedures for elderly patients.
Not too many, but especially in those places where there is recurrence or in a morbid patient where it is, we do get good results. Of course, our study is not a very long one, but a small mesh in through the perineum, the plane that we create for the this thing.
And a question for Samir, what is your take on handling recurrences? A rectopexy recurrence and a perineal recurrence. How would you handle them? In a young fit patient who has a lap rectopexy who gets a recurrent rectal prolapse, how would you manage that?
Again, I would see for the symptom. If patient has a huge recurrence with predominant constipation, I may still opt for resection, though I very high early chance of or maybe low threshold for a conversion to open surgery, because they are not very easy to go into that same plane, dissect it out. However, if the prolapse is not that very big and easily reducible, no complications and ulcerations over there, may still opt for a perineal procedure. I have hardly any experience for perineal other than doing few Delormes. But for performing Delormes, you usually require a irreducible or a prolapse rectum which stays there. Then only it becomes much convenient to do it. For a perineal procedure which has undergone or recurrence or a reprolapse, I think I still favor the laparoscopic procedure. Again, you require to still merit what symptoms patient has and perform the procedure. As Dr. Jani told, he is more fond of doing posterior, and so am I, because I personally I did not find any of patients having erectile dysfunctions. Maybe I'm working on analysis of my data, yet to happen. But yes, this option is yet to be considered. I always fear about ventral mesh rectopexy is that it may just act as a sling over the rectum, which goes onto one side. And I always used to speak to Roy sir about this. Though if you done a few ventral, many times I still wonder whether I do a thorough job or not. So because in this procedure, usually I actually do not many times get what is the end point of dissection. On one side, we see that the rectum is getting prolapsed entirely. So it is a circumferential prolapse. And on other side, we are trying to dissect only one side. So the concepts of the evolvement of this prolapse surgery, I personally always feel that it is surgeon's competence which has taken the advancement of surgery. Somebody doesn't like to do a good dissection on posterior aspect, they opt for anterior dissection only. Or somebody who didn't opt to do only the anterior and they don't know what the landmarks to completely do the anterior like me. So then I would try and opt for a circumferential when I know the entire rectum is in my hand, so that I can do a proper prolapse surgery.
I'd like to take the
Sir, your views, sir. Modi sir. Apurva sir.
Yeah. Dr. Sanjay Jain has arrived. Welcoming Dr. Sanjay Jain, sir. Yes, sir.
What do you think? Whether you should do only posterior, only anterior, or circumferential? What is your take, Ms.
For mesh placement?
No, for dissection.
Sir,
then mesh placement.
Sir, as a general surgeon, what I have been teaching and what I have been taught, a circumferential dissection would be better. I mean, what I consider, and the studies have shown that it is more of the fibrosis and less of the mesh that takes care of the recurrence part.
Sir, I'll just like to add few points that
Yes, sir.
we at our center, we used to do, at Zen Hospital, we used to do a lot of ventral rectopexy. Then what we have added is that we were just doing anteriorly. So there is a chance that we leave the lateral ligaments on both the sides and inferior to the when we see the levator ani on one side, we go posterior also. So we can do a circumferential dissection without injuring any nerves. And this will take care of both the things, that the whole rectum anteriorly and posteriorly we can dissect, and we can save the lateral ligament at the same time. And what Dr. Jani said has said that the mesh is staying on the anterior rectal wall. But if we are creating a very nice plane, we are just taking a small around 2 to 3 centimeter anteriorly, then the mesh is going to stay laterally on the meso rectum. So in that case, it is not going to form, or it is not going to corrode the it is not going to rectum. So these are few changes what we have made case to case. It is not like just ventral. We dissect posterior also. So circumferentially below the nerves which are ended, means as the sacrum ends, both the nerves are going to get apart. And below that we can make a posterior tunnel also.
Dr. Ankur,
Yes, sir.
If you are careful enough to understand the anatomy of the nerves,
Yes, sir.
and you stay above the level of the ureters, identify ureters, and after pulling the rectum, you identify a plane which is anterior to it, you would always try and preserve the nerves posteriorly. Secondly,
Definitely,
I
sir.
always thought that preferable to use an energy source which you are familiar with, and not go for only specialized energy source, only because they at times go in a different plane, so that then it becomes very difficult for you, because it causes the tissues get cicatrized, and then you do not understand whether you are in a proper plane or not. So there are, I don't think that most of the people are still doing posterior ectopexies, and I hardly had to get many people understanding that, that they are having erectile dysfunction following it. So
Our patients are not very open, and they never complain
No.
us regarding
This, I'll tell you one thing. These patients are quite open about this, especially to the surgeon if after performing any surgery, because they always, even if they have a void on the leg, they will attribute to your surgery. So it's always, they are very open about these things. This is what I personally feel. So at least, and this is a very sensitive issue, especially for a young person if you're doing it. So this is what I think. But your point is well taken, that if you can do a posterior dissection going below the level of after the lateral ligaments, I think I should give a thought to it, because
Definitely, sir,
that's still-
because lateral ligaments are the key. If we are able to leave the lateral ligament intact, because in circumferential dissection we always cut the lateral ligament, and post-op constipation is because of the lateral ligaments. We are cutting the lateral
Accepted.
ligaments, and because of that we are developing de novo constipation posterior ectopexy. So if we are able to leave the lateral ligament as such, and then we are able to dissect posteriorly, then we can suffice both the problem of posterior ectopexy and ventral rectopexy. So we can get a better result in rectal prolapse patients.
No, your point.
Ankur bhai, in fact, that modification is not my modification. It is a St. Mark's modification of VMR. It was first
Yes, sir.
put forward by a Sri Lankan surgeon, where you preserve the lateral ligament, do posterior dissection, but I would do a lot more dissection to expose both the levators on both sides.
Definitely,
And
sir.
yeah.
Samir sir, you were
Uh,
telling regarding the position of the patient. So will you keep this patient head low or no? No head low.
No. So usually these patients are on general anesthesia, and I don't see that we should be given head low. We have already covered, closed that the external space. So previously what used to happen, many people never used to close even while after doing open surgeries. And that's where they used to give the head low so that bowel does not go and get stuck. So many people after doing anterior section also, they may not make the anastomosis extraperonealized, especially even after lap surgery. So those were things where the people used to go head low. I personally do not, rather I try to mobilize them early because these are pelvic surgeries, may not be really prolonged, but still we do it for maybe after an hour or 2 hours. And we do not want complication because most of these patients are actually elderly people. So do not want any kind of thrombotic episodes happening in the lower leg veins.
So how long you will?
How long? Any choice of drains you have? Would you put drains? Dr. Ankur? Stop.
Yes, sir. We are with you right now. Yes, sir. How
So,
long you will?
do you, I usually will try and mobilize them as early as possible because we do not, usually most of the patient may not require any anticoagulant as low molecular heparin. But if somebody elderly, I may have to put them on low molecular heparin as a protocol. Don't they?
So the question was how long you will keep this patient on laxatives?
Laxatives, usually I will keep for at least 3 weeks minimum. So usually they go on liquid diet. Maybe after 2 or 3 days, they go on soft diet once they have good amount of bowel peristalsis. Handling of intestines, especially in retroperitoneum dissection, at times can give the paralytic ileus. So once they come out of any all bowel movements return to normal, maybe they go on soft diet. And once they are on soft diet, they are maintained with anticoagulants with laxatives. I would try and keep them for at least 6 weeks, 3 weeks. And if the patients complain of constipation along with it, then they would definitely be continued for a longer time.
Sir, what is your preferred choice? Osmotic or bulk forming?
Right now, I'll give osmotic.
What is your experience with the pre-op incontinence that some of these patients have?
A careful counseling has to be done with these patients because firstly, they require a good workup. Okay.
Is there any role of biofeedback exercises?
Actually, I have no experience on it, sir.
So Roy sir, please elaborate on this.
What is the status in the other OT?
So the robotic lap chole is just being induced. The PPH has already been given spinal. So as soon as Samir finishes, we'll bring the.
Can we have an external view of your robo?
Yes, sir. We'll give you, sir. Just we'll wait for Samir to finish discussion here.
Yeah, Dr.
Then we'll give
Rege,
you.
excellent dissection. Looks as good as normal.
Thank you, sir.
So I think usually we find that patients who have incontinence because of a prolapse is because of stretching of the levators and the pelvic plate. And most times when you correct the prolapse, we always find the incontinence resolves in 3 to 6 months. Our protocol is if somebody has incontinence, we will do a manometry from a medico-legal perspective to document that the resting anal pressure and the squeeze anal pressure are decreased. We also give them 1 session of biofeedback to teach them these exercises pre-operatively. So that after the rectopexy is done, immediately next day onwards, the patient starts exercising, he or she exercises himself at home. And we find that within 6 weeks to 2 months, most of the incontinence goes away.
What is your take on biofeedback? You said something about any protocols you follow?
Sir, we have a separate department with a lady physiotherapist, and we have both a EMG and a pulse-based biofeedback system in our hospital. But more importantly, for patients of obstructive defecation who have normal MR diffeography, if your MR is not showing any rectocele, basically for pelvic floor dyssynergia, in these patients, we find biofeedback to be extremely helpful. The second group of patients is who have SRUS, anismus, and trigger point pain. When you have specific perianal pain without Pils Fischer fistula, these patients often get labeled psychological, and when you do a manometry, you find that they have pelvic floor dyssynergia. And these are patients who benefit from relaxation exercises. So for the postgraduates, biofeedback doesn't necessarily mean strengthening exercises. It can also mean relaxation exercises.
And you may combine this with use of nitroglycerine, or in selective cases, we use Botox injections into the levator or puborectalis to relax the pelvic floor to cause relief of pain in anismus particularly. I think these are pelvic floor dysfunction is a very poorly understood condition, and anismus, SRUS, trigger point pain need very careful evaluation.
Right, sir.
Raw area. Sensor came. Sorry?
Any questions for by the audience?
Bowel. Commonly after doing these surgeries, especially with monopolar hook, I would always try and inspect the small bowel here, because though we have taken care that it has a good hook with proper insulation, coupling injuries because of trocars can happen. So it's always safer that you try and detect any kind of injuries which have happened at that junction itself.
Samir, since you do posterior mesh rectopexy or sutured rectopexies, do you take special consent from adult male patients before you subject them to that?
Very frankly, no.
So I work in a private hospital. I would feel very scared of doing a posterior rectopexy without taking a special consent, because medico-legally it is disaster. You know there is a potential for a nerve-related injury, and unless you consent, the minute you take a written consent, no patient agrees to posterior rectopexy. I guarantee you that. In a private hospital, nobody would ever agree to even a 1% incidence of erectile dysfunction. So I would ask everybody like Samir, Kalpesh, Jani, who are proponents of posterior rectopexy, is do you take special consent from these patients, which to me is a medical legal requirement?
Yeah, absolutely, absolutely. We explain to the patient, it's there in the data. We explain to the patient and we take the consent also. I haven't lost a patient who, it's how you explain to the patient. If you tell them it's going to happen, obviously a patient is going to go away. But you explain there's a small possibility that this is there. It's been reported in literature. You tell your experience. You tell how many erectile dysfunction you have faced in your experience.
You have faced when your patients are faced.
No, in the sense of patients, obviously.
I'm just kidding you.
How many such complications in your patients you have faced, and patients don't get scared. And there's we have a special rectopexy consent. And even, and as I said, for young adult males, I do offer ventral mesh rectopexy. In that, I take a consent that there is an increased risk of mesh erosion. This patient, we have an unknown increased risk of mesh erosion. We take both the consents for this thing, and patients, we let the patients opt for that. For young adult males, I do offer ventral mesh rectopexy to my patients.
So I think this is a very important point that Kalpesh mentioned. If you are doing this, you must take a special consent, because otherwise medico-legally you have no defense.
मेल लेंगे वेळ काढायचा असेल तर आपण काढू वेळ काढायचा असेल तर काढतो So all ports have confirmed hemostasis, so now closure remains. All ports more than 5 millimeter, I would always try and close it. The good method where you can have a closure, NMAS closure.
Kalpesh, in your center, how do you preoperatively work up these patients? Kalpesh bhai?
Yes, sir. Just hold on, sir. He's coming on the mic.
Yeah, right.
What is your pre-op workup for these patients of rectal prolapse, in female patients particularly?
We do get an MRI done, MRI pelvis, to see if there is sort of and we also get a dynamic. If there is a strong history of constipation, all the patients, we get a MRI difficography done to see if there is dyssynergia, pelvic floor dyssynergia. So basically, in those cases, what we have to additional step that we are looking is to, when we do this posterior dissection, if there is a wide opening behind the rectum, we try to, close the pelvic floor defects also. Anything
And
special
how do
you are
the?
looking for?
Please go on.
No, anything special, anything other than this, what you do?
No, what about patients who are complaining of incontinence or constipation pre-op? Anything different you would do?
Yeah, that's what I'm saying. We try to look for the pelvic floor functions also.
So
and which patients would you offer a resection rectopexy, Kalpesh?
All the patients who are having very strong history of constipation, previously we used to get a barium enema done. Now, of course, we just get a CT scan done. there is a very long redundant loop of rectosigmoid. Those are the patient in which we'll do a resection rectopexy. We explain to the patient resection rectopexy that this is there. Again, I usually believe in letting the patients, giving the options to the patient and then letting, them take a decision. So when I do ask them for a resection rectopexy, I tell them that this is a major surgery and we have to cut the bowel, and then there is an attendant risk of just as I explained about the erectile dysfunction here. Also I explained there is a small risk of a leak happening. So I gave them the option to choose between the two, but I would prefer to do a resection rectopexy in those patients.
Kalpesh, you want to make an announcement of Amasicon?
Oh, great. So yeah, I would like to take this opportunity here to invite you all to Amasicon 2022. It's in Guwahati this year, 18 to 20th of November. And those who are, it's a beautiful time. Guwahati, of course, Northeast is a beautiful place, and it's a beautiful time to visit the Northeast. And if you have to combine it with a family holiday, we also, tied up with certain companies, travel companies over there. They will give you some itineraries, and you can just combine a short family vacation along with the conference. Thanks, Roy, for reminding me. Thanks.
And as you know, Kalpesh is the incoming president of Amasi, who will take over in the Amasicon.
No, not this year. I'm president-elect. This year, Varghese sir will take over. So I'll take over after Varghese sir.
You take over. Right.
Yeah.
So I thought you were going to make some special offer for attendees of Guj Asicon.
We have one for those that are coming for the FMAS convocation. So they still get to register at a very discounted rate. Those who have done their FMAS during this year, and if you register for the conference, you still get to register for at a very discounted rate.
So that I'm just going to walk across to the other OT. I'm first going to show you the robot, and then we'll start the robotic lap chole. And then my colleague, Dr. Nitish Jawar, will show you a PPH. I think as per the request from Nishit, we have deliberately kept some anorectal cases. We have 2 complex transsphincteric fistulas, 1 PPH, and 1 patient who has incontinence with a sphincter deficiency. So depending on the time, 1 OT now will be robotic lap chole, hiatus hernia, achalasia. 1 OT will be the perineal procedure. So we'll try and keep everybody happy. Nishit specifically told me that he wants also anorectal cases to be kept. So hopefully we will try and keep you entertained in the next 2 or 3 hours.
So Roy, if you can see the docking of the robo.
Yes, sir. Yes, sir. I'm just going to the other OT and then we'll show you the docking.
Thank you.
At this point, I would like to conclude the first session, and I would like to thank our existing chairperson for beautiful and smooth conduction of this session. Sir, kindly collect your memento on your step down.
Our next session will be robotic cholecystectomy by Dr. Roy Patankar and MIPH stapler hemorrhoidectomy by Dr. Nitish Jawar. To chair this session, I would like to call upon the stage Dr. Narendra Sanghvi, Senior Consultant Surgeon and Chairman at Anand Surgical Hospital, Ahmedabad. Dr. KK Patel, Consultant Laparoscopic Surgeon at Ahmedabad. Dr. Ahem Arora, Assistant Professor at JJ Grant Hospital, Mumbai. And Dr. Jayesh Parikh, Professor and Head of Unit at General Surgery Department, BJMC. Two important announcement for today. 4 teams which have been selected after preliminary round of quiz are BJMC Ahmedabad, Government Medical College Surat, GCS Ahmedabad, Government Medical College Baroda. Final round of quiz will start at 2 p.m. sharp at Hall B. And there is a 1-day live workshop which will be a feast on piles, fissure, fistula and pilonidal surgeries to be held on 13th November at Asmita Bhavan Civil Hospital, Ahmedabad. This event is going to be organized by AAS, ASI, ASI GSC and ACRSI. Spot registration fee is rupees 1770 with GST. Thank you.
Good morning, ma'am. Good morning, ma'am. Can you hear me? Dr. Marere? Audience? Can you hear me in the audience?
Hello.
Hello, can you hear me?
Your audio is not clear.
Audio is not clear. Okay, we'll try and work on that. तू बात कर, बात कर। इतना सा रख दे।
इसका बैटरी है। बैटरी है।
Can you hear me now?
Okay.
Sorry, Sorry. Can you hear me, friends?
Hi, sir. We're getting a little bit of an echo from your side, so maybe if you could shut the caller mic because
Nice to see you looking fresh and smart in a new suit.
Sir, can you hear us? Hello, sir. Sir, can you hear us? Yeah. Hi, sir. Roy, sir, can you hear us?
we are still not audible. We are getting a very low volume with a lot of echo. Are we audible on your side?
Yes, sir, you are audible.
So the person who said,
Sir,
"Well,
can you hear
we
us?"
can hear you very clearly, but in the OT, we are getting an echo.
In a OT, you are getting an echo. One
Yeah,
second,
very
sir.
low volume with a lot of echo.
Okay, 1 second, sir.
I think a change of mic would be good.
Can you hear us here?
Yeah, Prasad, that's a little better. Yeah.
Hi, good morning, Dr. M.
Good morning. How's it going?
I was saying you're looking smart as usual.
We're getting a little bit of the echo again.
Echo again?
Can you understand what I'm saying or you can't?
With a little difficulty, not very clear yet.
So, this is a case of robotic lab coat. Can you hear us or you can't hear us yet? Can you see me? Can you see? You can't see us yet.
It's still not very clear at our end.
Can you hear me now, Em? Is it better?
A little better without a mask, yes.
Little better without a mask. I think the mask will be this. So this is a robotic lap pony that we're going to show you. And the other OT, Dr. Javar will show you a PPH. The patient has already had a spinal vein, so within a few minutes you should have the other OT as well. I'm just going to show you the robot. But we have a good video signal of Em, can you hear me?
So, I mean, we can hear you talk, but we can't really understand it very well. The audio is not clear at all. Would it be possible to change the wireless mic?
Increase your level.
Maybe that
Come again, Em, I can't hear you. Just increase the level from your end because this end we seem to be okay.
Yes. Hello.
पहले बड़ी बड़ी चैनल है एकदम
अरे डब चल रहा है उसने ना अभी वो हो गया ना तो बंदे ने नीचे कर दिया है फोन कर रहा हूँ फोन बिजी में दिया आपने जैसे सही
निश्चित रूप से ऑडियो आपके ऑडियो से बोला नंबर अब सब
कुछ ऑडियो का प्रॉब्लम है, आप अभी बढ़ाई है और कभी आप ऑडियो के साथ हमारे ऑडियो की बात करने को बोलो बढ़ाई क्योंकि ना ऑडियो प्रॉपर जा रहा है। हेलो सर, कैन यू हेयर अस? हेलो सर, हाँ हाँ हाँ, आपको बोल रहा हूँ सर, आप आइए ना ऑडियो लेकर आइएगा और वहां से ऑडियो बढ़ाइए प्लीज। ठीक है, हेलो सर, आपका स्पीकर भी बढ़ाइए, हमारा यहाँ का भी ऑडियो बढ़ाइए और माइक का भी बढ़ाइए। हेलो ठीक है।
Is this better?
Yes, sir, this is better.
You can hear me and see me clearly?
This is better. There's still a little bit of an echo. I think the audio
Great.
will try to clear it, but it's much better.
So I'll start by just showing you the robotic ports and the robotic instruments. And then while the patient is being painted and draped, you can ask me questions as we are operating. Cameraman, ye dikhaiye niche. So these are the, can you see the robotic ports?
Yes, sir, we can.
So these are ports which have a little balloon at the tip. Balloon for so they have a balloon at the tip. Our assistant brother Prashant is showing, just putting some air into the balloon, and this is to prevent vertical movement of the trocar 2 and 4. I have with me Dr. Samir Reged, Dr. Sachin Vani. So these are the ports, and I'm going to show you the instruments. So these are the various instruments that I'll be using. I'm using a. So these are the versus. For example, this is the focus. Karo thoda usko. This is the
We
TV.
just see the tip a little
Hello, can you hear me?
Yeah, yeah, we can hear you.
Yeah, yeah. Okay.
Isko dikha de. So these are the various instruments I'm going to use, and I'll show you the robot in a minute. Idhar focus karo aage, iske upar. This is the CMR robot that we are using. We only had it for the last month and a half, so we have limited experience. So you've done a CA rectum, we have done a CA stomach, we have done gallbladders, TAPS. We have just yesterday did a achalasia on that. But today I thought we'll only show a robotic lap chole, and as we get more familiar and better with it, I'm sure in the next workshops we can show you esophagus or a rectum with this.
So that's a
The
very
port
impressive list of
positioning.
cases for the first 6 weeks.
Sorry, I can't hear you. A little louder, please. I can't hear you. Can you be a little loud?
Can you hear us now?
Yeah, a little louder, please.
Yeah, so I was saying that it's a pretty impressive list of cases for the first 6 weeks. Many congratulations on that.
Thank you, Em. Good team, Samiriana. Hi, Em.
Hi, sir. Yeah, Samir sir, you just have to speak up a little bit.
Yeah. So right now, I want to discuss robotic lab call. It's not lab call. Robotic police system the first time. The instruments are quite different than what model website system has. So the only advantage what I see in this robot is it's an open console. So the surgeon, the robotic surgeon, does not inside a window and he's open to what the arms are. Especially what the exercise we have limited get on the arm and rest it. So where we are little liberty to move here and there and still operate. And this is a very compact robot where it can move from one theater, one room to another room. You can use whatever the arms are different, so that the arms can be shifted. So usually it's a quite portable robot what I'm seeing here. So let's hope to see a good robotic cholecystectomy today. So we routinely move our robot from the 4 OTs here, 5 OTs out which we routinely move the robot from OT to OT. And the advantage is that you see these arms, these are separate arms. So we have 4 separate arms. These are the operating arms and we have the visualization bedside unit as it's called. I'm going to spend a few minutes थोड़ा सा zoom out करके पूरा arm दिखा. हाँ बस बढ़िया. So this is individual arms and they can move from OT to OT quite easily. So we'll hope to, I think I'm getting Dr. Prasad and Dr. Ajit to put in the first ports. We can't use an energy source or a suction in this. So we need to modify our technique accordingly, and we're still in the learning curve on this. But I'm hoping in the next Bujasicon, I'll show you esophageectomy or a rectum in the next year. So it's we only done about 25 cases on this, and still very much in the learning curve. But I think it's very, very easy to use. I think apart from me, Vishakha, Dr. Prasad has done several cases, Dr. Tanveer, I think very easy to pick up. And I think my team has probably done more robotic surgery and I think the highest number is Vishakha, who's currently in Falls, Chennai, which is why she can't be here. Otherwise, she would have shown you a robotic gallbladder today. How come you are not in Chennai?
Well, Dr. Nishit had tied me down to this event many months in advance, and he's difficult to say no to.
Preempted. Very good. And nice to see you there. So is there anybody in the audience who has experience with robotics? We'd like to hear their opinion on this.
Anyone in the audience has experience in robotics?
So I had one question. What are the advantage of robotic laparoscopic cholecystectomy over conventional laparoscopic cholecystectomy?
So for cholecystectomy, to be honest, the advantages are to the surgeon. I'm an old man now, so it's easy to sit on a console, sip at some tea, read something, and then do surgery side by side. But certainly we have seen that in our rectal resection. So yesterday I did a coloanal anastomosis with a robot, and in a male pelvis that would have been very, very difficult without using a stapler. So I think the real advantage would be in rectum, rectopexy, like what Samir did. I could have gone much lower down with a robot and sutured much easier using a robot. Similar thing for fundoplication, esophageectomy, adrenal, where you're operating in depth.
So
Yes,
just as you were starting, we kind of lost the feed and we just got you back. So I'm sorry, but could you start at the beginning again?
So I think for a gallbladder, I don't think there is great benefit to the patient. I think it benefit more to the surgeon. But I think the gallbladder and the tap is a good learning modality before we proceed to esophageectomy and rectum and colon. And I think particularly we 2 days ago did a coloanal anastomosis using the robot. And there the suturing is actually very, very easy as compared to laparoscopic suturing. And I'm sure in the years to come, we don't need to use as many staplers as we do currently. So I think this is a process in evolution. To me, we took on the robot because it's a technology that is here to stay. And we wanted to be in the first mover advantage, a bit similar to laparoscopy. So in 1994, when I started doing laparoscopy, the instruments were crude. I was using an air insufflator. I had very few good instruments, but we were in a good place because we started doing this procedure very early. And I think robotic technology is here to stay. I'm sure the newer robots will be better. They'll be cheaper. The instruments will be more accessible. And I'm sure that this technology is not going to go away.
Yeah, thank you very much.
So my team, Dr. Prasad Bokebag is just placing the ports, and Dr. Ajit is just moving. You can just see how the bedside units are being set up. I think this is I think the worry is that robotic docking takes 1 hour. That is what I was told earlier, and it really put me off. But you can see with this robot, I think, and although we have only done about 15 cases, the average docking time is about 15 minutes, which I'm sure will bring down to 10 minutes as we get better at it. But I want the audience to understand what this concept is. So Prasad has put an umbilical port and 3 more ports like a lap chole. भाई तुम उसको दिखाओ अभी वो bedside unit को दिखाओ आगे तुम आगे आ सकते हो क्या आगे आ सकते हो
So any change in port positions compared to standard lap code?
Yes, there is we on the patient's right we have only 1 port and we put 1 pararectal port on the left side.
We're getting the lap view right now. Okay, we're back to the overhead camera.
So you can see how Ajit is taking the arm in and setting up, getting the arm ready to insert the instrument. You can see that there are individual arms, unlike the Da Vinci, which is like a big console, which can't be moved. These are all portable arms, and we routinely move the arms from OT to OT. You can see Brother Prashant putting in the left side grasper through the port. And we do what is called port training because you have to give a little spectrum of coverage for the robot to move.
आराम से कर अजीत, take your time. और भी आगे आ पाओगे तुम तो उसको दिखा दो जो कर रहे हैं ना, तो तुम आगे ना उसको खींच खींच उसको उनको दिखाओ, उसको दिखाओ. So you can see how he is putting in. Ajit, you are blocking the camera. So show him how the thing is going in. Huh? So you can see Dr. Ajit putting in the Maryland now. And I think on the average, every instruments take 3 to 4 minutes to get in. And the whole docking process, I'm sure we can bring to below 10 minutes after we cross about 50 cases. Right now, we go a little slow because, to be honest, we are still in our learning curve. So you see Brother Prashant doing what is called port training. He's rotating the instrument and then doing the port training, as it's called. This is to prevent adverse movement of the robot away from the field of vision, preventing accidental injuries. Now, Ajit has got a bipolar Maryland on the right side, and he's doing what is called port training. You see him rotating the instrument. This process is called port training. नहीं, बाद में. अभी तो बाहर से ही दिखा. So this concept is called port training. Prasad, you're blocking his vision. दिख रहा है. So right now, Dr. Prasad is holding the camera manually, but in a minute he will connect that to the visual bedside unit. And I think the beauty, I did a fundoplication last week, and the suturing is actually very, very simple and without strain to the surgeon. So I think the suturing is the differentiator between this. I think dissection for a person like Samir, he operates like a robot. But I'm sure 10 years down the line, when he gets a little more gray hair, like some of his mentors currently, then you will find that the robot will make his life much simpler. Yeah. विकास की तरह विकास है ना आराम कर रहा. So the best part is I can remain outside OT watching CNBC and having some chai while the team is setting up the robot and training the instruments. Yeah, we need no room for the anesthetist.
Would it be possible to shift to lap view right now?
Just, yeah, as soon as the ports go in, we'll shift to lap view. So these are the 2 ports that have gone in. I'll give you a PIP here while we wait for the PPH to come on table. As soon as the PPH is on, you will find both the screens live. The other thing here is we get a nice 3D vision, which I'm afraid we can't give you there. But with the operating surgeon, you get a fantastic 3D vision, particularly when you're working inside the pelvis. It makes life really, really simple. Madhav, kursi ge. अच्छा एक्सटर्नल कैमरा इधर लेके आना जरा हमको उनको अभी ये दिखाना है हमको. So do you have मेरे पीछे से तुम दिखाओगे तो आसान होगा. यहाँ से तुम दिखाओगे ना, यहाँ से आओगे तो. So can you see you'll see the robot in a minute?
Yes, sir.
Acha. So can you see the robot now?
Yeah, we have a side-by-side view on us at our end.
Great. So Dr. Prasad has just put it in the camera. You can see that I've got so I've chosen a 30-degree down vision on the console. The hand scaling I keep to medium. This is the speed of the surgery. Because we are still new at this, we keep it okay, now we're ready to go. So I've activated the left instrument. You can see the left instrument there. I'll just show you the movement of the camera now. This is how we can zoom in and zoom out with the camera, go up and go down. Do you have the robotic vision now?
Yes, we do.
Great. So I'm just,
you have a
forward and you have a forward and backward movement with the camera, which I'm doing, sitting with my, toggling with my thumb. I have a left to right vision, again, toggling with my left hand. It's a bit like a PS4 I think for my son would be very happy with this because he's so much spent so much time on the PS4 that I think anybody with the PS4 would find this very, very easy.
So did you negotiate a few gaming consoles with the robot?
The other way around, actually. So you can do a anti-clockwise and clockwise rotation. Can you see that? So all with the toggle of the left hand. Lift up. So I'm going to get my colleague to hold the fundus up. Aram se. Yeah. Take it up, Prasad. Up to the right shoulder. So the other advantage is you see the movement of the left hand. You have a 360 movement up and down, which you can't do with ordinary surgery. Head up. Take it up. Cautery is connected. Prasad, you need to push up more. Sam. Yeah. Do you have good vision, Am?
Absolutely, sir.
So as I mentioned earlier, the gallbladder is a training ground for us to move beyond. And I'm sure in the years to come, we will show you more complex surgery with the robot. The other advantage is this is only costing me about 50,000 more than a conventional surgery. And I'm sure that cost will come down as time progresses. Unlike the Da Vinci, it is portable. If you see my port training, and this is despite us being fairly new at this, we actually spent about 12-13 minutes extra in docking and undocking. And I think when you're doing a rectum or a rectopexy, it really doesn't matter that extra time. So I'm very much in my learning curve. We were toying yesterday whether we should show a live case, but the team felt that we should go ahead and show it just to show you what the new technology is all about.
Can we have the near look close-up view?
The close-up view is because I'm quite far on the robot. Is this better?
Yeah, little bit better.
To the AV guys, can we also just have the robotic view for a bit so we can appreciate the dissection a little more? Because the side-by-side view is So with regards to, you were mentioning the fact that you're early in the learning curve and the indications are therefore a little broader at this point. Recently, I spoke to quite a few surgeons in Boston who are performing almost exclusive robotic surgery, and this is something that they shared, that they like performing the easier standard lap procedures robotically early in the learning curve. Then they gradually shifted to doing, say, only bariatric or upper GI for a short duration. But the comfort from the robot has been so high for them that now they are exclusively performing robotic surgery. It doesn't matter what surgery they're performing, but the platform now stays robotic. So I think there is a lot of merit in what you said, that robots are here to stay, and usually surgeon satisfaction and comfort is not put at a very high pedestal, at least for lap work right now. But with cervical spine and tendon issues becoming more and more common, I think we really should be looking at the robotic platform for ourselves more as time progresses.
So I'm very clear, that this is first mover advantage. I think you'll start learning early in your career as a young guy. And I'm now old man compared to you guys. But this is very, very important that as a department or as a hospital that has complex GI work, I want my youngsters, Prasad, Nitish Jawar, Vishakha, all to be robotic trained by the time they come out. This is very, very important. I think if the cameraman can just show my hands, there is hardly any strain on the neck or the shoulder at all. It's actually very, very easy. Can somebody check if the PPH is getting ready next door so they can?
So one question, do you have a hand clutch just in case, your actual hands move a little too far away for comfort? Can you like realign yourself like in the Da Vinci Excel?
Very much, very much. We have a clutch, which I'm using right now. So I'm doing a bipolar for the artery. I heard a lot of discussion about clip versus artery. My own feeling is if you have a small size artery like this, I'm very happy to just bipolar it. I'm now going to ask Prasad to disengage his grasper and just cut that for me. I don't want to waste time in changing. Prasad, release your instrument, put in a scissor and cut that for me. I'm not going to waste time on putting another instrument. The other beauty of the CMR is that irrespective of the number of cases you use, the cost of the, just wait. The cost per patient remains the same. We don't have to pay more just because, be careful, be careful. Oh, shit. Shit. Come back. Hold the fundus again, please, quickly. Hold the fundus again, please. So good that you see this. You'll learn how to control, like Samir showed you early. Good bite and push up. Doesn't matter. You'll get it. So okay, get a suction in. So I think the youngsters in the audience need to realize is that no blind, 1 minute, no blind cautery in the callows. Everything is always under vision, and do not use any monopolar cautery. So Prasad is doing the suction on the callows triangle. So we have reasonable control. I think somebody who said, who mentioned that always clips the cystic artery will now be smiling now, saying that, see, I told these guys and they didn't listen to me. Suck nicely in that cystic duct area. Cystic duct area, Prasad. Very nice. A little bit more suction, that's fine.
We're
So
still
I'm gonna
having
get-
some issues with an echo. Is there a feedback speaker that is also on in the OT at the same time? Maybe switching that off could help.
So external speaker, Dinesh, कुछ है क्या आपने पास?
Or reduce the volume, maybe something, because we are
Okay, we'll
losing
get Dinesh
clarity.
Pal to do this.
Sir, let me check that if any mic is on.
Dr. Roy, sir.
Yes, Nishit bhai.
Nishit here from audience. Actually, in the audience, your voice is very good.
Okay.
As far as the ergonomics are concerned, you say that your hand, wrist movement, all that can understand. What about your back, lower back?
I'm sitting on comfortably on a chair, Nishit bhai.
Okay.
Can the camera show them how I'm sitting? In the years to come, I think I'll have CNBC also playing in the background during market hours at least. But right now, actually, I'm inside the OT. I'm sitting on a simple chair. Nothing special about it.
Okay. Do you lean forward sometimes during the operation or that?
Not at all. I think I'm actually sitting quite comfortably against a chair right now. Maybe sometimes when you're doing rectum and you're doing anastomosis, you tend to bend forwards unconsciously. But the robotic people will tell you that you don't want to do that. The idea of doing this is surgeon comfort should be paramount.
I think that is the difference between varices and intuitive. For that, you have to go inside the console and you have to bend forward. While in this system, you just sit straight and you can perform it.
Actually, let me request Dinesh to just show you with the external camera how I'm sitting. He's showing. Can you see how I'm sitting?
Yeah, we can see that. Yes, yes.
Yeah, I've just got my 3D glasses on and I'm sitting quite comfortably. The other big advantage is, see, we have 6 fellows in our department. For them to train on this is very easy. They just wear a pair of glasses and sit next to me. In intuitive, the surgeon has got his hands inside, and unless you buy a additional teaching port which costs 65 lakh rupees, nobody else in the among your fellows can understand what's happening. So this is very, also to me, it is an affordable robot. To be honest, I'm not a rich man like Ankur Patel or like Kalpesh Jani. So I need to have a technology that is affordable to me and my patients. Any questions about the robot? Otherwise, anybody in the audience would like to ask anything?
In a robotic, any change in the step as we do in a routine lab cholecystectomy? Here you
Any
are
change in
not
what, sir?
using as
No, sir, the
routine we
steps
do.
remain same. The critical view of safety, everything remains same, except that
Okay.
I'm minimizing the changing of instruments. Actually, in the
that-
early part, we were using a hook also, but now I've decided that I usually am used to using a monopolar Maryland when I used to do lap calls, and I'm doing exactly the same here now, sir.
Okay.
Can you appreciate the window I've got, sir?
Yes, yes.
I've got a reasonably large window. Now I'm going to ask Prasad to release his grasper and to put a clip on this for me. Prasad, go slow, take your time. 300.
Here we can see with the tissue grasper,
Yes,
there
sir.
is a frequent tear in the gallbladder. With the grasper forceps,
Yes, sir. other side.
there is a tear in the gallbladder seroja.
क्या हो रहा है सर? Okay. Okay, wait. This is better? Sir, I think it's horse, be careful taking the momentum, Prasad. Yeah. Fire. So I think it's how you do it, as I think earlier on Samir said, it's one more clip. It's how you do it rather than blaming the instrument, sir.
Yes. So any type of instrument is not available in this case, all type of instruments are available.
Come again, sir. I missed that. What are the questions, sir?
Any hook type of instrument in a robot is available?
So most routine instruments are available. They currently don't have a harmonic in this. So I need a good assistant like Prasad to help me with a harmonic. But I believe in January, they're going to introduce a harmonic and a ligature in this. That will make my life even simpler.
In the OT, same, not outside the OT. So is it a little unnerving to be doing these procedures, staying several feet away from the patient, not washed up?
Not really.
I'm
I
just
never
asking,
found that.
like,
Never found that actually, to be honest. I'm
Right,
actually in the
so-
OT.
Here clip is applied by a robotic hand or it is applied by some assistant?
assistant as
Hello?
Yeah, tell me.
Yes, this clip is applied by some assistant surgeon or it is
Yes, sir,
applied
we
by.
are actually doing a better job than the robot at present. The robot doesn't have a clip applicator, so Prasad is putting the clip for me. So I'm
Okay.
currently using 3 instruments.
Okay.
एक मिनट रुक जा. Go. Cut.
This is also done by assistant.
This suction कर ले एक बार. I'm just going to ask Prasad to suck. So you need a good assistant through this. I see Samir, so I have some heavy weights behind me. Dr. Mahadev Gawale, Samir Rege. You know, in Marathi, there is a saying, "Biu nokos mi tuja patishi hai." Means when you have such people behind you, you are never scared during a workshop. Abhi hook laga do. Now I want the instruments RSD. So now what I need to do is withdraw my instruments back. I need to change my Maryland. So I straighten out the Maryland. I bring both instruments under vision. Using my clutch, I'm going to move the instrument backwards. So I'm using the clutch like Dr. AM mentioned to bring my instruments back. I straighten the right instrument and then he's going to remove. I want the camera to see the instrument change now. So what Prashant is doing for me, Brother Prashant, is to replacing the right bipolar Maryland with a hook. And you will see that this whole process will take 3-4 minutes. You know, my biggest scare, which put me off robotics, number 1 was the cost. And number 2 was the time, because in a day we used to have 15-16 cases. So see, the hook is already ready.
Yeah.
Now I'm going to shift to the coagulating with the hook and I'm ready to go. So actually it took me about 2 minutes to shift this. And this is despite we being fairly new to this. I'm blessed to have good assistants with Prasad, Ajit, Prashant, all helping and Rohit standing behind. But these guys make my life very, very simple. Do you have a picture from the other OT? Can somebody check if the PPH is ready? Because this will be over in a few minutes. We'll go 2 screens now. Yes, please. Dinesh, can you shift to 2 screens?
So is it possible to have all working instruments on one side of the camera and with this system?
We
You
have
can if
lost
you
the video.
You lost the video. So do you have 2 screens now, please?
Yeah, we have you back. Is it possible to have sectorized instruments with the system?
Yeah, so we did a robotic prostate with a urology colleague of mine. We've done 2 prostates so far, and there you have ipsilateral ports. Our next step is to do a lateral hernia Zehem. And we are just working on how to place a port. Like I said, we are still in the learning curve. You know, I'm like a small child with a new toy. I like to try new things, do new things, and we are in the process of doing this now. So we have started doing ventral hernias. So we are still in the learning curve, but you know, we're getting better at it.
So, so that's a fully sutured IPOM plus?
Soon you'll see me doing ETEPs also, God willing.
All right.
IPOM Plus is a definitely a learning curve, but I thought the TAM would be a easy process because suturing with this robot is actually very, very simple. And I think really what works for this is when you're dissecting deep in the pelvis or when you're doing suturing.
Yeah.
Absolutely.
I think the TAP, routinely what we're doing now is suturing of TAP peritoneums. And I think just day before yesterday, Vishaka did a TAP in 45 minutes using the robotic arm because the suturing of the peritoneum is simple. Suturing the mesh,
Hello.
suturing the peritoneum is very, very simple.
Hello. थोड़ा ये दो आगे
Yes,
दो।
sir. We are shifting the audio in next OT, sir.
Okay.
Hello. Am
Yeah,
I
we have
audible there?
We have video from the second OT. There's a perineal
Right.
case that's been going on.
Okay, fine. So can you see, can you hear me?
Yes.
Yeah.
Yes.
All right. See, I'm Dr. Jhavar. I'll be showing MIPH, that is the stapler hemorrhoidectomy. He's a 65-year-old gentleman who presented to us with anemia. His hemoglobin on admission was 3 and he was bleeding from hemorrhoids. We have done colonoscopy, which has come normal other than the hemorrhoids, which we were seeing here. And in the meantime, when you were watching robotic surgery, we have already fixed the circular anal dilator inside. And the important thing to remember when you are putting this inside is to avoid letting any hematoma or congestion forming in this area. You can see quite a bit of prolapse which is coming in the way here. Usually I start operating from a 9 o'clock position because for a right-handed surgeon from 9 to 12 o'clock is the area which is relatively difficult. So we start our suturing on this side. It's better to fix the one end of the suture on one side of the patient, usually on the right, if you are starting from 9, and then using your exit point as the entry point for the next suturing. Is it clear? Can you see? You have a good inside view there?
Yes, yes.
Would it be
Okay,
possible to
fine.
zoom in slightly more with the camera?
Yeah, Urvin is the one who is holding the camera. I'll ask him to do that. Fine. So every single time when we are readjusting this purse string anoscope, we need to completely come out and then push it back. A good technique is to avoid relying too much on the stay sutures which you have taken. My assistant, Dr. Vineet, he'll be holding the circular anal dilator all the time in position. So we are not actually trusting the sutures which we have taken on this side. Every single time he comes out and then pushes it back, I'm using the exit point as the entry point again. So we are almost reaching on the 3 o'clock side, and that is where we need to take a belt loop. Now, usually if you have a large hemorrhoid like this, it's a good idea to take a belt loop even before you finish the purse string. Sometimes we finish this purse string suture first and then take a belt loop. So here what I'm going to do is I'll use this loop. Give me a scissor. And we have divided this double-ended suture at 2/3 and 1/3. So the other remaining part, that remaining 1/3 of it, I'm using to make a loop here. So this particular loop we will fix on the other side. And once you pull the purse string suture, which is going on at 9 o'clock, it will give you a belt loop. So you don't have to struggle in cases when you have larger hemorrhoids where you don't have a very good vision above the hemorrhoidal tissue. You can still go ahead and do it. Every single time, just make sure that your needle is not going too much deep inside and causing puckering, one, and you're not locking the suture. So once we do that, now it's a good practice to keep your suture line little low if you have more prolapse of the hemorrhoids. And if the grade are little on a lower side, you can stay little above. So here is where I'm finishing the suture line. You have a good view inside?
Yes, sir, we do.
So it's almost done here. So that is how we finish the purse string
So how
suturing
far
here.
beyond the
I'll just-
dentate line are you?
You want to see that? Can you see? Do you have a good view of the dentate line here? Can you see this white line here? This one.
Can we
the
please make
transition zone?
that image full screen for a little while, please?
Yeah, full screen. Just do that, please.
How much
See,
Yeah, we have
usually
it.
we remain around 4 to 5 centimeter above the dentate line. But in
Yes, it's
cases
visible
where
now.
the prolapse is more, you can remain even 3
3
centimeter above also is good enough. Okay, so once we have finished this, I'll just pack this so that any hematoma formation is avoided till I open the stapler. Give me a stapler, please. So I'm using this Midas 34 from Merrill. You have to, this is one is the with the non-detachable anvil. So we have to open the stapler completely and then plain fast. Right. And you have to go beyond the suture line. So somebody has to hold the circular anal dilator. I'll just go inside and try and go beyond this. Now my assistant has to hold the stapler shaft in such a way that it remains in a particular position. And while tightening, you just need to do this pull and push action. So you don't have to rely solely on the knotting of the suture. This slips, hold it properly. So what we do is if you're pulling at one end, the other one should slide freely. It will achieve two things. One, you are sure that you have not locked the suture inside. Secondly, it will be snug with the shaft of the stapler. Try to keep both the limbs almost of equal length and then throw single knots and guide it with your finger so that you get a nice closure around the shaft or the rod of the stapler. So this is done on one side. Now, fine. So I'm just cutting the needle off here. And then the other side, when we go for the this belt loop, so we have to remember that we have not taken a knot here. So if you pull the only the one end, then this can just completely slip out. And now you won't have a chance to go inside. So what I'm going to do now is just hold it. I'll just thread the suture from both the sides. Usually it goes little oblique. So you need to cross on the other side in order to facilitate this removal of the suture from one side that is on the right of the patient. Hold it, please. And then on the other side, as I said, this side you have to be little careful because we have not tied the knot here. And if you pull only one end, then the whole thing will come out. The next thing what we need to do now is to make a loop here where we keep both the things almost equal. You can put two arteries, two mosquitoes and put some gauze there so that it is little convenient for you to hold and pull. Now this particular position is very important. You need to put your, leave this. You need to put your middle finger in that loop or the bowstring type of thing which you have created. Keep your thumb here and then start closing the stapler. I'm keeping it in the midline, slightly angled towards the sacral hollow, and that's how we go inside. As you keep on closing, you will get a tactile feedback of what kind of a tissue you have got inside this. Sometimes if it closes very easily, that means you have not taken enough tissue. If it is too tight, that means you have taken too much tissue inside. What you have to do is just try and stop in between and go in slowly so that you will remove the fluid which is coming in the tissue, and that will give you a proper closure. The idea is to come in the firing window like this. Do you have a good view of firing window?
Yes. Yes, sir, we do.
Okay, fine. So this is where you will get a perfect B-like thing. That means the closure is coming somewhere around 0.75 millimeters. Yes. So now what we usually follow that once we have closed this, usually wait for around 30 seconds, which is a must in all staplers. But if you are dealing with hemorrhoids, which are quite vascular, you can wait for 1 minute, 1.5 minutes also before you fire this. Secondly, till you have closed it completely, you should not let this traction go. So you see this middle finger, I'm just pulling it throughout when I'm going inside. That will give me some idea about the, the traction which I'm putting on the future donut, right? And as we fix this circular anal dilator, that we do with keeping the end in mind, so that if you have any prolapse which is coming outside, any mucosal prolapse, you need to push it back inside first and then try and fix the circular anal dilator. Okay, so I think we have waited enough. Now there are two ways of firing the stapler. If you want to do it in a sitting position, then I can keep my hand position like this and close this, which will give me the maximum advantage. Usually I prefer doing it in a standing position. So I'll just now leave it now and will fire the stapler. Okay, just give me, sorry. So first I have to open the lock. Vinay just reminded me. And you do it only once. That opening of the lock has to be done once only. You fire in one go. Here for that click, which is the kind of feedback you get when the stapler fires. And afterwards you lock it again. So just be careful that you should not be firing the stapler twice, because if you do that, it will staple only once, but it will cut twice. Now, the second thing which we should keep in mind is when we have fired the stapler and your assistant is holding, you can let go of these sutures which are holding the CAD or circular anal dilator in place, so that when you remove it, it comes out easily. Sometime when you are doing it for large hemorrhoids, even before you tighten the stapler, you can let go of these stitches, so that will achieve little more reduction of the prolapse which comes out in those cases. So these are little modifications which you can make when you are doing this procedure in order to fit the requirement in that particular case. Am I audible there?
Yes, sir, you are.
Yes.
Hello, because it sounds more like a monologue. If there is anybody who has any question, I think I'll be happy to
No,
answer.
but it's a very good monologue.
Okay, fine. Just give me a pause, please. All right. So now, when you open the stapler after you have fired, then you should keep in mind, can you just show it here, Urvin? That we should not open it too much. You open it by 180 and then 270 like this. The other movement which you will do is on sideways to make sure that it has cut and disentangled properly. And then by fishtailing, you can just come out. So come out like a complete assembly like this, wherein the circular anal dilator as well as the mosquitoes which are holding the suture or purse string comes out, and then you examine the donut. So before removing the donut, you should check it without changing the orientation. So there, like I said, we get a feedback when we open these staplers or fire these staplers. So this is the plastic ring kind thing which breaks. You have to remove this, hold it at 12 o'clock, take it out and see it all around. So usually the donut has to be almost equal on all sides, one. And if there is any deficiency at one particular area, if you're holding it at one place, you will actually know whether it is.
Very excellent and complete donut.
Thank you so much. So now, when we have seen the donut, if suppose there is a discontinuity or you find the donut is thin at places, then you can go back and resuture that area by taking a figure of 8 sutures. Now, all of us know that there is some limitation of these this particular technique where we are not doing much to the external component. So you may have the skin tags like this or like this, which can create problem later on in terms of patient's dissatisfaction. He may come back and tell you that my piles are still the same. That is one. Secondly, after firing the stapler, sometimes you may get this swelling of these skin tags, which we call as splicoma. So if you want to avoid these problems, you can actually remove them. And before you do that, you should talk to your patients before taking them up for surgery, that this is not going to be a completely painless one. Some pain is going to be there. There will be some wound, and this kind of a thing he should be accepting. After
Dr.
we have
Jawar,
fired
what are
the
your-
stapler. Sorry?
Dr. Jawar, what are your strategies to minimize pain after PPH?
So the first thing is that we should keep the suture line much above the dentate line. That is the bottom line. If you come down too much towards the dentate line, the patient is going to have a lot of pain. That is
Literally
one.
the bottom
Secondly,
line.
we can give, secondly, we can give pudendal blocks to these patients to achieve a pain relief after this particular procedure. We have tried giving methylene blue also mixed with local anesthetic, and which gives a lasting effect in control of pain. And if we don't cut too much outside in terms of cutting the skin tags and all, then again the pain can be minimized. And the suture line should not be too deep also.
How much of methylene blue do you use, and what is the logic behind that?
See, it prolongs the effect of this thing, local anesthetic, which we use. So we mix it with locks 2% and then inject all around in a circumferential manner, and that gives a longer effect, pain relief in post-op.
Now, what
I
you
know
are
you-
doing, sir?
I know
Right,
you
so
also,
right now, sorry, sir, I interrupted, please.
I know that you also do a lot of laser surgery for piles. How do you compare these two techniques?
So it depends on the indications. So usually if there is a circumferential hemorrhoid, I would prefer doing a stapler. And if it is an isolated one, 2nd degree, or even isolated 3rd degree, then I prefer laser hemorrhoidoplasty. Laser in a circumferential hemorrhoid is not a very good idea. But nowadays, we get a lot of patients who are very demanding. They want laser only, and they, even if you tell them that stapler is good for you, they will still not agree. Then we can do that Chivtase procedure or transanal rectopexy to take care of the problem circumferentially. And the bigger hemorrhoids we can treat with laser. Show me this. So what I am doing right now is one, reinforcing the stapler line, and the similar thing we can do for the bleeding points. If you see that any of the staple line is bleeding, you can take this figure of 8 stitch. So the first stitch has to go above the staple line and the second one should go below.
Isthmus, post-operatively?
Was not really, but you know, that's we know that 3, 7 and 11 o'clock position is the one where we get this superior hemorrhoidal artery branches. So you can reinforce that. And if there is a bleeding point, like I said, you can do it. Sometimes I add this with something called as RAR. Even after you have done a good job, you may feel that one of the hemorrhoid is prolapsing a bit too much. Then you can take an anchoring stitch above the staple line, and then you take superficial stitches on the hemorrhoidal tissue, come up to the dentate line and plicate the whole thing. So you can slide the hemorrhoidal tissue inside, and that will give immediate relief to the patient. Because even if you don't do, after a period of say 4 to 6 weeks, the whole thing can subside. But then for this particular period, the patient will keep on feeling that the piles is still coming out, and that, you know, beats the purpose. So these kind of modification you can do. And generally, either we do it at 4 quadrants or at 3, 7 and 11 o'clock position, and wherever it is bleeding from. One more important thing is you have to look for bleeding carefully. Don't feel that it is just a small bleed. I'll keep a pack and this will subside. In whatever studies they have done so far, they have found that the complications of stapler hemorrhoidectomy are much more sinister as compared to open or a closed hemorrhoidectomy. So you should have little paranoia about controlling bleeding, which is one of the complication. And after you go in, say after 2 or 3 days, sometimes it is very difficult to find the area from where it is bleeding. So whatever best you.
What is the protocol post-operative for this patient? How will you manage?
So these patients, usually we either put a very small pack or we are using those commercially available packs like Sponstons and all. They come out with the first passage of stool. You really don't have to remove it. If you are putting a gauze pack or something like that, then just keep a stitch attached to this, and within 4 hours that should be removed. Because once you keep the pack inside for a long time, the patient will keep on getting this tenesmus and they unnecessarily strain, which can cause bleeding.
What are the complications of the stapler? In sake of the audience.
All right. So the complications of the stapler, like one is pain. The second one, you can have you can have a urinary retention problem in these patients because most of these patients are done under a spinal anesthesia. If there is a pre-existing problem, then they can have this problem. Or if there is too much pain, then again, they will have the same issues with cortisol. Urinary retention.
Some young patients tend to get tenesmus and persistent pain after PPH. How do you treat these patients and what do you think is the cause?
So generally, if there is a rectal pocket syndrome, like if we have taken these stitches in such a way that there may be some stools entrapment in those small pockets, they can present with excruciating pain while passing motion. That is one. And this can be tackled by doing a perrectal examination and opening those small pockets of pus. Many a times you can do it in OPD while examining, and that should do the trick. If there is a problem with the tenesmus, usually, this increased frequency of motion, that usually goes down by the end of 4 weeks. Because when we do this, we are actually removing the transitional zone, which is the feedback mechanism for a defecation reflex. Usually patients, they get used to this at the end of 4 to 6 weeks. The kind of self-limiting, but at the same time, you need to give them a stool softener, Schwarzschild bath, and some reassurance. And usually it gets better with time.
Is there any role of agrapectomy?
Agrapectomy, we will do only if there is a stricture and you find it convincingly that this is at the suture line, and you can take that particular previous staple line in the next stapler and remove that. And agrapectomy can be done for this indication also, what we were talking about. Yeah.
Yes, I agree with you.
Fine. Tooth milega to अच्छा है. वो tooth. Fine. Any other question from the audience?
Any questions?
Regarding Lawrence bleeding from the 7 and 11 o'clock after firing, how do you take the bleeding?
Sure. Gauze.
Way of taking bleeding?
Not
There is
audible.
there is a question
Yes, sir.
from the audience. If after doing stapling, there is
Yes.
a bleeding from the suture line,
Yes,
staple line.
right.
So how will you manage that bleeding
So
from the?
like you saw me doing one thing, then even after I had a
Hello.
you have to take the similar suture which I took, either take a 2-0 Vicryl, which we usually use. Sometimes if you have very congested hemorrhoids, you can use a 3-0 also, because it bleeds from the needle prick site also. So take a figure of 8 suture. The first bite should be above the staple line. The other one should be below the staple line. And once you tighten this, most of this bleeding will stop.
And in all cases, you are taking reinforcing stitches after doing
Yes, we always do it. If you see the original description of this particular procedure, there is no mention of a belt loop. There is no mention of reinforcing sutures like we take, but we have seen in our patients that we get very good post-operative relief and we sleep better. So that's why we follow this particular standard technique in our hospital.
Okay. Dr. Jawar, this is Dr. Bhatt from audience. Wanted to know your comments on incomplete donut and how much depth you take while you are taking your bursting suture.
Right. So see, if you look at the depth of the suturing, it should be mucosa and submucosa. It should not go very deep. So while taking sutures, if you feel that there is a lot of, grit kind of a sensation which you are getting when you are doing this, and there is puckering of the suture line. So every time you saw me taking sutures, when I take it out, I usually pull it. So if you are only mucosa and submucosa deep, you will see a ridge-like thing raising from the muscular wall, if I may say. But if you have gone deep, then this will not be seen like that, and there will be puckering. So avoid that. That is one. Secondly, if you get an incomplete donut, like I told you, after you have fired the stapler, don't change the orientation of the donut. Look for the incompleteness, whether it is at 3 o'clock, 6 o'clock, or wherever, and therein you go in again, look for the staple line. If you still see that there is a staple line there, sometimes it may not cut, but it can staple that area. Then you go and reinforce it with figure of 8 stitches like I showed you. Even if there is no staple or at one place it is missing, you can reinforce that by using the similar technique. You do figure of 8 multiple sutures in that area. Avoid taking a continuous suture. Otherwise, that will cause puckering and shortening of the opening. Does that answer your question?
Yes, sir. And any precaution in elderly females with the lax vaginal vault or something, where we are always afraid of anterior wall taking stitch with the
Taking it,
posterior
yes.
vagina. Yeah. So
So,
what
right.
kind of precautions to be taken for
So
that?
usually once you have finished taking your pustering suture, you should put in a Sims speculum inside and try to lift the vaginal mucosa off the rectal wall or the posterior wall. If you are able to lift it, that means you have not taken it inside. If you see that it is hinged or puckered, then you should do your pustering again. So there is no point packing the vagina and thinking that, you know, this will help you take the anal mucosa properly. That is counterproductive. That should not be done. One. And secondly, if you find that you have taken the vaginal mucosa by mistake, you redo your pustering. There is no corrective measure as such. But and afterwards, once you close the stapler, again you go inside, and when you are tilting the stapler side by side, there should not be any puckering or pull on the vaginal posterior vaginal wall. These are the two things which we can do to make sure that we have not taken the vaginal wall in the staple line.
Excellent, and congratulations.
Thank you so much.
Very well done, sir.
Thanks a lot.
That marks the end of this second session. I would like to thank our faculties on the stage for conduction of this excellent session. Kindly collect your token on your way down. There is an important announcement about Proctocon 2022 to be held next month on 13th November at BJ Medical College, Ahmedabad. It will be an surgical feast on colorectal surgeries organized by Ahmedabad Association of Surgeons, Gujarat State Chapter of Association of Surgeons of India, in collaboration with Association of Colorectal Surgeons of India and Association of Surgeons of India, to be held on 13th November. Registrations open.
In the meantime, when we are getting the other theater ready, if there is any, there are any questions, I'll be happy to answer.
Hello, sir, do you advise post-op anal dilatation?
No, that should not be done. See, if you do anal dilatation after firing the staple, then the stapler line will break and that will create problem. I don't think that's a good idea to do. The dilatation in this cases should be controlled one, which we do by putting in that obturator, that white colored obturator, which we put the first thing inside before firing the stapler or introducing the circular anal dilator rather.
Yes.
Sir, sometime while taking pursing suture, there is submucosal hematomas in there. How to
Right. Yes. So at the moment you feel that there is a hematoma, you stop proceeding further, put pressure on that, wait for a good 2 minutes till that hematoma subsides, and then only go ahead and finish your pursing. Because if you let this hematoma expand, even if you get a complete donut, it will contain only mucosa in it. And later on, it will not correct the piles, one, and secondly, there is a good chance of bleeding. So hematoma has to be controlled then and there. Either you can do it by using a gauze piece to put pressure on this, or just rotate the pursing endoscope in such a way that the curve comes to lie against the hematoma, and in 2 minutes time, that will subside.
Other question, sir. Is there any specific indication for 2-row or 3-row stapler?
Right. So see, if you are doing you have seen me doing a 2-row stapler, and this is the patient who had come to us with anemia and a lot of bleeding, but still the donut has come out well. The 3-row will have 48 staples in comparison to 32. So you get a better hemostasis. Other than that, there is no other advantage. So if you feel that the mucosa is very fragile and you fear the bleeding afterwards, it's a good option to use a 3-row. But otherwise, it will not make much of a difference as far as the outcome is concerned.
Sir, any ergonomic consideration while you are firing a stapler, your lie and your axis, how it should be before firing the stapler? Because usually patients are head low position or they are given some other positions. So any specific tips on that?
Right. So head low position actually is the most ergonomic way of doing a stapling, in such a way that the tip of the staple is going towards the halo of the sacrum. So that is in alignment with the normal curvature of the rectum. So that helps, and you should remain in the midline. It should not go haywire on one or the other side. So your assistant should be supporting the stapler in such a way that the weight of the stapler is not in your hands. So that usually helps you get full mechanical advantage to fire the stapler rather than, directing and deflecting the tip of the stapler in such a way.
What happens to these staplers later, Dr. Jawar, in the long term?
So they usually fall off on their own. So we don't have to actually remove it unless they are becoming a cause of pain. Sometimes when you do a rectal examination in postoperative period, the patient may come with bleeding or may come with pain, and you do a rectal examination, you find a loose staple, you can remove it in your OPD only.
I see Kaushik Bhai sitting in the front row. Kaushik Bhai, good morning. What are your indications of doing the STAR operation today? I think many people for very large piles and constipation use STAR. What is your take on this?
I think the STAR procedure should not be done for large hemorrhoids. That is reserved for people who have got a single compartment prolapse. I mean the ODS, like in male patients, wherein only the rectorectal intussusception or rectoanal intussusception is a problem. There we can do STAR, or we can do it for the mucosal prolapse only. But for large hemorrhoids, we should refrain from doing this because there is no added benefit and it can further add to the misery of the patient.
So when you're doing this hemorrhoids procedures like laser combination or something, do you use hybrid method anytime with laser with stapler or like laser with open technique together?
Yes, so laser with stapler we never use. Either we do a Chiftes procedure, that is the transanal suture rectopexy, or we are doing a finger guided hemorrhoidal arterial ligation with laser. Or sometimes if it is a very large hemorrhoid and if you can talk to your patients at one particular area, you can do excision and rest of the things you can do laser. So those combinations are possible. We are doing these hybrid procedures now because our patients, they demand laser even when we try to explain them that this is not the correct indication for doing a laser.
So what you're saying is standalone laser should not be done for third degree hemorrhoids. Is that correct?
Yes, should not be done at all. I mean, for third degree, no. Second degree isolated, we can still do.
And what about fistulas? I think we are going to see Dr. Niranjan Agarwal showing you a complex transsphincteric fistula next in this OT. In the other OT, our patient of achalasia cardia is being induced. What I'm going to do is show you a cardiomyotomy, door fundoplication, and intra-op endoscopy, while Dr. Niranjan shows you a transsphincteric fistula. There's a lot of hype about laser fistulas.
Right.
What is your take as a colorectal surgeon? What is your take on this?
So in fistulas, we get my mic proper? No. Just take it. Mask. Right. Sorry. So in fistulas, usually if we are doing a transsphincteric one, then we can combine it with lift or slough. If we are doing only laser procedure for fistulas, just by ablating the tract and hoping for it to heal, usually that doesn't work. So we have to always combine a fistula surgery with some kind of additional procedure. So like I said, either you do a slough or you do a lift. My preferred technique is to do a lift surgery wherein we disconnect the tract in the intersphincteric groove and then ablate the internal as well as the external opening using a laser fiber. So that
Sometimes you can
gets
do
to
a coring up to the sphincter and the distal long tract, say pinoscrotal tract, that you
Right.
can just burn with a laser.
Right. So if it is a long tract, then again laser works very well, but we need to make small holes in between in order to provide the drainage of the debris which is collected in that area. After you have fired the stapler, a lot of this granulation tissue will come out. So you should provide some passage for it to come out. So if there is a 15 centimeter long tract, it will definitely not drain and it will cause separation again. So we can make small, the punches in the tract wherein we provide enough drainage. So that gives a very good result. Usually if we are using it for a long fistula anteriorly, we are saving the sphincter as well as we are treating the fistula in a very good way.
And finally, for pyeloneal sinus, in fact, my preferred surgery for pyeloneal sinus today is standalone fistula, standalone laser. I
Right,
think I
sir.
find laser excellent for pyeloneal sinus.
Yes, I agree with this.
What
Yeah.
is your, how do you actually do this and what is your logic behind it?
See, in pyeloneal sinus, usually, if it is a mature sinus, usually the laser gives a very good result. So laser in pyeloneal sinus today gives very good result because we can actually delineate the tract completely, and if we can do a laser, then usually they heal very well. And if you compare a laser procedure with a flap surgery, then the difference between the two is vast. One procedure you are doing under local anesthesia, and we don't have to cut too much. We are not dependent on the healing of the flap tissue. And if at all the laser fails, you can actually repeat that in your OPD setting only.
Dr. Sanjay Jain, good morning and welcome. Nice to see you in the front.
Hello.
Front row, sir. Yes, Pankaj bhai.
Hello.
Pankaj
So
bhai,
we conclude this session.
sir.
Before starting a new session, I request all of you to register for Proctocon, which is on a 13th November, a workshop at BJ Medical College and Civil Hospital. The counter is at the start of the stalls. So please get registered. It will be a good feast, only workshop, no lectures, 9 to 2 or 3, however long it will run. Please, thank you.
Good morning, Roy. Nice to
Sir.
see you also.
Thank you, sir. Good to see you. I missed meeting you in Goa for various reasons, but
Yes, yes.
nice to see you, and I hope to see you soon at ASICON Mumbai. Also want to request everyone in the audience to register for ASICON Mumbai. This will be a special feast, excellent workshop, great hospitality, and I'm just going to invite Dr. Niranjan Agarwal, who is the organizing secretary of ASICON, to come in to welcome all of you officially.
Moving on to the next.
Dr. Niranjan Jain, who is organizing secretary of Niranjan Agarwal. Sanjay Jain is in the audience, so I'm confusing you, two big men together.
Both the big men have one thing in common, that is you are their friend, you know. So good morning, everyone. I hope all of you are having a great time over there. I take this opportunity before I commence my case to invite all of you for the ASICON 2022 at Mumbai. We have got so much at Mumbai this time for all of you. We've got the live operative workshop where surgeons are going to demonstrate from their own centers at their own places to the venue. We've got, apart from the 13 orations designated in the CME program, multiple panel discussions. We've got around 8 international faculties coming down. And we have got special programs for the nurses, for the entrepreneur among us, for the hospital management system, and a separate hall dedicated only for innovation. So any one of you who want to present your innovations also are welcome to submit your work to the organizing committee. Mumbai at December between 21st to 24th is quite pleasant to be along with, and there is so much more which we will be offering you. So please join us at Mumbai. Do come. We are all waiting with our folded hands to welcome you. Thank you.
Moving on to the next segment, we would be having the live telecast of laparoscopic Meeson's fund application and fistulectomy. For this session, I would like to invite Dr. Kaushik Gajjar, Consultant General Surgeon at Path Hospital, Ahmedabad, with over more than 40 years of experience and Governing Council member of Association of Surgeons of India. Dr. Kaushik Shah, Chairman and Consultant, Trauma Laparoscopic and GI Surgeon at Panchsheel Hospital, Sabarmati, Ahmedabad. Treasurer of Gujarat State Chapter of Association of Surgeons of India. Dr. Shashank Desai, Professor and Head of Department, General Surgery at GCS Medical College, Ahmedabad. Dr. Rashmi Thakkar, Consultant Surgical Gastroenterologist and Laparoscopic Surgeon at Jalaram Hospital, Ahmedabad.
Good morning, everybody. I'm very happy to be part of this excellent conference. I request two things to all the delegates. First, become a member of ASI, and those who are member of ASI, kindly vote for the ongoing Vice President election. Today, I welcome our distinguished two guests, Dr. Sanjay Jain, who is a Vice President and incoming President of ASI, and Dr. Bhamar Yadav, who is a Treasurer of ASI. We continue with our workshop, and I would also like to congratulate Dr. Roy. Dr. Roy, sir. Hello. Dr. Roy has just recovered from his bypass surgery, and he is in the field going for 4s and 6s.
No. Thank you very much. Kaushik bhai, nice to see you again.
Yes.
But missing being here, Ananta, with all of you, and missed all the live Garba scene yesterday.
I saw
Yeah.
some beautiful videos and photos, but hopefully you'll call me next year again. I'll participate in the Garva next year.
Inam participate, and we are meeting soon in Bombay. Right?
Indeed, I look forward to welcoming all of you at ASICON Mumbai. Please register, as Kaushik Bhai said, become ASI members and also come to ASICON. It will be a
Yes.
special feast, which we'd like all of you to come. And also become social security members. With the boss sitting on the dais, I can't say anything. I have to say that.
Good morning, Roy. I am Dr. Kaushik
Morning,
Shah.
sir.
Yes, sir.
Yes, sir.
Roy, thank you very much for our members to be a member of the ASI Social Security Scheme. I think everybody is knowing about the Social Security schemes, and my request as a secretary of the ASI Social Security Scheme, I request to be a member of the Social Security Scheme because it is a very extraordinary scheme, which is you compare with the other schemes of the other association. This is the most beneficial scheme. So I request all the members to be a member of the ASI Social Security Scheme. Thank you.
It is the cheapest scheme in the insurance aura. Please start, sir. What are the cases?
So the next case we are showing you is achalasia cardia. This is a type 2 achalasia. Focus karo isme. You see a typical narrowing of the esophagus. She is a young lady, 35 years old, has previously had one episode of endoscopic dilatation done, as she was earlier not willing for surgery, and she got a recurrence within 7 months of dilatation. So today we are planning to do a laparoscopic cardiomyotomy, a door fundoplication, and an intra-op endoscopy to confirm the completeness of the myotomy. She has a type 2 achalasia on manometry. It's our policy to do an endoscopy, a manometry, as well as a barium swallow in all patients. And an important learning tip for the youngsters in the audience is why do a manometry before achalasia surgery is there is a Chicago classification type 1, type 2, type 3, looking at the LES pressures and the body pressurization. A type 3 achalasia, which is a pan-pressurized body or esophagus, you must do a longer myotomy. And this myotomy must be 3 centimeters on the stomach and 7 centimeters on the esophagus. So the manometry is helpful, and if you know, the highest chance of recurrences after surgery is in type 3. So in type 3, we need to do a longer myotomy. So this is a patient with a type 2 achalasia. In our center, we do all 3. We do balloon dilatation, we do POEMs, as well as cardiomyotomy. Obviously, I think my choice is to do a laparoscopic cardiomyotomy because it is cheaper, it is more long-lasting, and to me, it still remains the gold standard. But we still get patients who insist on endoscopic POEM, which we perform. But to be honest, almost 10 to 12% of patients get quite significant reflux after POEM, which is one of the main drawbacks of POEM. Would any of the moderators or anybody in the audience want to comment about the type of procedure chosen for achalasia?
Rashmi?
I think we normally do, we prefer to do laparoscopic surgery in front of POEM, as you already mentioned that POEM has a lot of reflux problem. And generally we prefer doors fundoplication in this type of cases.
So also in our center, the POEM costs almost 40,000-50,000 more than a laparoscopic cardiomyotomy, because here you require only 2 ethibond sutures and nothing else. So the cost of a Hellers with a door is very low. We can do it at any cost in general ward. While POEM, you need the clips, you need the Irby knife, you need a lot of for this.
Yeah, just for the benefit of audience, can you differentiate out the type 1, 2, and 3?
Yes, sir. The type 2 achalasia, which this lady has a normotensive LES, and it is the best candidate. And they do well either with POEM or a Hellers. And in her, what I'm planning is a 6 centimeter esophageal myotomy and a 2 centimeter myotomy. So for the postgraduates, most time failures of surgery are because of inadequate myotomy on the stomach side. The esophageal side, everybody does well. The second point I need to mention is that to me, an intraoperative gastroscopy is a must for 2 or 3 reasons. One is to confirm the completeness of myotomy. Number 2, to look for leaks. So because what our protocol is we'll remove the nasogastric tube on table, feed the patient in 4 hours and discharge in 24 hours.
We don't put drains, we don't do dye studies, and you can be sure that the patient has no micro leaks by doing this. If you don't have access to an endoscopy, then you can put a clamp on the OG junction and ask the anesthetist to put air through the right tube to look for small micro perforations. But a small perforation of the esophagus has very high morbidity, and it is something that you should actively look for on table.
And what do you mean by complete myotomy on stomach side?
So what I have seen is first is you need to identify the OG junction. And the way of identifying it is not only the angle of his, is once you start extending the myotomy in the stomach, I will show you that you start seeing oblique muscle fibers. In the esophagus, you have only the longitudinal and circular muscle fibers. In the stomach, you have oblique muscle fibers. And the third thing that you see is you see a lot of submucous vessels crossing. These are two ways of knowing that you've entered the stomach. And here, the myotomy must be at least 3 centimeters below the OG junction to ensure that the myotomy is complete.
3 centimeters, you say?
Yes, sir. For a type 3 achalasia, 3 centimeters. In a type 2 achalasia, 2 centimeters.
Okay.
So most failures are because of inadequate gastric myotomy, not esophageal myotomy. Now, in patients like this, who have had dilate, we have done patients who even had 5 or 7 dilatations. We don't find the myotomy in the esophagus to be very difficult, because the difficulty in myotomy is those patients who had a Botox injection. And there was one gastroenterologist in Mumbai who was doing a lot of Botox in, I think, between 2010 and 2014. And that causes extensive submucous fibrosis and makes life very, very difficult for the surgeon. So be beware of surgeons who patients who had a Botox injection. Dilatation, I'm not worried. We have now done 7 patients who have failed POEMs. And after POEM also, if you go in a different quadrant, you can easily do a myotomy without difficulty.
Which type of fundoplication do you prefer, Dr. Roy? Is it tope or?
Sir, in our hospital, we routinely do a door because we
Why
find
not
that the
tope?
door is, the dupes I don't like for a achalasia.
SF microperforation. SF microperforation, why not tope? Because tope has got good results.
So the tupes is a posterior fundoplication. It actually leaves the anterior part of the mucosa open.
It
In a
has got
door, it's like,
it has got lowest recurrence rate.
not true, sir. The tupes and door in all series are about the same. The tupes is a marginally better anti-reflux property compared to door, but the door closes off the mucosa. In a tupes, the central mucosal tube remains open. So that is my concern. That is why I prefer a door.
Hello, or this
Yes, sir.
patient is type 2 or type 3 achalasia?
She's a type 2, sir. She's a type
Type
2
2.
achalasia and has had 1 dilatation in the past.
Okay, one way.
So the patient will be kept in a leg split position. I'll stand between the patient's legs and the monitor will be placed above the left shoulder of the patient. I'm working with a Stryker 1688 camera. And the other thing we are doing now is doing a prospective study looking at injecting ICG through the right tube to coat the esophageal mucosa. And the logic is that, can it have a situation where people who don't have access to intraop endoscopy can use ICG? If the brilliant ICG is seen, you know there is no muscle covering it, plus you will see any leak. But so far we have done only 7 patients, and this is a prospective study that we are doing, comparing using ICG versus intraop endoscopy to confirm the completeness of myotomy.
Dr. Roy,
Yes,
in
sir.
your institute, I mean, which patients you subject to endoscopic dilatation, which patients you subject to POEM, and which patients you subject to straightway laparoscopic cardiomyotomy?
So all the elderly patients who are grade 3 or grade 2 ASA, we usually do balloon dilatations, explaining to them that the effect will wear off between 6 months to 2 years. This, we also, otherwise, we always offer cardiomyotomy or door fundoplication to all patients. But sometimes you have patients who have read on the net, who are very convinced and want a POEM done. And we are happy to do that for them, explaining to them that 1, the cost is more, and 2, the reflux is almost 10 to 12% after POEM. We will take a written consent and then do a POEM in our hospital for these patients. The cost is almost 40,000-50,000 more than a cardiomyotomy. The patient is just getting ready, and the other OT will have Niranjan Agarwal showing you a complex high transsphincteric fistula, which he's going to show a coding with sphincter repair.
Okay.
Can we shift to OT2 so that we can have, so
can I
then
have
we
one
can
last
preview,
question?
a little preview of.
Below.
You can have your
Hello.
question. Yeah, yeah.
Sir, my question to Roy, sir. Any
Yes, sir.
situation where you do not add a fundoplication, only you do cardiomyotomy? Any situations like?
I've never in 25 years done a cardiomyotomy without a fundoplication.
Even
See, if you
the
look at
even the
even
patient
my-
is even the patient is very elderly and something called sigmoid esophagus or like that.
No. So in a sigmoid esophagus, I always tell them that you may have a recurrence and land up with a esophagectomy later. But the DOR is not going to cause dysphagia. It's going to prevent reflux. We know from the earlier data when they were doing transthoracic cardiomyotomies that almost 20% patients get volume reflux. And this volume reflux may not be PPI responsive. So I would never have a situation. I have done a achalasia in a 5-year-old. Please quieten down. जरा आवाज कम करो ना भाई. I've done a achalasia from 5 years to 75 years of age, and I can't think of a situation where I wouldn't do a fundoplication with a cardiomyotomy.
Okay.
Because there can be intractable reflux, which is doesn't respond to PPIs. And what is the harm in doing an extra DOR? It'll take me 5 minutes and 5 sutures. Why would you not want to do a DOR?
Right. Till we get the preparation from your OT, can we go to the Dr. Niranjan OT?
Yes, sir. We just walk across the other OT.
If they have started their operation.
बात कर रहा हूँ. चलो audio shift करा सर. Dinesh, can you shift the audio to Dr. Niranjan Agarwal's OT, please?
Yes, sir. Audio is on, sir.
Yes. Good morning, Dr. Niranjan.
Taken. Good morning.
Hello.
Am I being heard?
Niranjan, yes. Good morning, Dr. Niranjan.
Good morning,
Doctor-
sir. Am I being heard?
Dr. Kaushik Shah from Ahmedabad.
Yes, of course, sir. I can see you from here.
Oh, thank you, sir. Thank you.
Good
Can you
morning.
give us some information about this case?
Yeah, so this is a 25-year-old lady. She has been complaining of perianal pain discharge, and she's been on and around the Sion Hospital for perianal fistula. 2-3 MRIs have been done. 2-3 MRI have been done for these patients, but no surgery has been done yet. So earlier there was an abscess which burst. Now she's got an external opening. We'll show you the picture. Can somebody focus here? इधर कोई फोकस करेगा पेशेंट का? इधर फोकस करो तो एक्सटर्नल ओपनिंग वगैरह दिखाते हैं. So as per the MRI, there is an internal opening at 8 o'clock position around 2.3 centimeter above the anal verge. And then there are 3 tracks going from there. One is going towards anteriorly and opening in the 11 o'clock to 12 o'clock position. The other track is going towards the left, opening at the 5 o'clock position. You can see there. And there is a third intersphincteric track which is going toward the supralevator position. So there are 3 tracks coming out of this one particular fistula. I'm going to start this now. I'll just wash up and come back. In the meantime,
Can you, sir, anybody show the MRI?
yeah, 1 minute. Vinit, where is Vinit? जरा MRI का plates दे दो इनको. I just show the picture also. Picture दिखाओ. एक मिनट.
पैसा पेशंट માટે તો સર कुछ
कुठे दिसतोय? इकडे घे कॅमेरा. इकडे घ्या कॅमेरा. हो, इकडे दाखवू.
Thank you, sir. Thank you. Can you explain on the MRI, sir, so that the
Yeah.
audience can appreciate?
Yeah, definitely. चल इधर आ जाओ कोई एक जन. Just hold this. Just hold this. So you can see that there is a internal opening, which is at around 8 o'clock position. From there, one track is going to the right side and the other track going towards the left side. In the coronal picture, also you can see this is going towards the 12 o'clock position. This is going to the 5 o'clock position, and there is a intersphincteric track which is going toward the supralevator position. So this is marked on the picture over here. The MRI actual pictures, we will show them on the screen just now. So Dr. Urve is showing you the MRI pictures, actual pictures there. I'll just wash up in the meantime.
Good.
Is there anyone who can explain the MRI in detail?
Saras.
Any radiologist there who can explain the MRI?
बसायला chair द्या मला. Am I on with you?
Yes.
Okay. So many a time the actual fistula is not that scary. The MRI report is very scary. So it is better you just clinically evaluate that and take MRI as a guiding this thing rather than a Bhagavad Gita. You know, right now, हाथ निकाल. Give me Xylocaine adrenaline. So here you can see only an external opening at 5 o'clock position. Can you appreciate this?
Yes, sir.
Okay. The external opening mentioned at 11 o'clock position, etc., are not seen over here. There is just small puckering at this area where it must have ruptured earlier. Clean करने को दो. Clean करने के लिए दो. तो गीला करके दो.
Clean with the spirit, sir. Betadine will go away.
Yes, yes. Saline दो तो भी चलेगा. I am just injecting some saline adrenaline so that the dissection become a bit bloodless. I am very scary of using the word bloodless, painless, you know. Basically, they all mean less bleeding or less pain. You know, it is never bloodless, which is zero blood. So when people for laser talk, it is painless, woundless, then it scares me a lot. Can you see when I am injecting, there's something coming out
Yes,
from the
yes,
rectum?
coming from the rectum. Yes, sir.
So that means I have pierced the track there. चलो थोड़ा सलाइन दो मेरे को क्लीन करने के लिए. Now it is better visible.
Yes, sir.
Can you
Yes,
see the
sir.
scar here?
Yes, sir. Yes, sir.
Yeah. So there is a scar, but there is no opening. So they may be the tract is just coming there and ending over there. Jelly. So as a dictum, we all थोड़ा head low करने का, please.
Head low.
Most of the time, can you please others don't make noise. This is this. Can you see this puckering over here?
Yes, sir. Yes, sir.
Pus coming out from here also.
Yes.
Most of the time, in fistula, the internal openings are almost always at 6 o'clock position, say whatsoever. Now, this is the 8 o'clock position. I am clinically not able to feel anything. I am only able to feel at the 6 o'clock position. That is the place where majority of the anal glands are positioned. So, the infection because of cryptoglandular tissue invariably will open at 6 o'clock position.
Niranjan sir. Nitish Jhawar here.
Yes, Nitish, chota dena.
Sir, like you mentioned that, you know, MRIs, they look always more scary than the actual picture one. And secondly, unless they draw a picture and show us, it is very difficult to read the MRIs. So what do you
Absolutely.
think? I mean,
if I read this report for you, even I got confused and I
Right.
ultimately only saw the drawing and I, you know. So can you see the internal opening now?
Yes, sir. Yes, sir.
clearly see.
Beautifully seen at the 6 o'clock position.
Yes.
I will now show the 8 o'clock position where you will not see anything. Can you see anything there?
Nothing.
No, no.
Nothing. So now let's use some methylene blue.
Sir, many a times we see these fissulas where external opening is almost closed and you can see only internal one. So do you feel we should inject from inside also and that can give us a clue?
Yeah,
where
you
all
can
this is
inject
going?
from, see, I am just opening the mouth of the external opening, which is temporarily closed. And then from there, I'm going to inject. Otherwise, I would put in an infant feeding tube from inside and then inject.
Yes.
Can you see this going? So
Yeah,
I'm
yeah.
not pushing it. It is just walking inside. I have created the space for the methylene blue to go.
So do
Jera
you
gaal
always
dena, please.
inject methylene blue or you do hydrogen peroxide first and then go with this? So that
I have
guys
stopped
can-
using hydrogen peroxide. I use only a diluted methylene blue, not even a undiluted one. Can you see the internal opening there?
Yes,
Yes, sir. Yes, sir.
Clearly see.
And now let's see if there is any other place where the methylene blue has come out. No, it has not. Correct?
No, only one single track is seen thing.
Yeah, doesn't matter. We'll try and dissect from here. We'll come to know further. Many a time the tracts are fibrous and they all appear as if there are tracts on MRI and they are accordingly reported. But most of the time they are all fibrosed. So you don't really have to do anything for the fibrous tract because that nature has already done its job over there.
And sir, this particular internal opening is almost subcutaneous. So do you think we will have to go a little bit in the intersphincteric plane to reach at least dentate line?
Yeah,
where they
definitely we are
usually
going to
open?
do. See, it is at the, if you see properly, this is the dentate line.
Right.
It is just below the
come down.
dentate line.
It has come down, right? Yeah.
It's just a centimeter, it is going on the right hand side also.
Right sentence, right, sir.
Give me the methylene blue. So what we can do is from the internal opening as we were suggesting, we can try and identify the opacify, color the right side also. Don't push too much of methylene blue because otherwise it will all extravasate. And then will give you all false kind of a impression. So we'll start coring from here. Now this is definitely in the below the puborectal sling, which is supposed to be safeguarded at all costs. If you try and feel the tract, I can very well feel the cord-like tract from here to the 6 o'clock position. But I cannot feel anything here except this fibrosis over here, right? In fact, many a time we are thankful to the MRI people because they report in such a way that the patient get referred to me or Parvez, you know.
Some people, they keep the probe inside and then dissect. But usually we see that if we remove the probe and then dissect, it is a lot easier. So any tips for those people who are, have just started and doing that kind of a thing because of the fear of losing the tract?
Presence of probe inside is just to make you feel the tract all the time.
Right.
And if you, this is where this adrenaline comes into help. This field becomes kind of very minimum bleeding, and you just follow the induration.
Yeah.
This is the tract. You can follow the induration. I have already felt clinically the direction of the tract, so I'm going in that tract. These are the external sphincter fibers which are coming into my picture over here. Those are the subcutaneous portions of the external sphincter. Can you see the tract there?
Yes, sir. Yes, sir.
So you just go beyond that. That is the advantage of using a color dye. इधर retractor लगाओ.
ऊपर भी जाए. Track is going up.
It has to go up till the internal opening. We will see if it has gotten a separate extension. We'll come to know now. So this is not a malignancy. Be as close to the track as possible. You don't have to be very radical. This is all fat tissue which we are seeing. These are all the muscle tissue now. This portion is going transsphincteric. Can you see this crossing the sphincter here? Can you see this sphincter?
Yes, sir. Yes, sir. External sphincter.
And this is going, this track is going across the sphincter now. So I am going to detect the transsphincteric portion. So here I am just going to ascertain whether it is going as I have depicted clinically, or is it going somewhere else? So it's not going somewhere else, right? Pakad. So I am going to take the entire internal opening area.
External cup.
Yeah, this is the internal opening area till the dentate line where gland is supposed to be there. I have taken in my incision, so I will be completely excising the pathology. Can you see this fibrosis?
Yes, sir. Yes, sir. The dye is going on the right side.
The dye is going here, but this is also a fibrous tissue over here. Anyway, we'll remove everywhere where the dye is going. इकडे करा थोडं. We must try and keep on filling the puborectalis sling so that you don't breach the puborectalis sling anywhere. You must always remain below that even if you are doing muscle excision and primary repair.
Yes, Dr. Niranjan, Dr. Pankaj Modi wants to ask question.
Yes, sir. Please, sir.
Good afternoon, sir.
Good afternoon.
There is an excellent dissection. But what I want to say is, sir, how will you confirm that the MRI is showing so complex fistula and dye is not going? So what is your uptake on that? So should we
Sir,
search for other fistula or not?
So when you dissect, right now, when you saw this dye going there, though
Yes, sir.
clinically we were not feeling anything. So now that
Yeah.
we have committees, we'll excise that portion also, or at least scoop if it is going above the sphincters. Get my point? And we can laser ablate it. Similarly, you can also sometimes see granulation tissues while dissecting.
Yes, sir.
You know, so whatever you see by your eyes cannot be denied, you know.
Sir, have you reached the internal sphincter now, sir?
Internal sphincter is cut, already dissected.
When I remove the internal opening, the internal sphincter is here. Can you see this? Right now, what I'm dissecting
yes.
is at the
Yes,
part of
sir.
the internal sphincter.
That is a part of internal sphincter.
So you don't find any tract which is going in the intersphincteric area above, which was mentioned there right now. There is some more tissue which I'll dissect. But till now, whatever we have reached, we are not able to see that, right?
Yes, sir.
So this is the entire tract which we were filling earlier, and there is some extension on the right side.
So this is what I want to comment upon. The fistulectomy has a disadvantage. If you do fistulotomy, there will be a problem of finding the extension of tract many times when you lay it open.
So even when you lay it open, if there are methylene blue or any color dye, whatever you have used, if you see it going in some other place, you can always confirm.
The point will be because floor will be stained by methylene blue in that case. So when it is
Sorry?
a complex,
yes.
When you lay open the fistula tract, sir, only the posterior walls will still have a methylene blue. And to identify the extension will be more difficult in that circumstance.
No, the posterior wall having methylene blue and a tract going up with a hole having methylene blue are two different entities, sir. And you will, for example, here itself, if you see this, chhod do ye. Here also, we were able to see methylene going through a separate hole here. Can you see this?
Yes, sir.
Yeah. So those things, even if you open, you will see it going there.
No, but if there is any extension from posterior wall, sir, and we have not removed the posterior wall, it can be misleading.
Sir, Dr. Modi is talking about the fistulotomy rather than fistulectomy.
I know, sir. The result for both are more or less equal. You know, primary sphincter repair is only to decrease the incontinence associated with that. But as far as result for fistula recurrences are concerned, the result with fistulotomy or fistulectomy are more or less same.
So there is no much extension on the right side.
No. इधर करो. अभी देख रहे हैं मोदी साहब, आप ये अलग से जा रहा है. डॉक्टर मोदी. Dr. Modi, can you hear me?
Yes, sir. Sorry. Yes, sir. I am hearing you. Yes, sir.
Yeah. Now, can you identify this is a separate thing going there?
Yes.
So similar thing happens.
Yes.
Okay.
But sir, the point is that when we are doing fistulectomy, it will be easy to identify this thing. But that the point what I want to impress upon is that fistulotomy has a definitely same result. But to find out the side tract, fistulectomy is a better option. That's what I want to impress. Because sometimes the side tracts are posterior, particularly on the floor of the fistula, those tracts can be missed.
If you are very vigilant, you have done an MRI and you are aware about this, you will try and search for it, right?
Here it is very clear, sir. We can see it without any issue.
Yeah.
So
So
what
this
I
is the
see that actually there is a gross difference between the MRI report and the clinical finding on the table.
No, except for the intersphincteric third tract, the other tracts have been seen over here. एक जरा इधर retractor लगाओ. See लो. अच्छा, एक और लो फिर. एक और दे.
The extension.
नहीं वो तेरा वो ट्रैक तेरे इसमें रिट्रैक्टर में जा रहा है.
No dye seen, sir.
No, sir. I am just seeing the dye which was going up through which I cut. नहीं वही दे दे. Right angle इधर.
बस ये रखो ऐसा छोटा स्कूप दे दो मेरे को. So this is the issue-rectal fat on the right side. एक मिनट. Can you see this?
Yes, sir.
Yeah. Anyway, this is just extra sphincteric. The sphincters are medial to that. ये hold करो. I'll just. Can you see this granulation tissue, sir? Dr. Modi. Kaushik bhai, can you hear me? Can you see this granulation tissue here? Kaushik bhai?
Sir, Dr. Modi has gone. I'm Dr. Kaushik Shah here, sir.
Okay, sir. Let's show you the volume which I was talking about. Can you see the? Now, see the fat over here. Sir?
Yes, sir.
Yeah, so this is that achalasia patient. What is the internal picture? They do. So just to first show you the port positioning. Can you see the port, sir?
Yes, sir.
So our viewing port is 2/3, 1/3 between the umbilicus and the zygosplanum. We have a Nathanson retractor. We have a walking port. जरा चुप बैठेंगे क्या please? Left mid clavicle line walking port and 2 retracting ports like this. I'm going to ask Dinesh to take the audio back to Niranjan, and then we'll come back to me once Niranjan is completed his fasciculectomy.
Yes, sir. Your audio is on, sir.
Dinesh, shift
audio nahi hai.
Dr. Niranjan, we are with you now.
You are with me, no? So I was trying to show you that there is no track going in the intersphincteric portion, which is going up.
So, sir, there is a left side, there is a slight spot of the dye is seen in the upper part.
Which one? This one?
This, 5 o'clock, the suction area.
This is the cautery, this thing.
Okay.
Cauterized tissue.
Okay, sir.
Okay.
Sir, would you like to suture, hold the tract or keep it open completely?
I will suture it, because if you leave so much of muscle incised, definitely there will be some scarring, deformity, and some minor incontinence, even if though not major incontinence. And by primary 30 by primary suturing the sphincter, the size will also get narrowed. The functions of the sphincter will be preserved because there is healing by primary intention. And there is no scarring, means the less scarring compared to the secondary intention healing.
So the suturing will remain for the longer time, or it will give way within 2-3-5 days?
No, it won't give the only 5% of the patient the sutures give way. Rest 95% they don't give way like this. And we are going to use PDS for the external sphincter. PDS de dena 20.
Dr. Niranjan, can we go to another OT? There they are ready with the surgery.
Yeah, please.
Okay. Yes, Dr. Roy, we are with you now.
Yes, sir. So you see, I'm just exposing the esophagus. I'm using a cordless sonocision, sir, which is an excellent energy source. This is the right crust that I'm seeing. This is the investment of the prenovascular ligament. I'm dividing the prenovascular ligament to expose the esophagus. I take my cut till I find the 2 crura meeting.
Dr. Roy, your endoscope is inside, or you will do it later on?
No, sir, I'll do it later, sir.
Okay.
Bleeding. So the endoscope is done only after the myotomy is complete, sir.
Yeah, my intention was there. If it is inside, we can just see how it looks before your myotomy.
Yes, sir. No, I'll do it immediately after doing the myotomy, sir.
Okay.
This is the esophagus that that is the esophagus that is mobilized. This is the window that's made. Now I just need, it's a very thin patient, so I'm just dissecting into the chest a little bit. This is the left crus. This is the right crus. This is the investment of the prenovascular ligament. This is the caudate lobe of the liver. Just below the caudate lobe of the liver is the IVC. Can you appreciate that, sir?
Yes.
So this is the IVC that the tip of my sonocision is showing you. So I'm just going to expose a little bit more of the esophagus in the chest, and then we'll be ready to start doing our myotomy. So as I told you, 6+2 in this patient being a type 2 achalasia. So this is, you must be in this loose areolar tissue. So whether you're doing a rectopexy or a esophageal surgery, the loose areolar tissue is your friend. So, now going to mobilize the left crus a little bit, because later on I'm going to do a door. So these are the investments of the left crus. Now the vessels you see here are the branches of the inferior phrenic vessels. So if you see these vessels, that means you're going too far laterally. All I need to do is to take care of these vessels. So this is a new kind of energy source that doesn't have a cord. It is a cordless harmonic, if you like. It has got an inbuilt transducer. The next step for me is to identify the anterior vagus. Center. Center. Show me the OG junction. I'm assisted by Dr. Ajit and Dr. Sanatan. And I have Dr. Kale as usual on my anesthesia end with Dr. Rasika as the anesthetist today. So I'm dividing what is called the Belsey's fat pad, dividing the pheniocerebellar ligament till I get bare esophagus somewhere. So never start doing a myotomy till you get bare esophagus. That is the crucial part. All these vessels, it's important that you take right at the beginning, because otherwise your gastric myotomy will be inadequate. Do a little bit more than what is necessary. You'll never regret it later. So all these vessels and the pheniocerebellar ligament divide well in advance. So this is where my gastric myotomy is going to go. This is what is called the Belsey fat pad. I'm removing all these tissues beforehand, because many times they will ooze a little bit and they will spoil your plane when you're doing the myotomy. You don't want a hematoma when the myotomy is being done. Do you have a good audio and video signal?
Yes.
Yeah, thanks to Mr. Dinesh Pal, who has been doing our audio video transmission for several years now. He always does an excellent job, and I wish to thank Dinesh. Dinesh ko andar bola, OT ke andar. He has consistently done a good job, and I hope to engage him in Massicon and Assicon this year. Dinesh andar aa gaya? External camera Dinesh पे ले लो अंदर लो किधर है तू रखना पकड़ external camera.
Can you show us the anterior vagus?
Yes sir, I'm external camera दिखा. Just want to introduce Dinesh Pal, who's been doing our audio video transmission, important part of our team. I'm just about to expose the anterior vagus. Come back to endoscopic camera. So the trick of getting the vagus is to do at the OG junction. See, this is the angle of his. This is my OG junction. Hold this tissue, and there you will find the vagus crossing from left to right. These are the bare esophageal fibers that I have separated. These are the bare stomach that you see here, and this is what I am exposing the anterior vagus, sir. So you must see these bare fibers like this before you start doing your myotomy. If you start doing a myotomy with the pheniocerebellar ligament intact, you are going to struggle getting your planes. क्या आवाज आ रही है? Any suggestions from the moderators, audience? Any questions? Any suggestions, criticisms? I'm open to hearing them, sir. So that's my anterior vagus separated. More importantly, see the bare muscle fibers that I'm showing you. This is extremely important when you start doing your myotomy. So take the anterior vagus away completely. Remember, the left vagus is the anterior vagus, and it crosses from left to right at the OG junction. So unless you take care of the vagus, you are never going to be able to do a proper myotomy. You always worry about where the vagus is. So all this tissue needs to be taken down. So these are all investments of the pheniocerebellar ligament covering the esophagus.
Sir, there is a question. Hello.
Yes, sir. Yes, sir.
Anand here, sir.
Yes,
Sir,
Anand.
accidentally, if the vagus is damaged and we recognize intraoperatively, do you add pyloroplasty, or since the posterior vagus nerve is intact, so we may not know? Like
Dr.
what is
Anand,
your
if you have one vagus intact, there is usually no problem. In my life, I have divided the vagus 3 times. Twice doing a redo fundoplication and once doing a redo achalasia. If one of the vagus is intact, there is no problem in gastric emptying.
If you remember the original Belsey Mark IV operation that was transthoracic, one of
Yes,
the
sir.
recommendations of that operation when
Lubago-
you are not able to lengthen the esophagus was to divide the posterior vagus. So dividing one posterior vagus or one anterior vagus, focus please. Talatha.
Can we shift to another OT? Dr. Niranjan is showing something. He has completed his operation.
Yes.
Dr. Niranjan, sir.
Yeah. Am I audible now?
Yes, yes.
Yeah, so you can see I have just approximated the sphincter muscles and closed. The anal verge is restored as it was previously. Even the tone of the muscle, you can see it's gripping my finger actually. And the
Good.
rest of the ischoanal fossa we have marsupilized. We have not closed this area because this will take some time to collapse and we don't want the cavity to remain and the skin to heal. So we have marsupilized it. The drainage will be very thorough and it will heal faster also, as well as the tone of the muscle and the anal verge are restored. So the keyhole deformity which occurs after such kind of surgery will not be there.
Excellent demonstration. Marsupilization is a new thing that we have seen. Excellent.
Thank you, sir.
Sir, what would be your post-operative advice and treatment?
So
And
we
follow-
give them a stool stopper, we give them painkiller, and we ask them not to squat. So no Indian toilet, English toilet, because there will be some strain on the
Yes, yes.
suture material if you squat a lot. And
Yes.
post-operatively, after they pass the stool, they are asked to use the hand flush if they have at home to clean the whole cavity, sit in the tub of warm water, and most important is to take the relatives in confidence, especially the spouse, so that after every passage of motion, they can clean this cavity with diluted saline betadine solution. That will ensure that no fecal matter remains inside this cavity.
Yes.
And we don't call this patient every day. We call them maybe in 3-4 days time so that we ensure that it is healing from below. The
Yes,
the
yes,
skin
it should
doesn't-
heal from below.
Yeah, the skin should not close before the cavity collapses. So this is one place where the surgeon interferes in the healing. If I find the skin getting closed and the cavity is not closed, I will reopen it under local anesthesia and ensure that the cavity collapses first.
So when will you call the patient for follow-up? And at that time, what is advisable to look at?
So usually I call them after 5 days after their relatives have been taught how to do the dressing at home. And when they come, I clean the cavity myself and see how the granulations are occurring, whether the continence is thorough, the sutures are in place, and how the cavity is collapsing and how the skin is healing.
Okay. Thank you very much, sir.
Thanks a lot.
Yes, Dr. Roy, we are with you now.
Finish.
Yes, sir, you are live.
So the second trick this is the vagus that I separated. This is the OG junction. This is the angle of his. Never start your myotomy here. This is where your muscle will be the thickest. Start it on the esophageal side a bit further up. This is why isolating the vagus is so important. Take a good bite of muscle like you see me doing. I don't use any energy source, no special instruments. And I just come close, Sanatan. Now I want the audience to appreciate the longitudinal fibers and the circular fibers. Can you appreciate the mucosa coming, sir? Kaushik bhai?
Yes, yes.
So you must see this very, very clearly. Longitudinal fibers, circular fibers, and just pull. It is possible that you may get a little bit of bleeding, but you will just put a gauze and keep it pressed. You see, I have taken a gauze inside. If I get bleeding, I will just simply press with a gauze. So 2 layers, longitudinal fibers, circular fibers, and the mucosa inside. There is Palnivelu scissor, there is using the sonocision. You can use many things, but I just tear the muscle apart. As you come down to the OG junction, my resistance of the instruments is increasing. The muscle is thickest there, and because of previous dilatation, she will have some submucous fibrosis there. You can see the bare muscle, sir, the bare mucosa.
Yes, yes, sir.
So now I'm beginning to see the oblique layer. You see these vessels coming? I told you earlier on that when you get the oblique layer and when you see the vessels, that's when you know that you are on the stomach side. So this is my angle of his, sir. See this is the angle of his. I've gone good 2 centimeters below, sir. Can you appreciate that?
Yeah, we can appreciate it.
So this is a very easy operation, but very anatomical. You see the vessel, this is going to bleed when I pull it, but that's okay. I'll keep it pressed, it will stop bleeding.
So I'm almost 3 centimeters on the stomach side now. I always overdo the stomach myotomy. As I told you earlier, failure is because of inadequate myotomy on the stomach side. So I'll do a little bit more on the esophagus side, and then I'm ready to do my intra-op endoscopy to see what's happening. I think Dr. Rasika has given me a blood pressure of 90 systolic, which helps me tremendously. Now, one trick is you may sometimes want to do this exercise. Just make a little plane between the muscle and the mucosa like you see me doing here. You see the mucosa getting stretched? And then you hold the muscle. The vagus is in my foreground, which I've seen. And then you tear the longitudinal fibers and then the circular fibers. Get a little bit of bleeding, don't worry about it.
You don't use the energy source here?
I never use energy source on the esophagus because I think this is only bare mucosa. Some latent energy can always cause problem. So I have now done more than 200 achilles. I have never used energy on the esophagus. I started off life with the Palnivelu scissors. Then I started using harmonic. And now I only, for the last 10 years, I only tear the muscle apart. And I've never regretted that.
Yeah, but still it gives excellent results. Yeah.
So one trick is in patients who have multiple dilatations, just create this plane between the mucosa. In case there is submucous fibrosis, sometimes the mucosa will be adherent to muscle and it may tear the mucosa. So just gently open it up and then do it.
By chance, it accidentally opens up. What do you do?
My God, let me finish. Please don't ask me that question now. You know, when you have a resident, na, हमारे पास एक मेरा co-resident था. Just when you were putting a clip on the cystic duct, पूछा था CBD होएगा तो क्या होएगा? So ऐसा आप मेरे को एकदम इसका याद आया आज. So it's important to recognize any mucosal perforation on table, suture the perforation, and then to do a DOR fundoplication on top of that. Nothing more is required. But obviously, I will put a drain and I will do a contrast study on this patient later, in case there is a mucosal injury. So this movement is important of just opening up the plane between the muscle and the mucosa.
Have you seen any problem tearing it? I mean, incising it with the harmonic, keeping the.
So I have managed 2 patients who came to me from other centers on day 5 and day 6 with a thermal injury of the mucosa suction there. After that, I got scared and I have stopped using this. So the mucosal tube is open to you. I'm just going to do a little bit of suction. And then I'm going to get my assistant, Rasika, I want you to suck and take out the RT. Now I'm going to ask my anesthetist, Dr. Rasika, to take out the Ryle's tube on table because I'm ready to do an endoscopy on this patient. I'm just cleaning up this area so that you get better vision. This is my vagus in the foreground. The mucosa is open to you. Now I'm just going to put a tape and show you the length. You know, it's important that you walk the talk. Beforehand, tell the audience that what you want to do and do exactly that. So I put a little tape inside. I think this is extremely important to do. So if you look at my esophageal myotomy is more than 5 centimeters long. And my stomach myotomy is easily more than 3 centimeters. This is the angle of his, sir.
Yeah.
I'll pull the stomach. You see that, sir?
Yeah, we can see it.
So my stomach myotomy is almost 3 centimeters. So the myotomy is now complete. I'm now going to just quickly ask Rasika to take out the Ryle's tube and then I'm ready to do an intra-op endoscopy. Actually, I'm not doing the ICG today, but that is a prospective study we are doing instilling ICG. So I'm just going to, I think it's important that as the Association of Surgeons of India also is now very, very clear that all endoscopies we should be trained in endoscopies. And the ASI has done a training program where, don't suck and take out, just disconnect it, please disconnect it. So I'm getting the Ryle's tube taken out and I'll just do the endoscopy in a minute. So the ASI runs various training programs in upper GI and lower GI endoscopy. And we are encouraging all young surgeons and residents to learn at least diagnostic endoscopy
so that we should be good at this, and intra-op endoscopies, either of a lap colorectal surgery, achalasia, diverticula, all become very easy. अरे आधी करून ठेवायचं ना रे राजा, मी बोलतोय तोंडाने एंडोस्कोपी पाहिजे आणि तू आता मी आल्यावर लावतोय, काय टाइमपास आहे. वर्कशॉप मध्ये थांबायची गरज नाही लागली पाहिजे याची. आता तू कनेक्शन करतो आणि वाईट बॅलन्स करतो, दिलायस तू. आता हे चालणार नाही, ते चालणार नाही, सक्शन नाही चालत आहे. अरे यार बेकार आहे यार, थर्ड क्लास सर्जरी कुठे सक्शन चालतंय.
Sir, Roy sir,
Yes sir.
our workshop will end at 2 p.m.
Okay sir.
and we have done these 6 cases. Now,
Yes, sir.
how much case you are planning to do and
We
which?
will continue operating till you tell us. We have a full day's list. So we have one more fundoplication, we have one lap assisted hemicolectomy, we have one incontinence surgery, but we'll stop transmission at 2 o'clock. Maybe we'll show, it is 12:40,
Audience
we'll
is,
show one
audience is
fundoplication, one
interested,
feature.
the audience is interested in the common surgery which you are doing nicely, so that you keep this this surgery earlier, so that we up to 2 we can see and we can enjoy the surgeries. So next,
Yes, sir.
which surgery?
So we'll
Which
show a
surgery?
fissure now. We'll show next surgery will be a fissure, and then we'll
Huh.
show a hiatus hernia, sir. ये देखो.
Okay.
External can you see the endoscopic view, sir? Ask
Visualize
Dinesh to
please.
Yeah, we have.
अभी
We
external
see
camera
what-
दिखाओ.
Huh.
Can you see the endoscopic view?
Yes, yes.
बेटा एक हाँ then दोनों दिख रहा है ना. So on left side you have the laparoscopic view, on the right side you have the endoscopic view. So this is
Yes.
extremely important that you see both simultaneously.
Dr. Roy, Pankaj here. Hello.
Pankaj bhai.
Sir, do you have some patient of incontinence, sir?
Sir, that will come a little later, sir. लेकिन he started.
Well, actually, we were interested in that surgery.
सर मैंने कल निशित भाई को लिस्ट भेजा था, जो उसने भेजा बोला हमने रखा है.
Acha, ठीक है sir. नहीं, so just it was a sentiment of the audience. That's all. Okay, sir. It's up to you. No issue. Thank you.
So now I'm going to show you the trans. Come close, please. Lap light band kar. Now I'm going to show you the mucosal tube, sir. Keep watching the laparoscopic screen, sir.
Yes, yes, we can see that.
So
Endoscopy
can
screen.
you see the mucosal
Endoscope.
tube coming, sir? You
Yes.
see the laparoscopic screen. You see brilliant transluminant mucosa. On the right side, you are seeing the gastroscopy picture. On the
We
right
are
side,
not-
you see.
Yeah. now
Yes,
we
yes,
can see-
excellent.
Yes, yes, yes. There is no perforation.
Sir, also there is no muscle. It's absolutely clean. Lap
Yes,
like water.
muscle is also only
yes.
mucosa. Yes.
Yes, sir. So now what I'm doing is, first step is to confirm the completeness of myotomy, which I've done, head low, pani on. So now what I'm going to do is ask Dr. Rasika to take the patient head down. I'm going to ask Dr. Ajit, who's a consultant with me, to put water, normal saline into the abdomen. And then I will distend the esophagus with saline in the abdomen, confirming there is no microperforation. So our protocol is we will not put a nasogastric tube. We will start feeding her within 4 hours of surgery and discharge tomorrow afternoon. So, अडते तिकडे बघ लक्ष द्या जरा. हा बस. So now that's fine. So Ajit, what I'm going to do is keep watching. उनको दोनों vision चाहिए मेरे को. दोनों vision चाहिए. उनको दोनों vision दो. Endoscopic view दो और ये दो. भाई cameraman. हाँ. So now you have both the visions. What I'm doing is I'm distending the stomach. You see the stomach distending on laparoscopic vision. I've now entered the esophagus. You see how distended the stomach is got, sir. There's no bubbling at all. I've come into the middle esophagus. Show them the whole stomach, Sanatan. Can you see the distended stomach, sir?
Yes, yes, distended, quite distended.
So we are convinced that there is no perforation. Now the
Good.
next step before taking out the scope is to go into the stomach once again and deflate the stomach, because otherwise then doing a door will be troublesome. So I put the scope back towards the pylorus, and then you can watch the stomach getting deflated.
Yes,
And
deflated.
then I will do a door.
Okay.
You have a choice of also doing a two-pace. Some people would prefer a two-pace, but my choice is a door because it acts as a serosal patch to cover the mucosal tube.
There is small announcement. Quiz will commence at sharp 2 p.m. in Hall B. Thank you.
Head high, please. ताई बाजूला फिशर घेतला का बघ तयार झाला का?
What case is being taken in next OT?
Sir, it's a laser fissurectomy, sir.
Okay.
Sir, do you
I will
do,
discuss with Nishit. Herald, please.
sir,
We
do you
will keep-
do intraoperative manometry?
Sir, we actually published this in the American Journal of Gastroenterology in 2012, where we brought the intra pressures to less than 5. That is a publication by my name. But we have realized that there are 2 or 3 things. One is it's not really required. If you do a intra endoscopy, like you see the mucosal tube now, sir. If you can get this kind of mucosal tube, you have an endoscopy that shows completeness of myotomy. The manometry doesn't help to improve your results. Now I'm going to use Ethibond, like Dr. Samir Rege showed you today morning. You may use either Ethibond or you may use 20 Mersilk. So the first step of the door is to take a stitch between the highest point of the fundus to the left crus. So I'm just going to push away this greater curve, see where the highest point is, and take a deep bite through that. Not a good bite, so I'll take a deeper bite. Now this is the inferior phrenic vessels. Avoid that. This is my myotomy. Avoid that and take a bite on the high part of the left crus. So why do we take this stitch? It accentuates the angle of his, and it's a natural mechanism to prevent reflux. So I think somebody asked me earlier, is there any situation where I won't do this? The answer is, if I'm doing a laparoscopy, the reason of doing a laparoscopy is to prevent reflux that I get in POEM. And in every situation, be it elderly, young, child, or in a sigmoid esophagus, doing this is absolutely mandatory. So this is the stomach anchored to the left crus. Sir, any questions from the audience or the moderator, sir?
Yeah, right, sir. I'm Dr. Dushyant here.
Yes, Dr. Dushyant.
Sir, your comments, POEM versus myotomy. What's your opinion or take on that? Which patients indications?
If the patient is my mother, I would do a lap myotomy. If she is my mother-in-law, I would do a POEM. And the reason is that, after POEM, there is a between 10 to 12% incidence of reflux. A lot of them require long-term PPIs. In fact, we also do POEMs in our hospital, and our own patients, whatever the gastroenterologist may tell you, we have observed these patients very, very carefully, and a lot of them actually have reflux requiring PPIs.
Very well said, Roy, sir.
Thank you, sir. So I think the same gastroenterologist who used to tell me in a public debate that they never saw reflux, suddenly are now talking of doing a POEM F, that is POEM with an endoscopic fundoplication. So don't believe everything you hear from them.
Do you do any crus repair in these patients?
So if there is accompanying hiatus hernia, then crus repair. So what you see me doing is taking sutures between the stomach and the cut end of the myotomy on the patient's left. I will do the same thing on the right. And then the last stitch would be to, so this stomach is getting sutured to the cut end of the myotomy. And this ensures that the myotomy remains apart. This is a modified Dor technique. And this is basically the experience of the Brazilian surgeons. See, in Brazil, they have a disease called Chagas disease, which is congenital megaesophagus caused by Trypanosoma cruzi. And those patients have a high incidence of recurrence after surgery. So they found that when you suture the ends of the stomach to the end of the myotomy, the recurrence rates are very, very low. So ever since that, the Dor we have modified to suture it to the end like you see me doing here. Yeah, come back, show him the scissor. Big grasp for all. So now I'm directly going to take it to the right crus. There is an option of suturing this to the other side of the myotomy. I don't routinely do that. I only suture it to one end of the myotomy, and the logic is it keeps the myotomy open. Now I take this to the lateral most part of the greater curve. and this will go to my right crust like this. Ek minute. No, 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 I'm okay. Now important, don't take off this peritoneum. You see this peritoneum? That sometimes if you pull it too hard, the right crust will, abhi pakad. Detector ko niche pakad and pull it across. So the whole crust will split. So in this situation, it is better to keep this peritoneum intact, whether you're doing a whether you're doing a fundoplication or a achalasia. Always keep the peritoneum intact so that this crust never splits when you do. This is a good size crust, but sometimes you may have a thinned out crust, which can be a problem. So you can have patients with two things. One is accompanying hiatus hernia, where you need to do show me the needle coming out. Or second is those patients who have an epiphrenic diverticulum. So if you have a patient with epiphrenic diverticulum, then you need to mobilize the esophagus in the chest and do a diverticulectomy. So we do a diverticulectomy, a myotomy, and a DOR. समझ में तैयार है? Live जा सकते हैं क्या ऐसा कुछ? So I want to thank Dr. Nishit Shah and the executive committee of Guj Asicon for allowing us to transmit from Zen. It will be my pleasure to give you a lecture tomorrow morning. I'm going to speak on doctor as an entrepreneur. I don't know why he has called me to do this lecture, but anyhow, we will see how it goes.
Roy sir, Pankaj here.
Yes, sir.
That lecture has a specific meaning for us. It has been designated as Dr. H.L. Patel Memorial Lecture, sir, if you do not know. Because this year, our senior most surgeon, Dr. H.L. Patel, has passed away. So in his memory, you are going to give this lecture. And Dr. H.L. Patel was actually a person who took Association of Gujarat very far. So that will be an honor for us also. Yes,
it's my proud privilege then to give this, sir. I didn't realize this. May I just request Nishit or Pankaj Bhai, if you can just give me a little on WhatsApp, a little bit of information about this great surgeon. I will incorporate that as the first slide of my talk.
Definitely, sir. It will be with you. We are also going to speak about him before starting the lecture. But yes, sir, we will send
I
definitely.
would like to know about him, sir. Yes, sir.
Yes, sir. Incidentally, his son is an onco-surgeon, Dr. Tarang Patel. So he was here just before few minutes. So definitely we'll send. No issue, sir.
Thank you, sir. So I'm going to take two more sutures and then this surgery is over. And in 2 minutes, we will get you to go across to the Fisher surgery. And chalu karo screen. Dr.
Right, sir.
Niranjan Agarwal. Yes,
Right,
sir.
sir. Jitu Patel
Yes,
here.
sir.
Is it true door or it's some modification?
It's a modified. I told you it's the Brazilian modification of DOR, sir.
Do you agree this will invite future re-adhesion of muscle fibers and fibrosis
I don't
that
agree
can
at
lead
all.
to recurrence
I don't
as
agree
compared
at
to
all.
tope?
Sir, toupees and DOR have nothing to do with recurrence. They have to do with control or reflux. I've been doing this operation now for 25 years, more than 200 achalasias, which we have now followed up telephonically very closely. And
I have been operating achalasia patients since 22 years laparoscopically.
Sir, but DOR and toupe, DOR and toupe really is to do with anti-reflux control. It's got nothing to do with recurrence, sir.
But topic gives open myotomy. And this can invite adhesion and recurrence.
So adhesion between the stomach and the esophagus, why would it cause recurrence? Anyway, we'll discuss this at lunchtime, sir.
Right, sir. Any reason why not to suture this with the right-sided myotomy? Right-sided.
Yes, sir. I just, as I told you, I learned this in the SAGES meeting from the Brazilian surgeons who do a lot of work in Chagas disease. And this is their modification because the classic DOR is suturing to both the ends of the myotomy, like I mentioned. The idea of those sutures is to basically keep the myotomy apart. So my thinking is if you suture it to one and take it to the crus, it will keep it apart as well as preventing reflux. So this is my last stitch, which takes it to the apex of the crura. And then we will hand over the camera to Dr. Niranjan Agarwal. Any other questions from the audience? Otherwise, then this surgery is over and we'll try and finish this quickly so that we can show you one more fundoplication and one fissure before we close the transmission. Does the audience or moderators have any questions about this?
No, excellent demonstration.
Just there is a question. Question from the audience.
Yes, sir.
If at all this patient develops a dysphagia, then how will you evaluate after surgery?
Yes, sir. So there are two types of patients who come. We have a big manometry lab in our hospital, and we get a lot of patients referred from across the country with failed fundoplications, failed achalasia surgeries. So first is the history. Was the diagnosis of dysphagia correct? So we will do a barium swallow, we will do a upper GI endoscopy, and we will do a manometry. So number one, was the diagnosis of achalasia correct, or was it actually a motility disorder other than achalasia? Number one. Number two, was this was this dysphagia developed late? Like if the patient says he was okay for 3 years and then has developed dysphagia, then remember the body remains amotile, and that dysphagia may be because of normal LES pressures. The manometry is crucial in this situation, because if your surgery has gone well, then the LES pressures will be below 10. That tells you that the myotomy has been okay, and there is nothing more you can do for these patients. If your manometry is showing a high LES pressure, then you know that the myotomy is not correct, and either adhesions are formed or your initial myotomy was incorrect. So our thinking is, these patients, we first offer them a balloon dilatation. If they recur after balloon dilatation, then we offer them a POEM. If they come to us with dysphagia after POEM, then we offer them a Heller's myotomy. That is our thinking. So that's the completed door. So I'm now going to ask the audio to shift across to Dr. Niranjan Agarwal.
Yes,
to show
thank
the
you.
fissure while we start the funder. Thank you very much.
Thank you
sir.
very much. This session is over. We are starting with new session.
Yes, sir.
Thank you. Thank you very much.
Thank you so much to our chairpersons. Now I request to collect them memento.
To chair the next session, I would like to call on stage Dr. Kalpesh Jani, consultant laparoscopic, bariatric and GI oncosurgeon from Baroda. Dr. Keyur Bhatt, MD of SITS Hospital, Surat, Director of GI and HPB Surgery. Dr. Samir Shah, Professor and HOD, Department of Surgery, GMC Bhavnagar. And Dr. Maulik Parekh, Consultant GI and Laparoscopic Surgeon from Bhavnagar.
Vinith, how old is she? Huh? How old is she? 28. Okay. Speculum. छोटा वाला अरे इधर नहीं लगाने का, हाँ इधर लगा, ये मत लगाओ, हाँ चल। Are we audible in the auditorium?
Hello.
Are we audible in the auditorium?
Yes,
Hello.
sir, you are audible.
Yes, sir.
Yes, sir. Yes, sir.
Should I begin or should I wait?
Yes, sir, you can.
Okay, so this is a 28-year-old female patient who have a chronic anal fissure, posterior fissure. You can see this fissure, external skin tag and the fissure when you retract the buttocks. And she has not responded to the chemical sphincterotomy agent used for a year. The plan to do is to do a laser sphincterotomy. So for laser sphincterotomy, it's nothing different except that the energy which we are using is laser. Normally we use either a blade or a cautery, whatever it is. And like any other sphincterotomy, you have to go into the intersphincteric plane. So you taut the anal canal. So your muscles are taut here with the help of that retractor. This is the internal sphincter. This is the dentate line. You are supposed to divide this internal sphincter. Can you see this depression over here?
Yes, sir.
Ah.
Yes, sir. Yes, sir. We can appreciate.
This is the dentate line, this is the internal sphincter, and this dip which you see is the intersphincteric plane, beyond which is the external sphincter. Can you see this?
Yes, sir.
Can you appreciate this dip? So what I am going to do is we are going to do a laser sphincterotomy. So this is a bare fiber of the laser. We are going to use a 7-watt current. उधर दिखाओ जरा machine पे.
Kalpesh bhai, you like your new look with the beard?
Kalpesh bhai is not heard.
Kalpesh bhai, good morning.
Yeah, I'm here. You're right.
We like your new look with the goatee beard.
Your voice again is not very clear. We can.
I said your new look we like with the new goatee beard.
Yes, sir, we can hear you clearly.
No, I'm not able to make out what he's saying.
So have you seen the machine?
No, I was here, he was praising your new look.
दिखाया machine दिखाया. Have you seen the setting on the machines?
Yes,
So
sir.
we are using a 7-watt current and the intersphincteric plane. I am going to just puncture with the laser fiber. My fiber is inside now. And normally we go from lateral to medial side when we use a blade with our finger inside. Now, because you are using a heat energy, there is a chance that you may damage the mucosa with the energy. So that's why we use a medial to lateral approach. But in this approach, you should take precaution that you don't damage the external sphincter. So I am inside, I am just directing my fiber just in the submucosal area so that I am below the mucosa and I have turned the direction if you notice, and I am dividing the internal sphincter now.
Sir, how much energy you are going to give?
So I am going to use maximum 70 to 80 joules here, and with the help of my finger, once the initial fibers are the integrity is broken, I can break the fibers with the help of my finger here. You can see I am using force on the sphincter fiber, and there it is. It's a complete sphincterotomy. You can feel it here. You can feel this depression now.
Yeah, we can see this.
Yeah, so that means the sphincter is divided at this portion. There is hardly any bleeding over here, and the sphincterotomy is over.
So sometimes it bleeds from the entry point. So do you do the fissurectomy first or you do LIS first?
No, I do the LIS first.
Right.
And fissurectomy is only if there is a large external tag like this.
Like this.
Yeah, otherwise you really don't need to do anything. When if somebody is spread like this. In fact, if there is a large tag here, if there is a large tag over here, I do a sphincterotomy from the same wound laterally. So yeah. But that's not a described technique. That is my technique. So I did not show in the workshop. You have to excise only the skin tag over here. So the same laser fiber can be used. If this was a very small tag, I would have left it unattended.
Are you going to do something to the fissure base also?
We can just spray it with laser current.
Right, sir.
That's all. Yellow. So the base which is fibrotic, you can just spray some current over here. Which will destroy the granulation tissues which are at the surface. There you are. Just see if you have any other pathologies, hardly any hemorrhoids, large hemorrhoids, etc., which needs your attention. Hold this. There is a small tag anteriorly, but it's not too large a tag. You can be left unattended, untouched. And I don't know how much we noticed when we were inserting the speculum initially, but now it's going very easily.
Yeah, it is quite clear.
Right? Even if I try one finger or two finger is also going easily. I'm not pushing it. Right?
Right, sir.
So that ensures that my sphincterotomy is complete. There's no bleeding. I don't nearly need to do any packing over here. I'll just put a betadine soap gauze piece and that should finish it. Sorry. Because of laser, we'll have to use ice pack over here because the latent energy keeps on releasing for at least 20 minutes and that should be taken care of. So you keep in an ice pack over here. Hold it. Needle holder. Yeah. Cut. Then, okay.
Dr. Agarwal, sir.
Yes, sir.
This is Dr. Dushan from audience. Usually we have seen that patient have no pain from the sphincterotomy, but pain is from area what we have exercised as sentinel tag. How to tackle that, sir?
So as I said, do whatever bare minimum is required. If you try to exercise a lot of the complete fissure complex, then there will be a larger area. In fact, if I do that, if there is a lot of hypertrophic papilla, etc., then I close it primarily with interrupted 3O vicryl suture, but in a tension-free manner. We have to mobilize both the flap, the mucosal as well as the skin flap, and suture it without tension. That reduces the raw area, and therefore the healing time is also shorter, and the pain is also lesser in that case. Otherwise, you have to use some local, apart from your analgesic in the post-operative period, stool softener, you have to use some local xylocaine jelly before they pass for stools or some antiseptic solution also containing sucralfate is shown or metrogyl ointment has shown to reduce the pain and increase the healing in many studies.
Thank you, sir.
Yeah.
Sir, this is Dr. Maulik Parikh from audience, sir. Are you using ice pack in each and every patient of sphincterotomy?
So when you use a laser energy, you use a ice pack. Ice pack is not used for non-laser surgeries. If you do a blade sphincterotomy or anything else, you don't have to use an ice pack. The use of ice pack is basically because, as I said, the heat will be releasing for next 20 minutes. And to tackle that heat, that it doesn't damage the other tissues surrounding, you use this ice pack. In fact, in this patient post-operatively for at least 48 hours, we don't give them cis bath, we give them ice pack post-operatively.
Right. Thank you.
Thank you. So again, before I close this case, I request all of you or welcome all of you for ASICON 2022. You can remove my specs, please. For ASICON 2022 at Mumbai, please be with us. There is a lot of activities being planned for all of you. And Gujarat is very close to Mumbai, Maharashtra. So there is no reason why you should not be there. Kalpesh bhai, am I right?
Yeah. Niranjan bhai, we are going to be there.
कुछ ख्यालों में खोए गए हो आप?
बिल्कुल यहीं पे है.
नहीं, वहां पे तो हो, ख्याल वहां पे नहीं है. I was inviting all of them for ASICON and I need your support to endorse my welcome.
Absolutely, sir.
Thank
We'll ensure there is a very good contingent from Gujarat over there.
Thank you so much, sir. Anything else? Any other question, or should we wind up in this this OT?
So everybody is speechless with those your skills, sir. No questions. They're quite happy with it. So how long do you leave this ice pack? I mean, it's just going to be inside and then come out when the thing dissolves. So I saw you tied it up and left it inside. The ice pack that you have put inside, I noticed that you tied it over a gauze piece and you have kept it inside. So will it just, when it dissolves, it comes out by itself? What's the protocol of removing it?
Yeah, so if the patient feels irritating with that, we remove it. Otherwise, it comes out on its own. The gauze piece is kept there so that it does not go inside. the gauze does not migrate inside, you know. That is the reason why we have tied it to a gauze piece.
Right. Thank you, sir. Thank you. That was, yeah, there's a question. Just a second. There is the one question from the audience.
Please, please.
Sir, what are the recurrence rate for the fissurectomy, and what you advise the patient for post-operatively advise that to prevent that recurrence or prophylactically?
So recurrence rate with sphincterotomy per se is around 1%, and post whether you use blade or you use a scissor or use laser energy, the recurrence rate doesn't change provided you have done a proper sphincterotomy from the dentate line below. The post-operative care, as I said, it's mainly stool softener, analgesic, and cis bath, because it does give them symptomatic relief, you know, and some local ointment, especially containing sucralfate or metronidazole to enhance healing.
Thank you very much, sir.
Dr. Niranjan, can you hear me?
Yeah,
sometimes you get patients who come back with abscesses and fistulas after laser fissures. And the second is you see some patients coming back with horrific burns after laser. What is your comment? How to prevent this?
So again, as I said, as you said, I should say it that way, that a man with a fool with a tool in his hand is still a fool, you know. If you don't use the machine properly, if you use too much of energy, you destroy the mucosa, then you will end up with a fistula because of the energy itself. And too much of energy, too much of burns is going to cause a lot of pain, burn, swelling, and sometimes infection, which can give rise to an abscess. So you saw we have used only a 7-watt current and not more than 70 joules, and appropriately from medial to lateral. That also we just broke the integrity of the sphincter and then used our finger so that the energy is not used in large amount, nor have we damaged the external sphincter.
So the second message you must give is that with laser, you don't see color change on table. The piles or the fissure, where you sprayed the current, you may not see anything on table. The piles don't change. So don't expect a change in the mucosal color. Otherwise, then you're using too much energy.
If you, in fact, if you see change in mucosal color, you have burnt the mucosa. It is the other way. So in hemorrhoid also, when you use, you should not expect the piles to reduce on table. You just apply appropriate amount of energy and leave it at that. But ensure that while giving the energy, you have splayed it all across the pile mass inside, and you are not very too close to the mucosa, not too deep to the mucosa, because if you are too deep, you will burn the sphincters, and too close, you are going to burn the mucosa. I personally do not spray the mucosa in hemorrhoid from top, because that definitely causes some ulceration and bleeding in the post-operative period.
Tell us the difference between the 980 and the 1470 laser.
So the 1470 is basically water-based, and therefore it is the energy required is much less. 980 is basically the hemoglobin-based current transmission, and for the proctology, 1470 is a better one.
So the message is very clear that all proctology use only 1470. Don't use 980. Is that correct?
980. Yes, even the depth of current infiltration with 980 is around 5 millimeter, whereas with 1470 is only 2 millimeter. So the depth of current and destruction is also very limited with 1470.
And what is your take on this radio frequency that is now new kid on the block?
I have not used it, Roy, to be very honest about it. Again, it is a very precise use of energy, and people who are using it are claiming to have good results with it, but maybe some more people have to come out with their results.
Right.
Roy sir.
Yes,
Nishit
sir.
here, sir.
Haan, Nishit bhai.
Which are that stirrups you used in the OT to giving the position of the patient?
So can the cameraman focus on the stirrup? These are excellent stirrups.
Yeah.
Either can be from American company. The ones we have are Chinese made. Excellent for elderly patients who have hip problems. You can adjust any angle that you want. And they are very well padded, so there is no problem any nerve compression.
Yes, sir. Advantages we all know because you purchased that thing. We actually want a viability of that stirrups address and cost also in my personal WhatsApp.
So the one we have 3 stirrups and 3 OTs. The one we recently bought is from an Indian company called Stan. and it costs about 1,35,000. The imported
Thank
ones
you.
are about 2 lakhs.
Thank you, sir. Thank you.
So in a few minutes, we'll start the fund application. The patient is just being induced on the next OT. The patient of a sliding hiatus hernia, but we'll talk about that in a few minutes. So just as that Achilles patient is being shifted out.
Okay. There is an important announcement from Bhavnagar Surgeons Association. And the next Guj is to be held at Bhavnagar, organized by Bhavnagar Surgeons Association. There is already a registration counter. You can register yourself today also. And today, the delegates who are registering today will get 10% discount also. Thank you very much.
So can I just, in the meantime, while the patient is getting ready, ask Kalpesh what his protocol is of investigating patients before fund application? Kalpesh bhai.
You deliberately are, starting a controversy. So,
I'm
okay.
asking information.
Yeah. Okay. Got it. So basically, I know that it's mandatory for you that you do get a manometry and in all patients. I don't. So I've got an algorithm which we also published. Patients having classical symptoms of GERD, relieved by PPI, and plus endoscopic evidence of reflux esophagitis and a hiatus hernia. I won't do anything. I'll just take the patient for a fund application on this basis only. Patients in whom, there is evidence of a hiatus hernia, but there's no evidence of reflux esophagitis, still these patients are because that's a hiatus hernia, still these patients are going to need a fund application. You need to get the hiatus hernia down, so I will still do a fund application. The patients with evidence of endoscopic evidence of reflux esophagitis alone, without any hiatus hernia, these are the patients I will investigate further. These are the patients, I'll get a 24-hour pH study done to know whether it is indeed a reflux esophagitis. And then I'll maybe post the patient for a fund application. And in this patient, I also get a manometry done because I want to know whether it's a motility issue also, which is causing a stasis of esophagitis, which is again going to be give a very similar picture to reflux esophagitis. So these are the patients I will investigate, get a pH study to confirm whether it's reflux, and get a manometry to confirm the esophageal motility. And the patients who have very strong signs, symptoms of this thing, and they give a history of there's a lot of symptomatic, a lot of functional component that you feel. They'll say they have swallowing difficulty. They have got that supragastric belching syndrome. These are the patients that I try to avoid surgery as far as possible. I'll get them thoroughly investigate. I'll ask for a manometry. I'll ask for a 24-hour pH study. And then I'll always tell them that, why don't you go to Roy Patankar and get it done? He's a much better surgeon than me.
Okay. And how do you decide which wrap to use?
Yeah. So, as I said, if there's a patient doesn't give any history of dysphagia or anything, I'll still do a floppy Nissen in all the patients, because there are papers which show that even if the patient have a dysmotility because of long-standing GERD, post your surgery, the dysmotility improves. So I won't use that as a basis to divide it between Nissens and a partial, because my primary aim is to reduce the reflux rather than this part. With partial, we know that there is a lower incidence of dysphagia, but then it's at a cost of a higher incidence of persistent reflux. So I'll still opt for a Nissens in those cases. All the cases, of course, we do a partial floppy, short floppy Nissens. And other cases where I mentioned that I'll get a manometry done, I'll tailor it according to the manometry. Where I'm suspecting esophageal dysmotility, those are the cases where I'll get a manometry done. And if the manometry also supports the diagnosis, I'll do a partial.
And any cases you do a DOR for reflux?
No, I don't do a DOR. I usually do a two-pace. DOR is only cases we do as an anti-reflux maneuver is in achalasia patients when there is extremely poor motility, and secondly, when on table we have injured the mucosa, then I'll do a DOR. So rest of the all cases, when I do a partial, I do a two-pay.
Okay.
So what is the grading system? Because in endoscopy reports done by gastroenterologists, we usually see grade 3, grade 4 hiatus hernia. And what is the correlation of grading with decision of surgery?
I think they're talking about the hills grading.
Yes, yes, yes.
So hill grading really doesn't have any significance to me. You may have a large hiatus hernia with minimal reflux and vice versa. What I'm more interested is the Los Angeles grading A, B, and C, which tells you the type of esophagitis. The second thing that I look for classification is what is called the Prague classification of Barrett's esophagus. So LA grading and Prague is to me important. Hill grading I simply ignore. To me, big hiatus hernia may have small reflux and vice versa. Sometimes we have lax cardias which have severe reflux. So I go by the patient's symptoms. I would do a manometry in all patients. I would be very careful to look at atypical symptoms. Somebody with chest pain, dysphagia, these are to me no-nos for surgery. The third group is patients who have upper abdominal bloating prior to surgery are also a contraindication, because in those patients I will do a gastric emptying study for solids and liquids before I do surgery, because they will invariably get a gas bloat and worsen after surgery. So I think in anti-reflux surgery, not only to learn the technical parts of surgery, but is to choose the right operation for the right patient. And I would never do a Nissens in an elderly person, those who have ineffective body motility or those who have any atypical symptoms. In those, I would only do a two-pace. I would do a DOR only in patients who have atypical symptoms, who are deemed a strong positive and who have good symptom correlation with reflux studies. I think I lay a lot of importance to my pH and manometry, and my decision to do what type of surgery is based on that. Those to me, I think over 20 years of doing this operation, I have had some problems. I've had morbidities. I've had patients who have come back with gas bloat, with dysphagia. And the operation I do today is very different from what I did 20 years ago. And I think patients are quite unforgiving of complications after a achalasia or a fundus. They'll forgive you if you have a CS stomach and get bile gastritis, because they only want to prevent recurrence. Here, in a functional surgery like a ventral mesh rectopexy or achalasia or a fundo or a bariatric surgery, the tolerance for morbidity is very low. Patients will complain. And I work purely in a private hospital. It's extremely important that we get consistent patient satisfaction. But I think this is an operation that in my hands has evolved with time, looking at my own morbidity and my own complications. Do any of the other moderators have a point?
Dr. Roy, sir, this is Keyur from Surat.
Keyur bhai.
Sir, I got another question. Like, do you really consider the length of Barrett's only as an indication in an asymptomatic patient for doing any fundoplication?
So I never do Barrett's. To me is not an indication of surgery, because in a Barrett's, even if you do a fundoplication, likely that the Barrett's will regress. But there is enough data to say that they will continue to require endoscopic surveillance, and doing a fundoplication or a radiofrequency ablation or a submucous dissection does not decrease the chance of malignancy. So I will go with the symptoms. If the patient has no Barrett's or Barrett's but has volume reflux, is PPI responsive and has no atypical symptoms, then I'm happy to do surgery irrespective of what type of Barrett's. I will never do a surgery only because somebody has Barrett's.
And do your say on any like grade 1 or LA class A esophagitis, and a lot of our endoscopic colleagues are recently doing RFE. So your take on that?
No, I missed that question. Can you repeat that, please?
Your take on LA class A, who are probably not very greatly symptomatic patients who are having a mild or intermittent reflux symptoms. And the recent techniques, I mean, you must have come across that they do a retroflex the scope and they do a charring of the mucosa surrounding the G junction. They do it generally in 2 sessions, one session half a circle, then the other session half a circle, creating an artificial fibrosis in order to prevent the reflux. So you have any experience on that?
So we have done 2 such patients. What you're describing is what is called the ARMS operation, ARMS, which was first popularized by a guy called Inouye, who was the same man who invented the POEM operation in Japan. Right. Now, to me, this is not a logical thing, because by causing charring, you're causing just fibrosis. You're not causing a wall effect like you do in a fundoplication. So maybe just in lax cardia with a First is LA grade A esophagitis. Why would you need to operate on these patients? Most of them will get well with PPIs and lifestyle changes. To me, the key issue in fundoplication is let the patient earn the operation. I've always realized that when you do this operation for mild reflux, patient have the most morbidity and they're never happiest with you. You do it in patients who have severe reflux, who really need surgery, they're invariably happy with you and there is minimal complications. So I would never think the arms is a good operation. The second option is what is called a STRATA procedure, which is radio frequency ablation, which is, we also did a trial on this we did about 40 patients in 2017, where we used to put a heater probe into the lower esophagus and deliver radio frequency energy. This is part of a multi-center trial. But this is again good for patients who have mild reflux with LA grade A esophagitis. I think the patients that we operate, and we do almost one hiatus hernia every week, very rarely anybody has anything other than LA grade C esophagitis, or they have large hiatus hernias, or they have GI bleeds, or they have strictures or complications of GERD. The third option is what my friend Amol Bape does in Pune, is called endoscopic fundoplication, or the TIF procedure, the trans-oral incisional-less fundoplication, where it's a full thickness fundoplication using an eagle claw. I went to Pune to see him doing this, but again, it is very unconvincing because they do a J position, they suck that, they put a hook into the full thickness stomach and deliver what is called anchors into the stomach. Also good for patients who have lax cardia, but doesn't work very well for patients with large hiatus hernias, which really are the bulk of patients that we treat. So it is apples and oranges. Somebody with mild reflux, lax LES, small hiatus hernias can be considered for this, but not the kind of patients that you and I see in practice.
So, Roy, coming to patients with Barrett's and evidence of an hiatus hernia, what level of Barrett's would you advise a patient to go some sort of mucosal ablation procedure? And if you do so, then what is the protocol? Barrett's ablation first, then fundo, and what's the gap between the two procedures?
So, Kalpesh, we do a fair amount of submucous dissection and EMRs in our hospital. So somebody with a high grade, the first thing is you must do what is called jumbo biopsies. At least 10 biopsies and have a good pathologist who will read your Barrett's to look for dysplasia. If they have high grade dysplasia or moderate dysplasia, number one, or number two, if they have a family history of esophagus adenocarcinomas, then I would consider doing a endoscopic submucous resection. We used to initially do a radio frequency, but now we have shifted. But again, the data is clear that even if you do a ESD on these patients, they still should remain under endoscopic surveillance and still have a chance of developing malignancy. And I never advise a fundoplication after ESD. If they remain ESD, then they only remain under endoscopic surveillance with high dose PPI or double dose PPI. I never do a fundo after this. So you do one or the other.
Even if the patient has a hiatus hernia associated, even if the patient has a hiatus hernia associated, you won't later on, maybe after a year or so, after
So if
surveillance?
they have hiatus hernia and symptoms, I would do it. I would not do it only because they have a Barrett's.
No, symptoms of GERD with Barrett's and hiatus I'm talking about.
So if I'm convinced that symptoms are there, I would do it after 3 months of the, and I've done 2 such patients. I don't find any difficulty in doing it because there is no mediastinitis or periesophageal fibrosis.
Yeah.
Just have another 5 minutes while the fundo is being induced. So I think we're still finished by 2 o'clock and let you go for your lunch at 2 o'clock. Kalpesh bhai.
Yeah, that's right.
Sir, for the sake of audience, that what do you take on a patient who is having a large rolling hiatus hernia, who is not having any reflux symptoms, the esophagus or G junction, practically there is no esophagitis. So how will you treat this kind of a patient, especially the elderly patients who are 70 plus? They may be having some comorbidities in the form of structure with the spine, which is leading to widening of hiatus and leading to a large part of stomach migrating into the stomach, into chest, paraesophageal hernias. So what is your strategy for treating them?
So that's a completely different proposition. So I think in your mind, you need to separate, as you said, sliding hernia from rolling hernia. And
Right,
I have
sir.
a very low threshold for advising surgery in somebody with a rolling hernia. I am very conservative in sliding hernias, but have a very low threshold in rolling hernias because of the risk of gastric volvulus and ischemia. If the patient is fit for anesthesia, I will push them to have a a surgery done for a rolling hernia. If the patient comes to me with a rolling hernia with complications and is very unfit, say they already come with a volvulus, and the patient, as you said, has a spine problem. As you quite rightly said, a lot of them have kyphoscoliosis accompanying this.
Right.
And I believe there is some collagen vascular disorder which predisposes to this. With very high risk patients, what I do is I do an endoscopic derotation for them and wait for 48 hours. I repeat a CT after 48 hours, then do a lap. If they are fit, I will do a formal repair with a partial fundoplication. If they are unfit, I only do a 5-point sutured gastropexy. So if somebody is very high risk under sedation with ketamine or a laryngeal mask, I will only the reduced stomach. I will take 5 sutures between the greater curve and the anterior abdominal wall just to prevent a volvulus. If they are grade 1 or grade 2 ASA, then formal fundoplication with a partial, always partial fundoplication in these patients because they are almost always elderly patients.
Right, sir. So that's what I just wanted to, back myself that at our center also we are doing more or less the same thing, that we avoid doing any sort of fundoplication, especially if patient is not having any reflux symptoms. And what we generally try and do is that we do a crural repair followed by we try and fix the greater curvature or a fundus of a stomach to the either diaphragm or the parietal wall so that it doesn't go back again in the chest. They practically don't require any anti-reflux procedure because they are not suffering from that particular problem.
Do you add a venting gastrostomy in such patients? Right?
So if there is ischemia, Kalpesh, then what I do is I give ICG on table to see if the stomach is viable. If the stomach is borderline viable, then I do a venting gastrostomy, not otherwise. If the ICG is showing a good pickup, then I usually don't do a gastrostomy. I just do a 5-point sutured and I put a nasojejunal tube in these patients. 1 lumen in the stomach, 1 goes in jejunal, so I can feed them within 6 hours of surgery. I have a very low threshold to use nasojejunal tubes even after gastrectomies or other such procedures.
Yeah, that's, I think in our patients, that's required because the cost of TPN, if you have to add, it becomes prohibitive.
Absolutely. And on table, you can just negotiate the NJ tube into the second, third part of duodenum. 1 part remains in the stomach. And I also, even if I have a little bit of doubt, I will give ICG on table. That's, I think the youngsters must know about near infrared imaging and the use of ICG to look at bowel vascularities. To me, in our center, ICG is not so much required for gallbladder as it is for anastomosis and to check vascularity. Even for mesenteric vascular ischemia, we have a very low threshold to use ICG. I think it's an excellent tool that and it's available in all cameras, Storz, Olympus, Stryker, all of them have ICG. Even some of the robots have ICG. So I think it's something that we all need to be aware of and need to be using regularly. Any questions from the audience about ICG, hernia, GRD, hiatus hernias? Otherwise, I'm just going to get washed up and we'll start the fundoplication.
Yeah, you go ahead. If anything is there, we'll pass it on to you.
Yeah, just to make a request, all of you to register for ASICON and AMASICON. They're in 2 consecutive months in November in Guwahati and Mumbai at December end. It is the ASICON. So please come for both of these meetings. I think Kalpesh has designed a very robust scientific program at the AMASICON, which is being conducted in Guwahati. And Niranjan, of course, is going to have a large workshop and a very robust scientific program in Mumbai for the ASICON. So please come for both of these meetings. I promise you that you will not be disappointed. I'm just going to go get washed up, Kalpesh, and then we'll show you the fundo.
Sure, sure. So can anybody brief us about this patient's history or something? Pre-operative investigations and everything.
Kalpesh, can you hear me now?
Yeah, absolutely. We can hear you.
So this is a young male patient who has a sliding hiatus hernia. For the last 6 years, he's been on PPIs. The history is that he lies down, he can't lie down at night. So he's lies down propped up at night. He has a volume reflux. He's PPI responsive and has no atypical symptoms. His scopy is showing on machine. If I can just show this is the manometry. I think all of you need to understand this. So the things to watch for are these. This is the focus karo. So these are the pressure waves that you see on the manometry. You can see that he has 100% successful wet swallows. The LES pressures are 6. So it's a hypotensive LES. This is important. He has a hiatus hernia on the manometry. And if you see this, EG is relaxing in response to wet swallows and 100% normal contraction. So the body motility is normal, contraction pattern is normal. So this tells you that there is no motility disorder of the esophagus, and the intrabolus, there is no pressurization. If you see pressurization, it tells you that he may have a achalasia. And this is a hypotensive LES with a hiatus hernia. So this, you need to understand these various pressure waves that go down. The different colors show you different pressures that are there in the esophagus. We have a fairly large manometry department in our hospital, and I would suggest that you must do a manometry in all fundoplications. The scopy showed a hiatus hernia. I think the plan is to do a Nissen's fundoplication. I think in our hospital, about 80% of patients get a 2 PS. About 17–18% get Nissen and 2% get DORS. So DORS we reserve only for atypical symptoms, but where there is strong symptom correlation with your PH studies. So the patient is, as you can see, is in a split leg position, and the TV is above the left shoulder of the patient. I'll be entering between the umbilicus and the xiphisternum and using a 1030 scope. Kalpesh, we have only about 15 minutes, so we'll try and show you as much as we can, and then you can switch off whenever you wish.
Sure.
पंद्रह मिनट आपके पास 15 मिनट है अपने पास
राइट साइड ओके फ्लैट स्प्लिट નથી કરતા લિથોટોમી હા ના એવી રીતે ના એવી રીતે ના હા લેગ સ્પ્લિટ નથી કરતા લિથોટોમી જ આપી હતો આ સેમ પેલો સળિયા ફેરવી કાઢ્યા હા બધાથી હું કલ્ચરલ બધા એવી રીતે જ કરે સળિયા ન સ્પ્લિટ વાળું તો નથી કરતા સ્પ્લિટ ખાલી પેલું સ્લીવ ને એવું કરતા હોય ને એમાં રાખે પેલા પગ એમાં કેટલા પગ તમારે હોય ને પેલા લેટા ચટકતા નથી એટલે સ્પ્લિટ એમાં કરીએ છીએ સ્લીવ ને એવું કરતા હોય ત્યારે ના આમાં તો ફાવે જ નહીં આમાં શું થાય છે પગ તમારા આમ રહે ને તો થાય તો નડે એટલે આપણે લોડ થોડું તો પગ થાય નીચે કરતો એટલે થોડું નીચે એક્ઝેક્ટલી આ હિપ કરતા થોડી થાય નીચે આમ સ્લેન્ટિંગ બહુ ઈઝી થઈ જાય રાઈટ હેન્ડ મૂવમેન્ટ છે ને ઈઝી થઈ જાય આ તો ભાઈ થાય એબડોમેન ઊંચું હોય તો ચાલી જાય બરોડા માર્કેટ એટલું છે વોલ્યુમ અનલેસ તમે ડિટેક્ટ કરો તો રોબોટ ટ્રેનિંગ ને બધું થઈ ગયું મારા ટેસ્ટ ને બધું થઈ ગયું એક તો કોઈ ક્રોસ ફ્રેક્ચર આવી જાય એડવાન્ટેજ સાથે બધું લેપ્રોસ્કોપી કરીએ છીએ આપણે તો શું છે કે હા ઇટ્સ અ માર્કેટિંગ ડિમાન્ડ આવવા લાગે તો મલ્ટી સ્પેશિયાલિટી હોય ને મલ્ટી સ્પેશિયાલિટી હોય ને તો ગાયનેક વાળાએ વાપરવાના હોય યુરો વાળાએ વાપરવાના હોય રેડિકલ પોસ્ટરેટિવ થતી હોય બર્બેન્સ થતી હોય સારા હોય તો પણ રિસેપ્શન બધું થાય ગાયનેક વાળાને લેન્ડ એટલા બધું ના હોય જીરોને ગાયનેક પણ શું લેબોરેટરી ફોર્મ એ લોકોના માટે રોબોટ બહુ ઈઝી કરે છે અધરવાઇઝ લેબ્રોસ્કોપી કદાચ ના કરે પણ રોબોટિક રેડિકલ પ્રોસેસ પણ કરી શકે લેબ્રોસ્કોપી બર્બેન્સ ના કરે પણ રોબોટિક બર્બેન્સ કરવા ને શીખલાઈ લીધું બસ સેમ પછી શું માલ પ્રેક્ટિસ કરવા કરે કરે પણ બિલ બનાવે રોબોટિક રોબોટિક
Light on. White balance के लिए मस्त थे.
विवेक हमें हाँ बिंदले वास्ते ये लोग ऐसा बिंदमा पास रोबोटिक ने एक अलग क्या है
उसने चेक करा चालते का 30 परत मगाशी त्याची कॉर्डलेस हामान पी घेऊन ठेव
Hello sir, can you hear us? Sir.
Energy. Shoot on.
So your port is, camera port is umbilical always?
Always 2/3, 1/3 between umbilical and Zyphus Kalpesh.
Yeah.
So
yeah,
whether I
exactly.
do achalasia, always 2/3, 1/3.
Right.
In a robotic patient, I go a little lower down because the robot needs a little more room.
Yes.
But in conventional lab, no. I think we now have to reinvent how we do lab because of robotics. Because we need to give a little bit of thought about how the range of the robot is.
Right.
But otherwise, as you said, conventional is 2/3, 1/3 between Zyphus and umbilical. Head up, please. The second working port is left mid clavicle line. In a minute, I will put the liver retractor.
So how do you decide the level of your right hand working port?
Of what?
The right hand working port. How do you decide where you will put it? Exactly what level?
Mid clavicle line, always.
Mid clavicular, but lengthwise craniocaudally?
Always left mid clavicle line. I never change that.
No. How high or how low? How do you decide that?
No, come again.
How high? I mean, exactly where on the craniocaudal line? How cranial or how caudal? Like how will it go?
That's how it is. That's my costal margin.
Right.
And just below that, this is where I'm just marking where my Nathan-Seen retractor will go in. So I put a syringe and a needle like that, like you see me doing here, and I see the logo, the liver where it goes in. You can, so the needle to me is like a GPS. I want to position it roughly at where the inferior border of the liver is like.
Right, exactly.
The needle actually is like a GPS for the surgeon where to insert the Nathan-Seen. And I am again very fond of the Nathan-Seen retractor. I just feel that, what happens is I have new fellows assisting me every time. And if you drop the left lower liver, then it can be a nuisance. Take this one to wash up. So you can see a fairly large hiatus hernia there. I'll just improve the picture in a moment. Knife के परंतु काही करत नाही का तू नुसतं उभी आहेस तिकडे तू काय अशा केस वृक्षाला वाशा देऊ नको माहिती काही तुझं प्रोएक्टिव्ह नाहीये तुझं लेफ्ट निघायची इसको चालतंय का बरोबर म्हणतात चेक केलंय का चेक केलंयस तेज चालेल चालू करूया आपण राहू दे इथून ग्रासपर घे पार्वती आता खाली काय लागतो आपल्याला अरे यार ये डिसअपॉइंट इधर ही इसको पकड़ चल मेरे को करना पड़ेगा ठीक है नंतर The key issue here is to look at the pars flaccida and I start working at the, do you have an audio video signal, Kalpesh?
Yeah.
So I always start at the pars flaccida and follow the caudate lobe till I find the right crus of the diaphragm. So usually you're working in the gastrohepatic omentum in a relatively avascular area. Focus. Here I can see the right crus coming, so it tells me I am in the right plane. This is the right crus, and that's the esophagus there. Sometimes you'll find abnormal left hepatic that comes off the celiac. And there is nothing of interest. I can just go on cutting till I come to the crotch of the diaphragm. So these are all the phenioesophageal ligament that I'm coming to. The right crus is my background. And once I see this, I just open the femur ligament like this till I find the left crus. I'm using the Sonocision, it's giving beautiful cutting. And for those of you who have not seen this, this actually doesn't require a machine. I just have a hand generator and a completely cordless machine that I'm using. Telescope निकाल के दिखा उसको. Telescope निकाल के दिखा. So this is what I'm using. There is no cord here at all. But it's just a hand controlled machine.
Yeah, that's the Covidian ultrastation. That's a good one.
It cuts beautifully. I've been quite impressed using this. At the minute I said that, I got bleeding. That's okay. That's me, not the machine. So the next step here is to, once you completely take away the right crus, rule na detala. I hold it like this, is to now make a cut just lateral to the right crus. So this is the caudate lobe. This is the right crus, and you must be in a plane flush to the right crus to bear the right crus. And if you're in this plane, it will always be avascular, Gospis theater. I am dividing the femur ligament here. I go on advancing my instrument till I come to the right plane and I keep pushing. You see, this is how the esophagus is opened up. This is the area behind the esophagus. This is the femur ligament anterior to it, and that's the esophagus that I've bared. So I'm going to divide this. It cannot be the anterior vagus because the anterior vagus, as I showed you in the achalasia, is closely applied to the esophagus. Now I am coming to the left crus. Now I need to create a plane between the left crus and the esophagus. Both achalasia and, so this is the plane between the esophagus and the left crus. The left hand, that's the lung. Can you appreciate the lung, Kalvesh bhai?
You're getting a beautiful picture. Beautiful picture.
Yeah. Great. So that's the lung. I'm just pushing up the lung and the pleura. This is where you tend to injure the pleura here. So you remain close to the esophagus and keep pushing the pleura away. And this is the mobilization of the, this is the vagus that I am holding in my left hand. Short of that, everything else I'll divide. Next is to create an area for the retroaxial window. So you just go on dividing the femur ligament here, and you see me do push, pull. Now I need to see the left crus from this side. For that, I need to go a bit further in the right crus, and in 2 minutes, I'll have my retroaxial window done. So this is a very easy and anatomical operation. You see, this is the left crus. Left crus on this side. So I just need to dissect in this plane, and my retroaxial window will be made. Don't go blind, don't push anything blind, because that's when you tend to make injuries.
So do you actively look for the vagus nerves?
I always look for the posterior vagus in a fundoplication and an anterior vagus in a achalasia.
Right.
The important thing is to remain just below the left crus and flush to the left crus. If you're on that plane, then you're not going to injure anything. That's my window made. I like to, you can use umbilical tape, or what I tend to use is a Foley's catheter. I've always used this from the beginning of my practice, Theranical instrument. Put on a tooth grasper. So the whole operation we'll finish in 20 minutes. So that's the Foley's catheter held. Now, I'm assisted by Dr. Ajit and Dr. Urvin. Ajit is a consultant with me, and Urvin is a fellow in our department. I have Dr. Anshul doing anesthesia. The next step of this operation is now to lengthen the esophagus. This is something I think people don't do very much. And that I think is one of the reasons of failure of fundoplication. You must be in this loose areolar plane, and if you're in the right plane, it can just open up for you like this. Somewhere behind you is going to be the aorta, nothing else of importance is here. I go on dissecting in the mediastinum like this. And then you see, this is the right pleura. I showed you the left pleura earlier. This is the right pleura. So the left hand goes in, pushes away pleura, and mobilizes the esophagus further up. The key issue is to get 5 centimeter length intra-abdominal esophagus with traction and 2.5 centimeter without traction. And I've almost already achieved that. You do circumferential dissection like you see. Ajit is showing me beautifully with the camera. I lift the left hand anterior to this is the pericardium. My left hand is protecting the pericardium and the right hand is doing the dissection.
So if during this, during this posterior mediastinal dissection, if the pleura either left or right opens up a bit, what should anything be done, what and why?
Nothing to be done. My anesthetist has to be just careful. Nothing. Usually at the end of surgery, if they give PEEP, it will fully expand. So in many cases of recurrent fundus, we have now done more than 50 redo fundoplications. And in these patients, we find the pleura is quite densely adherent to the esophagus. And we have opened pleura many times. Nothing happens to them. In my career, I have only put one ICD in a patient who had a thoracolaparoscopic redo, but otherwise never put a ICD even if you open pleura. Just be aware of it. Give good PEEP to these patients, and the lung will always expand on table.
So just for the audience and residents who are there, when initially we started doing lap fundoplication, opening up of the pleura was a very big thing. And then we used to put an ICD and watch the patient in ICU. Later on, everybody realized that, when the patient is in IPPR, it doesn't matter much. One thing that if it's a very small opening and you are afraid of a sort of ball cock effect, you just make it a little large opening.
Absolutely.
In the pleura.
Point well made. You basically have to prevent a tension pneumothorax.
Yeah, so you want to avoid a tension pneumothorax.
So as Kalpesh said, if you have a small opening, convert it into a big opening. Don't worry about that. So that's my left crust, my right crust, the pleural different. This is the aorta below this. Can you see that?
Yeah, beautifully.
That is and that is my IVC below this. So that's my dissection is almost complete. In a minute, I will start mobilizing the greater curve of the stomach. And I'm going to do a conventional listen on this man because he's a young, fit guy. Again, showing you the right pleura. Can you appreciate the right pleura, Kalpesh? The white border and the right pleura. So I'm pushing that away from the esophagus to get a little additional length, but I already got about 5 centimeters, so I don't need to go any further. छोड़ दे पूर्वेन. छोड़ निकल बाहर. छोड़ के बाहर निकाल और atraumatic grasp. Now I'm going to get Urvin to put a atraumatic grasper. Again, I have over time realized that you need to mobilize the greater curve well. I know there are people who don't believe in this, but over time I've realized that unless you mobilize the greater curve well by dividing short gases, you don't get good length. And for this, a good energy source like the Sonocision that I'm using is crucial. Because the earlier days we used to use bipolar, which was a real pain. So these are the short gastrics that are coming in picture. So like anything else, you will do a double coagulation of this. Just because you have a good instrument doesn't mean you can afford to be aggressive. You do a double coagulation and then do a sandwich technique in between. So last part of short gastric is left. Once we do this, we are ready to do crural suturing and the fundoplication. So go slow here because tend to have small, wide vessels which tend to bleed. So don't be in a hurry to do this. Whatever energy source you have, whether you have a ligation or a harmonic, do this very, very slowly. Don't be in a hurry to do this. That's when you will get in trouble. See, the stomach is in this particular patient is very closely applied to the spleen. Come back.
So, Roy, we have got an indication from the organizers that we may have to stop the transmission as we have to start our academic program over here. So till then, if they do it, we'll continue watching you on screen. But then once the academic program starts, we'll just switch off. So that's a wonderful surgery. I mean, you have just completed almost 75% of the surgery by now.
Roy sir, you can hear a big applause. Nishit here, sir.
Thank you, Nishit, and thank you for allowing
us
to
transmit. Yes, sir. There has been an excellent transmission today. Even audio, video, Dinesh is doing an excellent job. Here, Dhyanesh is also doing an excellent job. And you always rocks.
Dr. Roy, Pankaj here. It was a great to watch you. Sorry, we are very sorry to leave you. We want to see more and more. But because we have a tight schedule, our meetings and everything, so we may leave you. Thank you very much again. Thank you very much, Roy.
Okay. Thank you very much.
Thank you, sir. Only audio part will be shut down. Sir, video is going on, sir.
All right, Nishit. Thank you.
Thank you, sir. Thank you very much.
Thank you.
I would like to thank our chairpersons for conducting